and his topic is mitral valve repair in rheumatic heart disease. And just a quick introduction, Professor Devagourou has done his MBBS and MS from JIPMER Pondicherry and MCS from All India Institute of Medical Sciences. And presently he holds the position of professor. He has done his lot of fellowships in mitral valve repair from Vietnam, and being an invited international faculty into Vietnam for the same. He is also a member of the National Rheumatic Heart Disease Consortium, so he definitely would enlighten us more on this topic. And he is active interest in aortic surgery, pediatric cardiac surgery, and especially the topic which he is discussing today with us. Welcome, Professor Devagourou sir. You are always very helpful and very, very cooperative with us. Thank you so much for joining this webinar. Over to you.
Thank you, Dr. Rizvi, for this good introduction. Good afternoon, respected colleagues. I'll be talking on mitral valve repair in rheumatic heart disease. Why especially in rheumatic heart disease? There are some variations between mitral valve repair and other conditions in rheumatic. The problem in rheumatic heart disease is there is a positive tissue.
Sorry, your slides are not in full screen.
Okay.
Thank you. Yeah. Thank you, sir.
Yeah. The problem is rheumatic heart disease is there is paucity of tissue because of scarring. And the second is there is progression of disease, which may lead to a failure in later stage. RSD can present as pure mitral stenosis or a regurgitant lesion. And sometimes they can present as a mixed lesion with one dominating over the other. The surgical options for when indicated are: one is a closed mitral valvotomy, second is open mitral commissurotomy, and third is a mitral valve repair. CME, as Dr. Bahl sir has said, it's almost we are not doing any further because PTMC has taken over. Some historical facts, like Dr. Bahl has already put it, Bailey and Harkin were the first to perform the closed mitral valvotomy. The indications are a symptomatic isolated pure mitral stenosis, which is non-calcific and patient in normal sinus rhythm. This is the indication for a CMV when PTMC is not available or possible. The contraindication is atrial fibrillation with a LA clot. But if atrial fibrillation is there without LA clot, we can anticoagulate the patient for 6 weeks and take them for surgery after 6 weeks. The important steps are left anterolateral thoracotomy. Pericardium is opened anterior to the phrenic nerve. A purse string is placed just lateral to the and superior to LV apex, just lateral to the LAD territory into a rhumal tourniquet. A purse string is placed in the tip of the left atrial appendage. Incision is accommodated just to index finger. Valve is evaluated with the right index finger, and a TUPS dilator is passed to the LV apex with a screw set at 2.5 cm initially with left hand. Dilator blades are open against leaflets and not against the commissures. This is a pictorial diagram which explains the steps I had told you. The index finger is in the left atrial appendage. We can feel the valve and guide the TUPS dilator into it. And the dilator is open to ensure a good valvotomy. When some contraindication AF can be managed if we can start on anticoagulation for 6 weeks and stop it 2-3 days prior to the surgery. Sometimes the LA appendage may be small because of or contracted and boggy with a small thrombus. Then the approach will be through the LA wall at the junction of the superior pulmonary vein and the LA junction. This is the approach also taken in mitral stenosis. When post CMV we are doing a redo. This was quoted by Dr. Bahl. It's a historic publication from Dr. Stanley John, which appeared in Circulation 1983. They had 3,724 patients, ranging from 6 years to 69 years, with wonderful results. And late results also were very good, with a good follow-up, and the survival was 84% at the end of 25 years. Restenosis can also be managed with the redo surgery. This is a publication from the same hospital. where they did a restenosis. If closed mitral valvotomy or PTMC are not possible for some reason like AF with LA clot, or if you're handling with aortic valve where there is a lesion, or in addition to ASD which is not divisible, or the presence of a calcification, then we can go for open mitral commissurotomy. These are the indications for open mitral commissurotomy. The open mitral commissurotomy is a very safe procedure. Just steps include valve assessment, commissurotomy, papillary muscle splitting, leaflet thinning, which is unique to our institute where Professor Sampath started using this leaflet cuspal thinning. If the cordia adhere to each other, then we can do fenestration. Finally, we assess the valve for any regurg. If it requires, we can do a commissuroplasty if there is a leak in the commissures, or we should add an annuloplasty if there is a dilatation of the annulus. These are the steps of the open commissurotomy. First, identify the commissure by using 2-angle forceps. Then make an incision 5 mm away from the annulus to start with, and extended 5 mm short of the orifice. Then identify the chordae and the commissural chordae and divide them equally into each half and open the commissure. After the commissure is open, then we do a papillary muscle splitting as much as possible down. And if the chordae are stuck to each other, we can do a fenestration of the chordae. This is a publication from our institute, which appeared in the Annals of Thoracic Surgery in 2003 January issue. This included 276 patients over a period of 10 years with open commissurotomy. The 4 early deaths were said, and the reoperation rates were minimal. That was 3 out of 276 patients. With excellent long-term outcome. There was 87% freedom from mitral valve failure at 10 years. The advantage over closed mitral valvotomy are, we can take this when there is a minimal calcification or the commissure or the tips. It can be done under direct vision, and if there is subvalvular deformity also, this can be done addressed. Of course, there are advantages of over a valve replacement. OMC contraindications are, as already told, if the commissures are heavily calcified or the subvalvular apparatus is grossly fused, then we may not be able to preserve the valve. Even this type of valve can be preserved if the patient is a female or childbearing age group. If we can repair this valve, we can give easily 10 years of life till a further operation is done. This Dr. Bahl has already put a comparison of PTMC over OMC and CME. This is for the sake of the residents. These are all available. There's a randomized trials. All the randomized are put together, which shows equal efficacy of PTMC, OMC, and CMV. Coming to the topic proper, where we are thinking of repair of the mitral valve. The gross principles of repair are, we have to restore the normal leaflet motion. As we know, Carpentier is classified into 3 types of dysfunction. Type 1, when there is normal leaflet motion. Example, or a perforation or annular dilatation. Type 2 is when there is an excessive leaflet motion. Example, a caudal elongation or rupture, or papillary muscle elongation or rupture. Type 3 is when we have a restriction of the leaflet motion, as happens in mitral stenosis of rheumatic heart disease, that is type 3A. And type 3B is ischemic, when there is a retraction of the posterior leaflet. As far as rheumatic heart disease is concerned, the most common is the prolapse of the anterior leaflet, that is 2A, and restriction of the posterior leaflet, that is 3P. So we have prolapse of the anterior leaflet and restriction of the posterior leaflet. What are the options for repairing these? If there is a dilatation, we have to address the dilatation by doing a annuloplasty. These are the various annuloplasties which have over years. But as you can see, till Carpentier introduced this annuloplasty ring, most of them were narrowing annuloplasties. In 1968, Carpentier introduced the ring, Carpentier ring. There are three things which you can do for the prolapse. One is if with a small prolapse, we can resect a small area, but this is most often done only in myxomatous lesion. So the second option is to transfer a secondary chordae from the secondary position to the primary position. This is most often done, and this is even now practiced by the Carpentier group in Vietnam. So they transfer a good secondary chordae and move it to the primary position. Even when you want to put an artificial chordae, they can do this so that this gives an idea of the length of artificial chordae you want to do. The second option is to use artificial chordae. Artificial chordae, most of us are familiar because we do rheumatic, myxomatous, and we also do in other conditions of a ruptured chordae in endocarditis. So artificial chordae, the only problem with artificial chordae is adjusting the length. There are almost 20-25 techniques of adjusting the chordae. The simplest is to transfer the secondary chordae, at least in rheumatic patients, and adjust it according to that eye. Or you use a marker or a Liga clip. Once you adjust at a particular level, fit a small Liga clip gently so that it can be removed later. On top of it, you place a few sutures. And this is the best way to adjust the artificial chordae. The third possibility is chordal shortening. The technique which is shown in the cartoon is quite difficult, which is proposed by Carpentier. Instead, at the institute, Professor Sampath Kumar had introduced the chordal shortening at the cuspal level. So the most common things we use are cuspal thinning, where we'll remove the thickened portion and the fibrous layer on top of the AML and the PML. We use chordal shortening when required, and most often we use chordal transfer or artificial chordae. These are the things. In addition, one important thing which can be used is, most often, as I told you, there is this positive tissue in rheumatic heart disease. The posterior leaflet is quite small and retracted. If it is less than 1 centimeter, usually it is 2 centimeters length. If it is less than 1 centimeter, it will be ideal to augment the posterior leaflet with a pericardium. This increases the chance of repair higher. If you can extend the posterior leaflet, it increases the chances of repair higher. I'll show one video of the posterior augmentation. As far as the use of ring, there are different rings that are available. Classic ring is no longer available. Classic ring is a ring, semi-rigid ring, which we used to use for rheumatic heart disease. Presently, the Physio Ring 1, 2 are available, especially Physio 2 is available, which can be used for, it's a semi-rigid ring, which can be used in rheumatic process. The indication for using a ring is when there is an annular dilatation, when there is a loss of shape. Especially MR, we have to use. In MS, if there is dilatation of the annulus, then we use a ring. This is a short video which will explain some techniques of OMC and the augmentation of the posterior leaflet. This is a video showing a case of a pseudoprolapse. This is a case of a pseudoprolapse where apparently the leaflet looks prolapsing, especially if you see the jet, it is skirting on top of the posterior leaflet, though the leaflet is not crossing the mitral annulus. It is important to know a pseudoprolapse because if we assess when we realize there is no prolapse of the anterior leaflet, otherwise we'll end up putting artificial chordae to the anterior leaflet, and which may not suffice. So when we assess, we realize there is no prolapse of the anterior leaflet. The problem is the restriction of the posterior leaflet, complete restriction of the posterior leaflet. There is commissure fusion of the anterior and posterior commissure. As I said, it's a typical rheumatic valve. There is some scarring. If the leaflet, posterior leaflet is less than 1 centimeter, it's better to augment the posterior leaflet. This is a 12-year-old child who came presented with a mixed lesion. As I told, the principles of commissurotomy start 5 millimeter from the annulus and go 5 millimeter into the orifice. Once you identify the chordae, then you can split the chordae, commercial chordae, into two equal halves. Here in this case, not much of fusion was there. We could release half a centimeter on this side. Once this is done, we have to do the papillary muscle splitting. The papillary muscle split down, right in the middle. This will improve the secondary orifice. And if the chordae are together, then we may have to fenestrate. Then we look at the posterior commissure, is again open. Once that is done, papillary muscle splitting is done on the posteromedial papillary muscle. Since there's a mixed lesion, we plan for a ring. So you place the suture so that it makes it easier for the augmentation of the posterior leaflet, which we had planned already. These are simple sutures. As we move anteriorly, we take backhand sutures. On the sides, we take forehand sutures. Each sutures are taken around 8 mm apart, and between two sutures, you leave a gap of 1 or 2 millimeters. As we go posteriorly, we have to check exactly the junction and then place it, because the annulus is 1 or 2 millimeter behind the atriovalvular junction. So you place it 1 or 2 millimeter behind. Because of jet lesion, it's difficult to find out the junction. Once the sutures are placed, you take 2 stay sutures for the posterior leaflet, because we have decided to augment the posterior leaflet. Make incision at 6 o'clock and proceed towards the 2 commissures. The important thing is when you're augmenting, we have to augment in such a way the entire posterior leaflet is augmented. So the trick is to go up to the commissure on either side to get a good, because the commissure is where the area of coaptation is minimum. So we have to augment till the commissures. The area of coaptation at the commissure is only 4 millimeters. At the center, the coaptation is maximum, more than 7. So we have to make sure that you divide the tertiary chordae and some secondary chordae if they are coming in the way, and then augment with a rectangular piece of pericardium. If you use a crescentic shape, like this shape of this thing, then the diastolic gradients come up. So it doesn't easily open if you put a crescent shaped pericardial patch. So ideally, you should put a rectangular patch, measure the amount of length and the breadth you want. So you keep around 1.5 centimeter, or centimeter will be used for suturing. There's no question of SAM in case of rheumatic heart disease. We don't have to worry about the extension of the posterior leaflet, thinking SAM may happen. SAM cannot happen in a rheumatic patient. There's paucity of tissue, so there's no question of a SAM happening in a rheumatic repair. Once this is done, you test. This is the testing before the ring is even placed. Post repair, you have to check what is the problem. Once you have a saline test, at the commissure, there are some tricks which can be done. At the commissure, if it is there, you can move aside the commissure. As you can see in the first inside, you can transfer a secondary chordae to the commissure position, or much easier to close it off, because as I said, the commissure area, the coaptation is minimum, 3 to 4 millimeter only. The second possibility is there can be a leak at P1, P2 or P2 for a secondary tertiary chordae which is pulling it down. You can release the secondary or tertiary chordae on the P2, P3 area. That also may release it. Or you just look for a prolapse of the A2, corresponding A2 segment, then we'll have to move it, the secondary chordae, and fix it. These are the saline tests which are rotation as such. We have published a few papers on mitral valve repair. This is one in which we have presented the mitral valve repair in predominantly rheumatic population. These are good results. I should put the entire thing together. This was published in Texas Heart Journal in 2009 by Professor Sadiq. Then we had results of mitral valve repair rheumatic mitral in 2006. We had this some more cases till 2007 when Professor Sadiq retired. We had overall a total of 940 patients of mitral valve repair, aging from 2 years to 74. Predominantly, they were disease, and predominantly they were MR, and they were mixed MS or mixed lesions were also there. These were the techniques which were used. OMC was done predominantly. Cuspal thinning, as I told you, was proposed and presented by Professor Samir level, which is also again proposed by Professor Samir. Annuloplasty and chordal transfer. Later on, after 2006-7, we started using the artificial chordae. What about the results? Early mortality was 3.8%, and follow-up was 96% complete, and the follow-up range was 6.8%. And follow-up, nearly 70% of them had no MR or trivial MR. Moderate MR was present in 17 to 18%, and severe MR requiring redo was around 14.7%. Follow-up, we had this thromboembolism, hemolysis, bacterial endocarditis, and reoperation. The survival for hemirepass was nearly 95% at the end of 10 years. And freedom from reoperation was also about 80% at 10 years, which started decreasing beyond that. What about children? Can we reproduce the same results in children? Yes, this is our presentation in a group of children, and we were able to produce similar results. Actual survival was 95% at 15 years, and the reoperation-free survival was also nearly 85% at 15 years. Event-free survival was nearly 50% at the end of 15 years. Valve repair is, one, the difficulty because of positive tissue, more importantly, surgeon's attitude. It does require some skill in a rheumatic patient, and of course, we have to accept a need for reoperation. It is in children, there is no other alternative, good alternative in children, and a replacement should be the last option in children because this is quite disastrous. Thank you.
Thank you, Professor Devagourou. That's a very candid and very timely presentation. You're really finished in timeline, sir. Thank you so much with that nice video. So I would like you to stay on if possible throughout the webinars, and also be there because there are a lot of questions already prepared.
Sure.
Thank you so much, sir. So with this, I would like to start the next topic from Dr. Nishant Tyagi. So he will speak on the recent guidelines in the management of stuck metallic prosthesis. Dr. Nishant is an interventional cardiologist, EAMS Rohtak, MD from Medical College in Gwalior, and he is a DNP from the prestigious Fortis Escorts Institute in Cardiology. So with this, I would like to introduce, welcome Dr. Nishant for his presentation. Nishant, please. You have to unmute yourself. Nishant, you are mute.
Good afternoon, everyone, and thanks for having me on this wonderful afternoon. And is my slides visible?
Yes, yeah, they are visible.
Okay, so the topic given to me today is management of stuck metallic prosthesis, the current guidelines. So I will go through it.
Sir, your video is not visible, sir.
Okay, just a minute. Okay, so valvular heart disease affects about 100 million persons worldwide, and is associated with significant morbidity and standard of care for treatment for valvular heart disease in patient at low and intermediate risk for surgery. And there are two types of valves, mechanical and biological. The mechanical heart valves are more thrombogenic yet more durable, and the bioprosthetic valves are less thrombogenic and exhibit more natural hemodynamic properties but are less durable. So these are the kind of valves everyone knows. Ball and case one is St. Jude bileaflet valve, commonly used now. We'll go through the topic, that is risk of prosthetic valve thrombosis and thromboembolism events is higher with mechanical valve than bioprosthetic valve. It is more at position, mitral position than aortic position, and it is more on the right-sided valve as compared to left-sided. So mostly the right-sided valves are usually, biological valves are used most of the time. Annual rate of prosthetic valve thrombosis in mechanical studies with the higher rate observed with specific valve types in the early post-operative period, perioperative period, and with mechanical valve implanted in mitral with therapeutic anticoagulation. The other reason for stuck valve is fibrotic pannus ingrowth with mechanical heart valve manifesting as prosthetic valve dysfunction occurs with an annual incidence of 0.2 to 4.5%. This is the mechanism of prosthetic valve thrombosis. As you know, three factors. Surface factor everybody knows for any coagulation taking place. These are the three Vercoe strides, which we call low cardiac output, prosthesis malpositioning, anatomical position, then hemodynamic profile, hyperviscosity, hypercoagulability, significant tissue injury, thrombocytopenia, all this. Now, as you go, this is the potential mechanism of prosthetic valve thrombosis. By an tricuspid valve, there is no thrombosis. Same as with the pulmonary valve, but in mitral valve, relatively slow flow. And in case of atrial fibrillation, there is atrial dilatation also. And in low LV output, These are the local reasons for high thrombosis at mitral position as compared to aortic. So how to differentiate prosthetic valve thrombosis from PANUS? The pathogenesis is different in both the cases. Position, thrombin generation and clot formation. In PANUS, there is thrombin generation and fibrin deposit, fibroblast proliferation, collagen deposition, neoangiogenesis. Clinical features: thrombosis has a shorter history and sudden onset history of deterioration of the patient. Whereas in PANUS, there is long time from valve replacement to valve dysfunction, months or years, and there is progressive onset. You find it on echocardiography on a follow patient, and less commonly associated with suboptimal anticoagulation. Imaging, more you have to focus is in thrombosis, there is high total mass volume and area. There is high density, higher lesion density, and more commonly located side of the aortic processes. Whereas PANUS is more commonly located on the ventricular side of both mitral and aortic processes. So these are the modalities of diagnosing. Transthoracic echocardiogram is most commonly used and very helpful for initial diagnosis, but sometimes limited in early post-op period or in a post-op case with the poor imaging. Then TE is has a chest is thick on an obese patient, post-operative patient. So although TE is superior to transthoracic echo for identifying the mechanism of prosthetic valve degeneration, even TE cannot reliably discriminate between prosthetic valve thrombosis and fibritico-PANUS ingrowth. Then fluoroscopy is also used, and in mechanical heart valve, the valve mobility assessment for prosthesis opening angles. However, fluoroscopy is not applicable for bioprosthetic valve. Then multi-detector CT scan. This is the latest development in patients where TTE and transesophageal echo is inconclusive. Multi-detector CT could provide an accurate evaluation of prosthetic heart valve. Gated multi-detector CT scanning enables dynamic leaflet evaluation and anatomic assessment of the prosthetic valve in systole and diastole. So multi-detector CT scanning can differentiate between thrombus and PANUS on the basis of Hounsfield unit, and prosthetic valve thrombosis have lower attenuation than PANUS. Therefore, multi-detector CT could be used to categorize the etiology of multi-detector CT is the test of choice after initial transthoracic echocardiograph to differentiate thrombus and PANUS. And it will detect thrombus or vegetation or other masses. It provides more accurate assessment of geometry of the left ventricular outflow and effective orifice area of prosthesis. Of prosthetic valve is either surgery or fibrinolysis. Surgery has problems of it's always in a high-risk patient an emergency surgery and a redo surgery. And fibrinolysis, there's problem of bleeding, systemic embolization, and recurrent thrombosis that are higher than after surgery. So the factors enumerated that favor surgery or favor expertise, favor surgery, low surgical risk, contraindication to fibrinolysis. If there is recurrent valve thrombosis after a successful thrombolysis in the past, then NYHA class 4, a larger clot more than 0.8 centimeter square, associated left atrial thrombus or vascularization, other valve disease, a higher possibility of PANUS and patient choice. So these are the guidelines. They came in 2014 and were updated in 2017. And transthoracic echo is indicated in patient, and this is a class 1 indication. So initial diagnosis is by transthoracic echo, and transesophageal echo is also a class 1 interest, the thrombus size and valve motion. Fluoroscopy or CT scan is reliable in patient with suspected valve thrombosis to assess valve motion. This was class 2A. And then prosthetic valve thrombosis. Medical therapy is fibrinolytic therapy is reasonable for patient with thrombosed left-sided prosthetic valve of recent onset, less than 14 days, NYHA class 1 and 2, and it is reasonable for thrombosed right-sided ACC 2014. And intervention, emergency surgery was recommended as to treat left-sided prosthetic heart valve thrombus with patient with NYHA class 3 and 4, class 1 indication. And emergency surgery is reasonable for patient with thrombosed left-sided heart valve with a mobile large thrombus that is more than 0.8 centimeter square. Suspected valve thrombus, initially transthoracic echo. If not sure, go for CT scan and fluoroscopy, class 2A. It is right-sided valve, directly go for thrombolysis. And if it is left-sided, transesophageal echo for the exact thrombus size. If it is NYHA class 3 and 3, which has been updated, I will tell you the update. And if it is a large thrombus, then also emergency surgery. Now, this is modified in 2017. The ACC has modified. Urgent evaluation with multimodality imaging is indicated in patient with suspected thrombosis. So the role of CT scan is more now. After transthoracic echo, you can go directly for a CT scan to evaluate exactly what is the diagnosis. This is class 1 indication now. Medical therapy, fibrinolytic therapy is reasonable for right-sided valve. It is class 2 indication. Then modification, which was done in 2017, is urgent initial treatment with either slow infusions, low dose fibrinolytic therapy, or emergency surgery is recommended for patient with thrombosed left side mechanical valve become class 1 indication. Level of evidence is B, NR means non-randomized control. So the flow diagram is same, but the role of CT scan is rising and the role of thrombolysis. This is the update. Recommendation modification is multiple recommendations based only on NYHA class symptoms were combined into one recommendation. Slow infusion of fibrinogen rate, then prior high dose regime, and is effective in patient previously thought to require urgent surgical intervention. This is the modification. And the decision for emergency surgery versus thrombolytic therapy should be based on multiple factors, including availability of surgery for the treatments. This is 2017 AHA ACC focus update on valve thrombus.
Nishant, you have got only 1.5 minutes. Things.
What? 1.5?
1.5 minutes.
Okay, I'm about to finish. Yeah. This was the European Society of Cardiology recommendation, and it is a small slide, only 2 slides. This is for non-obstructive thrombus, and here it also says can go for surgery or thrombolysis. Otherwise, increase the anticoagulation and follow-up. And in obstructive prosthetic valve, that also critically ill patient go for surgery or thrombolysis. So this is the update from European Society of Cardiology, 2017. And I would now compile the overall 30-day mortality rate with of surgery is 10 to 15 class 1 and 2. And the result of thrombolytic therapy earlier with high dose thrombolysis was a higher complication rate. But now, with recently eco-guided slow infusion of thrombolytic therapy, success rate is more than 90% and embolic event rate is less than 2% and major bleeding less. While thrombosis is higher than actual incidence, approach could be individualized. The treatment for NYHA class thrombus burden. Newer regimes of very low dose slow infusion leads to equal efficacy with lower complication in majority of the patient according to recent guidance of NIHA if individual patient characteristics support recommendation of one treatment over the other. Thanks.
Thank you, Dr. Nishant. Thanks for your candid presentation. There are a lot of confusions there, so we will ask you a lot of questions at the end of the webinar. So I would like you to keep logged in for the entire duration and be there at 8 p.m. Thank you so much, Nishant. So with this, I would like to welcome our next speaker, Dr. Adil Sadiq. He is the Chief Cardiothoracic. So, are you there, Adil, with your presentation now?
Adil, are you there? I am. Yes.
Yeah. Okay.
Yes. Thank you so much, Vivek.
Yes. And, yes. So he has done his MBBS from the Bangalore Medical College. He has done his MS in General Surgery from KMC Manipal and MCH from Sree Chitra. And then he has got his advanced training in minimal access cardiac surgery, robotic surgery hospital and Harvard Medical School before he joined into Apollo Bangalore and moved to Sakra Hospital. And he has got practically interest in all the subjects. But I picked up this particular topic of MICS mitral repair, where you can show us some insights into this. Thank you, Adil, for joining. And
absolutely.
Please start.
Thank you so much, Vivek. Just 1 second, please, making sure we've got screen setting. Okay. Just making sure we're getting screen setting and everybody can see the screen, Rizvi?
Not yet.
Okay. Just 1 second. Okay, for some reason it is not letting me screen. There you go. 1 second. Great. Now we've seen. Excellent. Thank you so much. So first of all, thank you very much, Rizvi, for organizing this particular valve symposium, and thanks to Max and Abba talking about today. And the talk today is going to be about mitral valve repair and approaching that through a minimally invasive surgical approach. And I'm Adil Sadiq. The traditional approach we've seen, and more and more of our patients are knowing that there are lesser and lesser invasive approaches, and it's not uncommon for us to come to many. This is one slide that I always like to show at most of my talks, and it is the disadvantages slide of minimal access surgery. And the reason why I think it's very important for us to understand is that once we know what are the problems we're going to encounter, we are better equipped to handle them. And simply like just that learning curve, you got to learn to crawl before you can learn to walk, and learn to walk before you can fly. Well, the cost involved is around 20-30% higher and requires 20% more OR time. There are limitations with respect to anatomy and to physiology as well. Of course, the significant advantages that we have, cosmesis is the least important, and faster return to normal activity is the most important. There has been a significant, a rib spreading thoracotomy to more and more lesser invasive approaches, and the one that I will be talking about specifically today is an endoscopic approach, or the videoscopic approach for the mitral valve repair. We need to know our problems before we can create them, because then we know how to tackle them and how to deal with them. So the basic things that we need to know is we need to form a protocol for an institution, something from our team. It's very, very important that we need to get it the intra-abdominal course. This is something that we often miss, and this can land up in a lot of troubles. This is the basic setup before we get to the mitral valve. I'm sure most of the participants here have seen and have performed a safe mitral valve repair happen, and a short video at the end to talk about that particular valve repair. Anesthesia is very important, not just for the TEE, but also because single lung anesthesia with either a double lumen tube or endobronchial blocker, eye ratios are down. Always like to put PEEP on the lung that is collapsed to prevent postoperative atelectasis. So patient positioning, we've seen this particular diagram time and again, but the most mentors, John Pascas, would always tell me, if the anesthetist thinks that the patient is going to fall off the table, then the correct position of the patient is achieved, which means the patient needs to be almost, pulled up to the right side of the patient of the table, place a vertical roll behind the tip of the scapula, get that body, protect the vascular and the neurovascular bundle in the right arm. I think that's all right. I think we've got a little disturbance on that line. Never mind. So let's go on with the cannulation. The different kinds, you can have direct cannulation and also percutaneous and indirect and percutaneous. Always prefer a transverse incision. It's more cosmetically better. An important thing about there, apart from the Selinger technique, is just to limit your dissection to the anterior part. Here, many people make that you need to go at least 1 centimeter above that, mark your femoral artery, femoral vein. No, that's a particular area. It's easy going in out there to get a large size of the femoral artery and a good size of the femoral vein. Proximal distal control, put a direct cannulation, or the best thing, the safest, is to sew a tube wrapped in 8 mm Dacron so that there's no compromise of blood flow to the leg as well. If the femoral artery is extremely calcified, look no further, go on to the other side or even go for the right exit to understand that we need to downsize size of the cannula, ideally, no matter what a BSA is, no matter what gravity says, you need to downsize the aorta and make sure you see the guide wire in the descending aorta before you pass the wire up. So always size the artery. See, that's the anesthetist showing the descending thoracic aorta, and you need to see your guide wire in there. Coming to the peripheral venous cannulation, I've been a big proponent of a single femoral cannula. A 2-stage or multi-stage is placed in the femoral vein and reaches bone age. No need to worry. Other options are one cannula into the neck and one into the SVC and one down to the IVC. The femoral venous cannula to the IVC, and sometimes even the direct SVC cannulation. I tend to go for an additional cannula only if the BSA of the patient is close to 2 and above, or there's a very, very small linear. While you're doing the peripheral venous cannulation, is make sure the cannula, make sure the wire is in the SVC. The TE is very, very important to this. Once again, downsize the cannula. In case you're feeling any kind of resistance while passing the cannula, abandon that part, choose the opposite vein, or if there's any doubt, use an intraoperative fluoroscopy or intraoperative angiography to know where exactly you are. If you're going for a direct femoral punch, the trick is go 1 to 1.5 centimeters below the groin crease. It's easier to introduce it at that angle and easier to do not forget this particular principle. If you do not pre-dilate your artery and even your vein, you're going to violate the integrity of that particular vessel. So it's very important to dilate. And this again is an image that most surgeons should have in their mind. A TE image of the SVC out there. The left atrium is also grain in our mind. We need to see safely the guide wire in the SVC cannula before we pass the catheter up. Sometimes I always keep this as exit strategy, a backup plan, and that is in case for some reason I deflect some metallic cannula, place it to a future ICD, and introduce it directly into the vena cava. Usually it's the SVC. Always keep that in mind because sometimes you can have problems, and this particular simple technique can help you out of that problem. Well, it's come to the incision of the mitral, the X-ray. Specific tip for female patients, enter always through the inframammary crease. In the US, we always had many females coming with implants, so that's something that we need to totally safeguard. So enter through the inframammary crease, track on. This particular preoperative X-ray, everybody tends to make a mistake of counting the posterior intercostal spaces. You need to count the anterior intercostal space because that's the space you're going through. That's the space you're looking on. By a rule of thumb, overall, the third is the apex of the heart, as you can see out there. So that's a good place to go. Sometimes if you're starting out with a larger incision, it's always easier to go into the fourth space. So this is a photograph of a patient who's had an endoscopic mitral valve repair. As you can see, there's only 1 incision and 3 extra retractors for the skin. Avoid rib retraction. And I'll be discussing about the pericardium opening and the pericardial sutures. Very, very essential with a short video. Adjunct to the incision. Try and make the most of it. The very, very important is the chest tube. And it's what does everything for you. It gives you all kinds of access. You can put the diaphragmatic sutures in there. You can do, LA vent can be introduced in there. Just hang on 1 second. Yes. So, okay, there. So once you do that, the cardioplegia, usually you like to give a cardioplegia through a long MIS cardioplegia cannula, an antegrade cardioplegia. You do have a retrograde option, but you need to have ventricularized pattern and all the usual things. Cross-clamping, always try to develop a cross-clamping plane. I like to go over the right branch of the pulmonary artery, retro to the aorta, pass the clamp on. There have been instances when you've clamped up, you've had the left atrial appendage flexing in through your clamps. You need to be careful about that. Although I've got different sizes of the Chitwood clamp for me, I've never used a large Chitwood clamp in Indian patients. Somehow or the other, it's only the small Chitwood clamp that does the trick. This is a very busy set to just the three things that I use out there. One is the primary incision. Apart from that, down is the incision for the ICD vent. It's called the working port incision. The one on the top that you see is the incision for the superior retraction sutures, the cross clamp and atrial lift. So I always like to dissect the Waterson's groove, though many people like to reserve that for redo sternotomies. Different kinds of atrial lift plates. Initially, I used to use a V-shaped one, and now it's a standard Geister retractor. Don't injure the internal mammary vein when you introduce the lift apparatus. The standard procedure for whether it's a valve replacement or repair, the only difference I feel is when you do minimally invasive valve repairs, it's always easier to place your annular sutures subvalvular apparatus, and enables you to make decisions about that very well. The entire procedure is CE-centric. We need to understand that our anesthetist is going to help us just not just for cannulation, arteriovenous, but also for cardio. So let's head on. This particular short video shows us the endoscope introducing in the phrenic nerve is identified, go 2 centimeters anterior to the phrenic nerve, electrocautery. I always like to do a little bit of thymectomy, diaphragm, one at the right superior pulmonary vein, and one at the junction of the pericardium and the SVC. I like to make a little bit of space behind the inferior vena cava, dissect the Waterson's groove, so that in case I do need to extend the incision for better visualization, it's always MIS, cardioplegia cannula introduced in a Chitwood clamp, undervision, clamping, cardioplegia going on, making sure that the aortic root pressure is good. Go ahead and introduce a vent in while the cardioplegia is on and drain it out. So this particular initial simple light, and as I got more and more comfortable using this, I moved on to the Geister retractor, which I'll show you in the subsequent video. So this particular thing, easy video, see the visualization of the mitral valve, and let's just go on, yeah. So in this particular part, I've tracked mitral valve apparatus seen pretty clearly. As in a standard repair approach, go ahead and do the valve assessment. Here you're seeing A1, P1, there's clear prolapse of P1. Usually you take it standard, but if you check it out from all other segments, this particular case was shown to have a prolapse of the P2. My anesthetist has kind of measured the height of the required artificial cardiac that would have been required to repair this. Undervision again, clearly go in the junction, pre-place your valve ring sutures. I think that's very, very essential. I feel that's a big valve kind of opens up, and then you can see the sub-apparatus easy. So once I finish placing all the sutures, the second thing that I do is just correlate what my anesthetist has told me, and that's about the size of the ring that would be required. Here, size 30 seems right, 28 seems too small. And after that, this is the important part with all the sutures. You can straight look right into the pap muscle, and that is the culprit area. So I've taken you put it in and stitch it down, use your Gore-Tex stitch to fix it. Once you've done, I pre-place some sutures in the Gore-Tex card, so I don't spend time finding those ends of the Gore-Tex cards, and I inferior its P1. As you can see out here, there's a large cleft, a large gap that probably secondary developed over time between P1 and P2, and I just feel that that's a good cleft that we need to get a good opposition. Once that is done, I do a small saline test at this point in time, just to make sure we are in the right direction. If any of the rare, we can do it now. It's always harder to do small subvalvular work once you put the ring in, simply because of the rigidity of the ring. So once that is done, I get the appropriate size ring in. Line test and go down first in so many ways. Before TE came into place, it still holds good, and the rest of the procedure is standard closing of the right atrium, the left atrium, sorry, gearing of the heart, and checking the result on the TE before you're able to come up cardiopulmonary bypass. So I think I like to end at that particular note, and minimally invasive mitral surgery is here to stay because the benefits provided. Time and again, we've reproduced this procedure. There has been an evolution of approach, and I'm sure way forward there will be more changes. As of now, it's important for us to understand that our team that we work with understands what we're doing. We follow a certain protocol and select the correct kind of patient and the setup to be able to provide us all the benefits. Sacro World Hospital, where I work at Bangalore. And Rizvi, over to you. Any questions now at the end?
Yeah, that's fine. Just the small question to you: that what cardioplegia do you use? Do you use custodial?
I actually use normal blood cardioplegia. If it's a very complex repair that I need to spend close to more than 16 minutes on clamp time, then it's custodial.
Okay,
yes.
Thanks. So there will be a lot of questions to you as well. So I would like to request you to be there all the time at 8 o'clock, because I think there will be a lot of questions to you as well. Thank you so much, Adil, and thanks for the candid and nice presentation. And most importantly, it is done within time. So thanks. So with this, I would like to welcome our next speaker, Professor Amaresh Rao Malempati is going to talk to us. Amaresh, you are ready? This will take some time.
Yeah, I'm ready, Rizvi.
Yeah, okay. Thank you. So let me introduce Professor Amaresh. He is a faculty at Nizam Institute of Medical Sciences, where he heads the unit of cardiothoracic surgery and also the in charge and head of the Department of Vascular Surgery. And he did his MS and MBS from both from there. And then he did his MCS from Trivandrum. And then he did his residency in AIMS long back in 1999. Presently, he heads the Department of Cardiovascular and Thoracic Surgery at Nizam Institute. He has got a huge lot of students under him. That is number 12 MCS students under him. Conclusion of the Sree Chitra Valvular prosthesis. And I would like to request Dr. Amaresh to go ahead with this. Thank you.
Thank you, Hrithik. Always difficult to speak after Adil. He has taken us to the future, whereas I go, that's where how we'll know where to go for the future. There's a lot of thrust on Atmanirbhar, and there's a lot of thrust on Make in India. So I would like to proudly share what has been the major success story. These slides are just most often presentations made by Dr. Valyathan sir, Dr. Krishna Manohar, and various faculty of Chitra. And all stories have a small beginning, and this Maharaja of Travancore, Sri Chitra Tirunal Balarama Varma, who donated a multi-storied building for what would be the future of Chitra. And the Chitra Institute is nothing when we don't acknowledge Valyathan, the first batch of MBBS from Medical College Trivandrum, and then he has worked with so many greats, including Vincent Gott and the Gott Valyathan Shunt, and Town University, worked with Hafnagal. This is with Hafnagal. And then eventually he came back to India. He had a short stint at Safdarjung, and then at IIT Madras. And then when he was called to Sri Chitra Institute, and that's how it needs. You need to be at the right place at the right time to get a lot of fillip and boost by Morarji Desai, who declared it an institute of national importance as well. And then this is the palace which was developed as the facility equipped with a lot of labs, with a lot of research units, with a lot of testing units as well. And but that was really the vision of MSV, which really paved the way. Chicken biryani there as well, in case you go and visit there as well. Now there always remained that why should we do a heart valve and why a tilting disc valve? Because in those days, they assumed that the need for heart valve in those times, it would be 1.5 million, and they had done only 4,000 valves by that time. And cost was obviously so prohibitive, and there were hardly any abattoirs there in Trivandrum. There was one which did 200 executed around 200 pigs, and the bovine valves came with its set of issues, and there were hardly any autopsies done for a homograph. Then in those days, base level of thrombogenicity, they picked up on the tilting disc valve. So as I say, मैं थोड़ा chronology explain कर दूँ आपको. So there were various models in use. We'll go through them. And so on, and it so went on till it's a long story to commercialization in 1995. So interestingly, they were designed, initial Chitra valves were designed based on Delrin discs. So the first model which was used was the titanium Delrin model. Interestingly, these cages were, these struts were welded under high temperature fractures. These caused fractures at the areas where they were melded. And of course, that's what eventually they had to give it up. And then this was a polymer. Delrin was that when they were to be sterilized with steam or saline, they tended to get fractured as well. So that was the reason why they gave it up. And then came the titanium sapphire model, and then suddenly they realized that this titanium cage caused the disc to escape. Surprisingly, this was seen in the pigs, but it was when they had tested. So they realized that the testing was done with glycerine water, and this actually lubricated it and prevented it from the wear and tear. Whereas when they changed the testing to this wear and tear and escape of the disc was, then they were able to mimic it. So it was time to give this up as well. It was time to give up titanium. It was time to replace titanium with a higher. Then came the Haynes alloy. The Haynes alloy was already approved for use in human sectors, for some other things. And that's where the third model, in order to give it more strength, it was coated with a titanium nitride coating. And the disc was a sapphire. This was a ceramic now. Initially, they were using polymers, but this disc was crystal alumina. And it did well in the initial testing. It did extremely well in testing. And then they realized, when they implanted in animals, they realized that 2 animals died suddenly, and they died of the fracture of the sapphire disc. Now these passed, that was a cause of great concern. They could have accepted that it has worked quite well and maybe it was one-off, but they checked and checked. They checked maybe while the assembly, some part might have got weakened, or maybe there was not adequate, but they couldn't figure out. And then they decided that ceramics was not the way to go. They tested a lot of materials and then decided that probably polymers were the way to go. So ultimate model, which was, of course, the sewing ring was always the PET, polyethylene terephthalate fabric sewing ring, which was sewn in with hand. The disc was now the ultra high molecular alloy cage. Now this same alloy cage was earlier lined with the titanium nitride, but then now they realized that it didn't require that additional strength. And so they did away with it. So the plastic disc, as compared to the Delrin rings to cause any problems to the hemodynamics or breakage, it was less weight. And because the impact, it closed with a lesser impact, the sound to the patient was also less, blood as well as there was less disturbance in the pressure across the valve. All these are small incremental gains, but all these put together really made a big difference. Not radio opaque, and we have to use it by an echo, assisted by an echo. So I just wanted to share that this is a very unique. It has a lot of controls. There are long endotracheal tubes. It's really funny to see that the endotracheal tubes are so long in them. There is nothing like the surgery is also not that easy. You don't cannulate, or if you don't take strings properly. So it is not such an easy surgery. And there's nothing like an elective ventilation in the animals. You just finish the surgery, they're left alone to roam around here and there. But having said that, these animals are treated extremely humanely. They are extremely good professionals who work hard with them. And they are really taken very good. Animal experiments, they moved on. These animals, initially the animal was sacrificed at 3 months. They saw everything was fine. Sacrificed at 6 months. Another animal sacrificed at 6 months. Everything is fine. And then one animal died after 4.5 years due to a pneumonia. Then and mind you, these didn't receive any anticoagulations except for initial dipyridamole or some initial aspirin. And then one animal died after 7.5 years of some viral disease. Then they realized everything was fine in it as well. Finally, there was one animal which died at almost 8 years, 8 months. And then they found that there was a clot there, 9 years without any anticoagulation. That was amazing. So, of course, we wouldn't recommend that to our patient. And then subsequently, they had this multicentric trial where the various did a total of 266 cases, followed it up to 1,212 man hours. And finally, they said this is fine. And then not only that, they still kept performing advanced tests for all the components. And finally, on 6th December, they were ready with the first implantation, 6th December 1990. And of course, since then, we have been the best tilting disc valves available, and it actually outperformed them in a lot of parameters. They were assessed very closely. In fact, it outperformed the Bjork-Shirley valve even in hemodynamics, because this time the struts that they addressed the fractures and other things as well. Then, of course, they were one of the success stories where they could commercialize it. Chitra has a good history of commercialization, because they could commercialize the blood transfusion in the whole country. And then these were all manufactured by the TTK healthcare facility. In fact, during the initial stages, the titanium discs were molded at, the strut molded at Keltron, and then the sapphire discs were imported from Sweden. But this is now all homemade. They are fabricated from rods, then shined, and even the discs are, the dummy discs are made, and then they are trimmed using various, more than 1.5 lakh implants. Whether we like it or hate it, they have come through a long drawn process. More than 1.5 lakh implants at so hardly any issues of structural, no issues of structural failure. Interestingly, the first human valve implantation was on 9/11 in 1952 and December 6th in 1990. They did get a National Technology Award. Chitra is one of the centers which has approved the Technical Research Center for innovation, especially in cardio and neuro implants and various biomaterials. And they didn't. There has been work going on for a newer model as well. Now, what are the things which are improved? One was that we would like to see. One was they once again went back to the titanium nitride coating of the and then they did the occluder. Earlier it was convexoplano, and then they did make some hemodynamic changes. Of course, since the valve is not yet for commercial use, these things are not yet open. Multi-centric trials have done anytime soon. As I said, it was developed with the help of TTK Healthcare as well. They are MRI compatible. They are supposed to have better hemodynamics, more MRI compatible via fluoro again or not. Interestingly, this work on this has started in 2005, but the clinical trial results are yet awaited. This is mainly because of the regulatory issues. Earlier, the valve started in 1983, and they could commercialize it in 12 years. We would expect, since this is just an improvement, it would take less time, but regulatory mechanisms are much more stringent now. They say that it would cost almost the same, so there's not going to be much of a difference in cost. So that should be a welcome thing. So it is that Professor Valyathan, he is such an inspirational figure, and he's such an inspirational role model. He calls upon Muralidharan. The man in the white veshti is Muralidharan, the first patient. So he was assisted by his sister Janet. So they are the whole team. A lot of people are there in this team who have felicitated him last year on December 6th in 2019. So this is almost they say the valve has a life of about 40 years, maybe even 50 years. But at 30 years, he's really doing well. He's post AVR. He's had a pacemaker implanted, but this is one valve I wish that there is a lot of negative talk around it, but it has come through a lot of stringent testing. It has gone through a lot of stimulate. They continue to gather data. Nobody has really got any adverse data on this valve yet. There are certain difficulties like rotation of the valve and the valve holder, which are being addressed now. So in the new models, template which we should take forward into the future, that this is how we are to develop our own research, our own solutions for our own problems, and that's how we can progress as a country. Thank you very much.
Thank you, Professor Amaresh Rao, for your candid presentation. There will be a lot of questions on this for sure at the end of the webinar session. So I would like you to stay connected, as well as your MCS students, which also I presume that they will also stay connected. So with this, I would like to call upon our next speaker, Dr. Rajneesh Malhotra, sir. So he's he's presently located at Max Saket Complex and heading the Department of Cardiac Surgery in Max Saket. His primary role is in adult cardiac surgery, minimally access cardiac surgery, TAVI, heart transplant, and artificial heart and lung transplantations. And I have chosen a very important topic, how we can choose a particular prosthesis for a particular patient, how we can tailor it to the patient's needs. With this, I would like to welcome Dr. Rajneesh Malhotra, sir, to this webinar. Thank you, sir.
Yeah.
Are you ready, sir?
Thanks, Dr. Rizvi. Were you able to see my screen or no?
Not yet, sir.
Not yet. Okay. Let me try.
Yeah, it has started, sir. Yeah,
can you see my screen?
Yes, sir. Yes, it has come.
Can you see my presentation? You can see my presentation, yeah?
Yes, sir.
Okay. So at the outset, I would like to thank Dr. Rizvi and Bhatt for giving this opportunity. I mean, it's like covers all the aspects of the valve surgery. It has been right from, I would say, the cardiologist's perspective, as well as the perspective of the surgeons and different practices, what are being, I would say, a very, very good initiative, which the Dr. Rizvi has taken, and he has, I would say, taken up this topic and covering all the aspects of it. So for cardiac surgery, because all cardiac surgeons would have different kind of choices what they make with the different kind of the valves. So greetings from Max Hospital. Vivek is also part of our team, I mean, who is in charge and head of the cardiac surgery team at Max Parpadganj, and where we started with the, I would say, very small, humble beginning, but now we are doing a lot of cases over there. And not only that, alveoli transplant, everything is being planned and being done over there. So thanks, Rizvi, for today's invite. So I would say by saying, sharing our Prime Minister's Achhe Din Aage. So we all, as Indian citizens, have still been waiting for our Achhe Din. But we cardiac surgeons had dream run. We had our, I would say, Achhe Din, or dream run for, 3 as demigods. And we were doing and we were planning whatever, I would say, surgeries or whatever things we were doing. We were treating cardiologists as our, I would say, technical coaches, referring this to us, any triple vessel, because there were no stents at that time. And then when the stents were being invented, especially the drug-eluting stents, the cardiac surgery very to crossroads. And in 2005, the cardiac surgery was, I would say, had already seen the best of the time and the worst of the time. And but what we had to really think what lies ahead. So do we have a future as cardiac surgeons, or we all are finished? And I would say, because I have seen cardiac surgery developing in front of me, they will say the cardiac surgery is going to become extinct and there will not be cardiac surgeons anymore. But that really didn't happen, because cardiac surgery and cardiac surgeons evolved with time. So we stenting changed. Drug-eluting stents came. They started implanting stents in all kind of, I would say, vessels and multi-vessels. So we also changed our ways to minimal invasive surgery. And minimal invasive surgery has become standard of care. I would say the centers who are not doing it or not have made it the standard of care, they should really take care, because in time to come, most of the things will be taken over by TAVI for the aortic valve, and percutaneous also, mitral valve is also on the end valve. Many places it has also been being implanted. Change to minimal invasive and do not make it as a standard of care. We soon will face another dilemma, and then will be at the crossroads where we will be losing our I would say the coronary surgery volume. So what we have to really modify, change, and there are different approaches. So the surgeons have to adapt to the new realities, and they have to minimal invasive, partial stenotomy, partial thoracotomy, small thoracotomies, TAVI, and videoscopic. So surgeons can be done through this, whether it's aortic, mitral, ASDs, myxomas, tricuspid tumors, atrial tumors, everything can be done through this. The advantages are maximum, are obvious, and the cosmetic advantages there with these patients. This was the mitral valve, this is an aortic valve, this is again an aortic valve. But the problem with us in India still remains that a large population, what we see is still the younger population. We are seeing more and more, I would say, elderly people who are coming to us with degenerative disease. We are seeing they want to have a childbearing in future, so that those patients are also coming to us, but still the younger population is still coming to us. And then we have to plan that what we fevers or rheumatic heart disease prevalence, which is in India is still a very major part. So Indians are living longer, so we are seeing more degenerative disease, and especially the aortic valves. And we have started a significant proportion of the valvular heart disease are women who are picked up during pregnancy, and improved pediatric services result in salvage of the neonates who had congenital valvular. Still say the medical management of the prophylaxis is the best way to go about it, if it is possible. And if it is mitral stenosis, we can still do the balloon mitral valvotomy if the valve is not leaking. Valve is leaking, then we have to resort to mitral repair. And if repair not possible, then we have to really resort to valve replacement. And there is a definitive treatment of the valve repair and the replacement there. And the valve repair, and there is a regurgitation pathology, then we have to really adapt to and choose valve repair in these patients. But we have to be, I would say, take a caution that the whole team has to be trained for it, and your echocardiographer, the cardiologist, then you have to, because identify the right kind of people, right kind of patients, where you can give the best results. So the repair is the first treatment of choice in mitral valves, but yes, you need the expertise, and that remains the advantage, because we are preserving the natural valve, and there is no need for any anticoagulation, and thromboembolic phenomena are not there. So valve repair is, I would say, of many reasons. The valve is calcified, the valve is degenerated. If we are not able to do that, then we have valves available to us. This is like the Chitra valves, and we have plenty of options. As we go across, we see the valve, which valve to choose is always remains a problem for and if we are looking at the mechanical valves, we were just discussing about the single leaflet or the Sree Chitra valve. As we were being told the advantages of it. But many of my colleagues, I have seen they have been using it. So I don't have much of the experience with this. But yes, I have been using this bi-leaflet valves from Abbott and many other companies. And we have plenty of tissue valves available to us, which I will just take you through, that these valves are available to us. As I just recently said, the volume of the tissue valves are opting for tissue valves, and that these tissue valves have got better hemodynamics and better longevity, the current generation ones. So these are being launched. And the repair, if it's aortic valve, where we are putting more and more tissue valves, and even in the mitral, and same is the scene in India, where we're putting more and more tissue valves as compared to mechanical. But still, I would say if we compare from 2001 to 2006% mechanical valves, today we have 65% mechanical valves, and the tissue valve volume at that time was 4% versus 35% now. So the volumes have increased, which have taken from the industry itself, because So they have told me about this. This is the current status where more and more tissue valves are being implanted, but the premium quality priced. I mean, we have, and we see the valves costing from 60,000 rupees to 4 lakh, 4.5 lakh rupees. The standard, it's not, I would say, standard valve, and then put it, and the replacement in bioprosthetic valve, especially the previous generation valves, which were, I mean, the problem was that these valves can degenerate, and within 5 to 7. The new generation valves, I will just take you through, have come, which are, I would say, have a better or longer longevity. So mechanical valves or biological valves, they both can approach through any of the approaches, through the femoral, apical, carotid, subclavian, or transdirect aortic, and then the sutureless valves. So the options are plenty, and then the surgeons have to choose from a ball and a cage valve, which I have personally implanted in many of our patients, but now it is not available, which was Star Edwards valve. And then the single leaflet, there was initially the Sree Chitra valve available to us, and then the bi-leaflet. So there are plenty of varieties available to us in the bi-leaflet. On the right side, there are the tissue valves, which I'll just to see. To choose one valve and you just put it for your lifetime, and then you are good. But unfortunately, it is not available. It is not the scene. So as I said initially, then when we follow, so if we have a chance to repair, we should always go for repair. And if the patient has got life expectancy of 15 to 30 years, then you go what we have to use. And if the expectancy is less than 30 years, less than 20 years, then I think we should seriously consider tissue valves. And there are special situations. So the cost of surgery is included. I mean, it's like, as I said, costing between 22,000 to 50,000 or 4,50,000 rupees. These are the different companies making this. And thromboembolic, which is whether it is a single leaflet, whether it is a ball and a cage, or whether it is a bi-leaflet valve, thromboembolic, and this problem always remains. And there have been chances, and then the patient has to maintain the PT-INR, which all of us are very well aware that we have to maintain it between 2.5 to 3.5. And initially, Abbott or the St. Jude had provided with the machine where the patient could do home monitoring of PT-INR, but this has been discontinued. I would say this was a very good practice shown. If the patient does home monitoring of the PT-INR, the results and the outcomes are very good, and the thromboembolic complications become less. But this has been discontinued. A mechanical valve implanted, they will be given a machine, a PT-INR machine, where they can do a home monitoring of PT-INR and take care of that. And another problem, what people have to take care of, so we have got top hat or the valve, which are totally supraannular in mechanical situations. And many of our tissue valves are supraannular. So in a good exposure, position the light table in a proper position. Do not oversize the valve. Consider supraannular placement. Do not use everting mattress and the valves which are heavily calcified. So you have to take out the calcification and use, I would say, if you can enlarge this, and then you can put a stentless valve, a freestyle valve in these small aortic root situations. And then we have got releases, newer valves which are available to us. We have got new trifecta valve available to us, which has got both pericard as well as the this thing Inspiris, which is by Edwards, and then the pericardial valves, which is made in India at Daffodil. So I have implanted all of these valves, and I have got excellent results with these valves available to us. And then we have selfless or sutureless valves. This is I would say a trifecta valve, which has got a 10, 12 years, and have had excellent results with this. So this valve gives a very good hemodynamics, and a patient who is, I would say 60 years and above, you can very blindly mix. There are a couple of surgeons who have had bad experience with this valve, but I would say if they're oversizing and they're not properly placing this valve, then you have properly sizing and putting the valve properly. It is a very good valve, gives a very good hemodynamics. I have used this valve, and even after 10 years, it has got a single digit gradient. So this trifecta, and there have been many publications where they have shown the long-term durability, long-term hemodynamics, and as compared to other valves, the gradients is around 10 after 1 year. So even in a bigger size valve, the gradient becomes much less, and even in the 19 millimeter, you will have a gradient of 10, 12. This is an option. Even in a small aortic root, you can put it. And then another option, which is a Resilia valve, which is being launched in India. A couple of pericardial valve, which is being put, and it is, I would say, this Inspiris Resilia valve is future ready. I thought about that if we put this Resilia valve in a younger patient, and in future that patient requires a TAVI. So this valve is already ready for it. So it has an expandable, what kind of the size of this valve is, and the durability of this valve. I mean, this valve is preserved in not in glutenaldehyde. So they have taken Referral. So the water content is not there. So this valve is preserved in I would say in vacuum, and then it is a dry valve. You don't have to implant it. And in the lab studies which they have shown, I mean, this valve is more than 20 years, has a more than 20 years durability for 25, 30 years. So I would say this old patient, you implant this, and if suppose 10, 15, 20 years down the line, when patient requires this, so this valve is already ready with the technology where what I was saying. So they have taken the free aldehyde sites, and then you have, I mean, that is replaced with glycerol. So where you can, I mean, the calcium is not binding at those sites because these will reduce the longevity of the valve. So this is, they call it as glycerolization of the valve. So this glycerolization is totally a different technology which has been presented or given to us. And with this, we can, I mean, have a better longevity. So this is a Resilient tissue valve. As I said, the markers are there, and this valve is strut can slide on each other, and so that you can put a bigger size TAVI if required in future. So, and it gives you a better hemodynamics. And then the sutureless valve, I have to put it in a small aortic root. I have implanted in a small aortic root of the aortic annulus size of, I would say 19 millimeter, a medium size valve, where, I mean, you will have a, I mean, single digit gradient, which is equivalent to 21 ball and a cage. So now we have got many sutureless available to us. So but mainly which is available to us is a Perseveral, which is made by Soren company. And now the Edwards is also being launched. So this valve, I mean, have been implanted in, I would say, thousands of patients, both the Perseveral as well as the Intuiti, and have got excellent results. The 3F enabled Medtronic valve has, these valves I have implanted myself and have found excellent results with this. These valves need to be collapsed on the table. And once you have collapsed these valves in a sutureless manner, because these valves have got, I would say, the stents, and can be very easily, I mean, without any sutures can be implanted. So you excise the valve as in a minimal invasive platform. It's one of the easiest things what you do, because the time is, I mean, you reduce the cross clamp time, because the only thing what you have to do, you have to open the aorta, decalcify the valve, implant this valve, and you can very easily do the, I mean, suppressed, I mean, I would say partial sternotomy, whichever way, and there is no suturing. So, and there are no pledgets and sutures there. So you can always deploy a bigger size valve as compared to valve. Gives a very, very good, excellent hemodynamics. So, and this is a bovine pericardial valve with excellent durability. So this is, I would say, through mini thoracotomy, mini sternotomy, and there have been a lot of publications. In the interest of time, I will pass you through this, where, I mean, these valves have been implanted. It has shown 5-year results with no structural valve deterioration, hemodynamics, and excellent results. And I would say in a situation which are medium and high risk, in Indian scenario, this valve is good. In a I would say in a high-risk patient where TAVI has India the 25, 30 lakhs rupees, so which is I mean, I would say a high cost. So TAVI remains still for patients who are at a very high risk and who can afford that. But there is, so TAVI, we have a full lecture on TAVI. I will just pass you through this. So TAVI is also another option. As I said, in today's current scenario, we have to really think about it, that when we are going to put TAVI, because we can put these tissue valves and these tissue valves where, I mean, we have put these valves, I would say, in younger patients, and this can be put, I mean, I would say the medium-term results are also good, and the medium, and we have a full talk on TAVI where we are going to cover all aspects of TAVI. So I would say, so the current generation valve, which are future ready, can be put at a younger age, and then you can at a later stage or down the line if you require. So I would conclude my talk by saying minimal invasive cardiac surgery standard of care. Surgical anatomy pathology, one size fits all approach still does not work. I wish improving in terms of durability and hemodynamics. Sutureless of the rapid deployment valves, reduce surgical time and increase safety. TAVI is still for the high risk and can be put for the intermediate risk, as they are high risk patients who can afford this. And as I said, we can put the tissue valves and younger people, because we have got the new generation valves available to us. Thank you very much for your attention. Thank you.
Thank you, sir. Thanks for this candid and lovely presentation. And but I'm 100% sure that we'll have a lot of questions on this, because there are certain angles, certain things we need to know and clarify from you. So I would like you to stay at the end of the webinar around 8 p.m. and you can keep on logged in till now. You once again at 8 p.m. sir, for a lot of questions. So with this, I would like to welcome our next speaker, Dr. Adil Rizvi. Adil, are you ready?
Yes, Dr. Rizvi, I'm ready. So,
yeah. So, Dr. Adil is a principal consultant at Max Hospital now in the Department of Cardiothoracic and Vascular Surgery. He has done his MBBS and MS from and then worked for a long time at the Fortis Escorts Hospital before he became independent full-time consultant at Asian Hospital in Faridabad, then PSLI, and subsequently joined us a year back. And Adil has a huge interest in structural heart valve diseases, so he will speak on research. So my question to you, Adil, in the beginning: can Onyx valve be used in aortic position in all age groups? Thank you.
Yes. Good evening, everyone. It's been a pleasure to be on the panel of some such eminent persons. And by the end of this talk, I think Dr. Ritvik's questions will be answered. Yes, or which one valve which fits all, but there have been developments not just in tissue valve scenario, but also in mechanical valve scenarios also. So one of these development is the use of lower anticoagulation with better designed valves. So today I'll be discussing one such valve, which this low INR, this thing, anticoagulation management. So everyone is aware tissue valves have durability issues, calcification, tears can happen. With metal valves, we have two major important things to keep in mind. Those are thromboembolic and bleeding issues. And a minor one will be cell trauma. Some patients are very susceptible to cell trauma. So now what's this Onyx X valve, which is free from silicon, and this pyrolytic carbon leaflets which are there, they can open up to 90 degrees. They have very good mechanism. This is a hingeless valve, and it has very good mechanisms of channels which wash these pivot areas. So this is a new development encouraged by very low thrombotic rate of this valve. They started of this trial, which is known as the PROACT trial, and they had two arms in this PROACT trial. Two arms. One was the low risk platelet therapy, and the high risk arm, which was like 1.5 to 2 INR combined with low dose of aspirin. This particular regimen was instituted 3 months after surgery following a formal anticoagulation regimen that is like 2.5 to 3.5 INR. There were certain criteria. I'll not go into very details, but to place a patient in a high risk group, ejection fraction LVEF of less than 30%, enlarged left atrium of more than 50 millimeters in diameter, spontaneous echocardiographic contrast in the left atrium, vascular pathological features, neurological events, hypercoagulability, left and right ventricular aneurysm, lack of platelet response to aspirin and clotting. So these were the one of the how the patients were included, and the definition of high risk. So and exclusion criteria were right-sided valve replacement, double valve replacements, and with endocarditis. So this particular trial was initially published in 2014, and then subsequent intermediate review was also done. And the conclusion was, I want to tell you one thing, that the low risk arm was stopped in between because dual aortic rate, which was very high. So the low risk arm was stopped. Only the high risk arm, that means that anticoagulation from 1.5 to 2 INR plus ecosprin, this was continued. And at the end of the trial, even in the intermediate review, they found that it can be safely ecosprin. So these are just things where they compared all the other parameters. So they have equal thromboembolic rate, but much less bleeding rates, with an INR of 1.5 to 2, and with this ecosprin given. 2017 AHA focused guidelines for management of valvular heart disease included it as 2B, which is like weak clinical evidence based on a single study. So there are certain things that we should remember about this particular valve, and whether this low anticoagulation regimen is applicable for this valve or other valves also. So we will just find out. So one thing that this study did was in Onyx valve, but the other thing is that just because this particular study was done on Onyx valve, that does not exclude the possibility that we can have a lower INR in other bileaflet prosthetic valves. And in fact, there are not many studies which will compare different prosthetic hydraulic risk and bleeding risk differences. So this opens up a possibility that whether it is just Onyx valve or other modern bileaflet valves can be safely maintained with an INR of 1.5 with addition of ecosprin. So done with valves other than Onyx valves, although none of them have been like incorporated into AHA guidelines and other things. So these reports are still preliminary. So like this LivaNova valve, this was again studied in INR of 1.5 to 2.5. And so the same results were found that thrombotic events were coagulation profile. Similarly, St. Jude valves, this ESAT-3 early self-controlled anticoagulation trial study, this also studied a lower INR 1.5, 1.6 to 2.1 self-managed. This is a very important checking of INR by the patient himself. So with these St. Jude valves, they were able to maintain a lower INR with self-INR management with a range of 1.8 to 2.8. This standard coagulation, when they compared, they had a similar thromboembolic risk, but much lower bleeding risk. So in conclusion, what we can conclude is that this Onyx valve, it is possible to maintain safely an INR of one. But the most important thing to remember is that the INR is self-monitored, weekly monitored by this INR machine by the patient himself. The second part is that this lower INR which was studied was in combination with low dose. And to remember that although low anticoagulation was used, but it was used with ecosprin. The second point is that the INR were self-maintained, they were self-monitored. So like patient was much more motivated to maintain the target INR, because a lot of studies done otherwise show that at least sometimes is the INR is out of range. By just addition of self-monitoring INR machines with the patient, as done in this PROACT trial, we can really have a much closer INR control, and that can have a tremendous benefit in lowering the thromboembolic rate. And that we can use this particular combination, a lower INR with ecosprin in Onyx valves. The second part is it has to be, it is a dual therapy. It means like anticoagulant with a antiplatelet. Third is it is a self-monitored scenario, which studies which were conducted were lot of other modern mechanical valves can it is likely, the studies are indicating that it is likely that even those modern metal valves can be maintained with a low INR and with addition of ecosprin with self-monitored INR. So this is the point. So like for example, we are kind of looking towards a valve which will last forever throughout a patient's life, and the patient will be free from side effects of major steps towards achieving that. And in future, I think as design improves and the material engineering improves, we could have a mechanical valve which does not require, or which requires only minimal anticoagulation, and one which can really last for a very long time. So in conclusion, this is the take-home message, that Onyx valve for sure, and other valves too can be maintained with a little lower, very tight INR regulation. So if this can be done, I think we can control this thromboembolic and bleeding complications in mechanical valve. In mechanical valve, there is a very thin balance which has to be achieved between thromboembolic events and the bleeding complication. Data accumulates, at least for aortic valve, we can safely cut down this target INR, especially in Onyx valves, in like to 1.52 in combination with acetrom. So I would like to conclude my presentation here.
Thank you, Dr. Adil. That's really wonderful. Basically, for two purposes. One is that you have really given a new insight and the recent guidelines for the Onyx valve. And secondly, you have terrifically concluded the topic on time. Thank you. So there will be a lot of questions and ask you questions there on the Onyx valve, because it is to you as well as the company itself, the Onyx, about few things. So I will come to you later on. Thank you very much for this presentation. So next one will be so next one is from Dr. Ajeet Bana of minimally invasive right anterior thoracotomy aortic valve replacement, how he does it, and that's what we're going to learn from him. Dr. Ajeet Bana, sir. So he's the chairman of Cardiac Sciences in Eternal Hospital, Jaipur. He's completed an MCH in cardiothoracic and vascular surgery, 14,000 cardiac and vascular and thoracic procedures, which includes cabbage, valves, aortics, endovasculars, TAVIs, and heart transplant. He's trained in heart transplant from Israel and minimally invasive cardiac surgery from France. Therapies including TAVR as well as the MVR. With this introduction, I would like to welcome Dr. Bana to start. Dr. Bana, are you there on the Dr. Adil, you can stop sharing your slides now. Dr. Bana, are you there on? Yeah. We can see your slide, sir. You have to unmute probably, sir. You're muted, I think. Sir, I think you are muted. Dr. Bana, you have to probably unmute yourself.
Now I think you can hear me.
Yes, sir. Clearly. Thank you.
And
good afternoon.
Hi, good afternoon. Good job, Rizvi.
Thank you, sir.
And I'm really excited that so many people are here and so many people are interested in afternoon webinars. Now the webinar is too much, so majority of people don't attend it, but I'm seeing so many people are listening to these webinars. Very, very exciting. Replacement through right anterior thoracotomy. Some of the pitfalls, what I did wrong and how we can achieve good results. Let's talk about it. First of all, let's go to the next one. So we all know that the aortic valve disease is lesser common than the mitral valve disease, but it is not uncommon. And with the age, it increases. As the age increases, the prevalence of the aortic valve disease increases. And you can see about 10% of the patient up to the age of 80 can have aortic stenosis, which will be symptomatic. Logarithms are there to treat aortic valve disease, either aortic regurgitation or aortic stenosis or maybe a combined lesion. But at the end of all the logarithm will at the end will tell you that you need to replace this valve, means surgical aortic valve replacement. But now we have one more option that we can do a transcatheter aortic valve replacement in few selected patients. We are practicing it, we have learned it, and we are doing it for ages. Full stenotomy, central coagulation, routine myocardial protection, use whatever valve you want to use, mechanical or tissue. And this procedure, we should be proud of it. It's not a bad procedure, it's a fantastic procedure. More than 3 lakh operations, 40 years of clinical experience, predictable, and they're low risk, and long-term results are available with us. You can see either you choose aortic stenosis or a mixed lesion aortic regurgitation. If you do not treat the patient and if you replace the aortic valve, the outcome of the patient is going to be very good. We are very sure about it. And that's why we are doing aortic valve replacement for ages with fantastic results. If you see the short-term results of aortic valve, intermediate risk and high risk, the results of aortic valve replacement, even in intermediate and high risk, are not bad. You see all the parameters, they fit very well, and they are quite encouraging to perform aortic valve replacement in majority of your patients. Let's say you use mechanical valve or use tissue valve. They are reliable, they are durable, and they give a very good survival to patients. You put implants at any age, the patient's survival will improve, especially in aortic stenosis and combined lesions. So why we need to change? These are the scenario now in 2020. We have a population which is aging and increasing life expectancy, changing longevity. People say that I'm not bothered about it. How many years my valve is going to last? Give me a bioprosthetic, but I don't want to go for an anticoagulation. Productivity, aesthetic appearance. I want a cosmetic result. Circulation information. Patients are aware of it through Google and various informations that their minimal invasive techniques are available, which requires a low anticoagulant. So the patients are well aware of it. And on the contrary, in a country like India, we have to give the best of the results. We have to fulfill all requirements of the patient, but we have a limited resources and cost constraint, which is not in the Western world. So what means aging population? New technical solutions, imaging, treatment options, and newer challenges. And we need to perform these procedures with a limited cost. So what are the minimal invasive AVR procedures we can perform, or AVR aortic valve replacement we can do? It can be by upper partial stenotomy, lower partial, but hardly few people perform it. And the commonest and most satisfying to the patient is right anterior thoracotomy. So why minimal invasive surgery surgeons should opt for? Because we presume that there is less surgical trauma, less blood loss, which require a low blood transfer, faster post-operative recovery, better aesthetic appearance, and definitely there is a reduction in the pain. But the problem which surgeon need to address is important to provide the similar results like the conventional. We know that the aortic valve replacement has, in low risk patient, has a very low mortality and morbidity. Patient recover fast, patient walk fast, patient LV improve the surgeon. It should not be the surgeon is sweating in the operation theater and he's struggling, he's shouting, he's throwing instruments. It is not like that. It should not be like that. And the problem, because we are, all cardiac surgeons in our training are exposed to full aorta, full heart, full LV. We need to compress the LV to dare it for exposure of the heart, proper exposure of the aorta. Something go wrong. How to handle it? So we need to change our mindset. The risk of conversion. If we are doing a minimal invasive procedure, especially by right anterior thoracotomy, and we require a conversion, then sometimes it can increase morbidity and mortality if you are not for thoracotomy or any other form of aortic valve replacement through minimal incision. It is very important in your mind, in your back of your mind, that you need to be aware of that how to convert if you are having any trouble intraoperatively, so that patient morbidity and mortality should not a long learning curve. You see 10 somebody assists you 10 and you can perform 10, then you will be good. Upper partial sternotomy is suitable for any type of aortic valve replacement, maybe central aorta, whatever aorta is that. But right anterior thoracotomy need to be evaluated properly. You need to evaluate your patient properly so that you are not aspect, which I know. So right anterior thoracotomy, which was introduced by Bennett in 1997, and these all informations by which approach, which cannula, I will tell you. First of all, the patient selection. Patient should be severe symptomatic aortic stenosis or aortic regurgitation, or maybe combined regurgitation, aortic stenosis and regurgitation. Anterior thoracotomy, aortic valve replacement. Do not jump onto severe aortic regurgitation with your initial experience. This is not a good idea. It should be a proper pure aortic stenosis, so that you need not to go for a coronary cannulation for myocardial protection or cardioplegia. It should be a root cardioplegia. Not to operate, like chest wall deformity, displacement of heart, Highland index more than 3.2, post-pneumonectomy, adhesions, you can have a displacement of aorta, severe calcific aorta, or you can see on CT you find some small calcific plaques on the ascending aorta. If patient has a CVD, better to go for full sternotomy. Valvular heart disease can attempt MICS if somebody has a mitral replacement in the past, but not if in your initial cases. Obesity. To obese a patient, it is very difficult to reach to aorta. You may need a very good instrument. Rather, I'll advise you not to go for it with your initial experience. Radiotherapy, if somebody has a radiotherapy for Hodgkin's lymphoma or for other things, tissue will be friable, there will be adhesions. These are not good candidates for, at least for right anterior thoracotomy. You can go for upper partial sternotomy. Pericarditis, adhesions, because there is a pacing wire, taking a pacing wire, sometime manipulation of venous cancer. Right anterior thoracotomy, severe COPD, lung is full in the chest. It's very, very difficult to compress the lung. Documented peripheral vascular disease, you cannot cannulate the femoral vessels. You can go for axillary cannulation, but again, it will increase one more incision onto the chest. There's no cosmos is left than 9. If aortic root especially is less than 2.8, initially do not try it, because it is very difficult to place your sutures properly. If you try it, sometimes you can lead to a paravalvular leak. So initially, do not try into small aortic root. Avoid in severe AR, small aortic root tendered conversion to full sternotomy, or sometimes cutting the sternum is approximately 2%. Patient evaluation. Height, weight we need for the cannula, which cannula we need to go for, whether the patient heart is displaced to long heart and all those things. Chest deformity, pectus excavate, ankylosing spondylitis, previous surgery, previous trauma, all the muscularity, too muscular a patient. Narrow intercostal space. In those narrow intercostal space, sometimes we need to cut two ribs. So you need to disconnect two costal cartilage. I will tell you later on why. What are they? How to evaluate these patients? X-ray chest. Basic, you can relate the aortic valve position to intercostal space, but it is better to go for a CT scan to actually find out where is the aortic valve according to the intercostal space. ECG, if patient has a bundle branch block, then you can, if you're performing a sutureless valve, then there are chances that patient can need a permanent pacemaker later on. I'm not going to tell you detail. We need to look up all the things: ascending aorta, dilatation, root, calcification, septal hypertrophy, all those things, ventricular function. And sometimes it is not to perform a minimal invasive aortic valve replacement, especially through right anterior thoracotomy. If the LV function, if you do something to your myocardial protection, then the heart will suffer the burn and you will not have a good outcome. So this is the X-ray. You need to think that imaginary veil will be a aortic valve. If there is a calcification on the X-ray, you can pick up the calcification, you can find out. And by the location of that calcification, you can draw image of second space, which is more convenient for you to reach to the root of aorta so that you can easily hand sew in your suture. Now we have a corner, but if I'm talking about hand sew in your suture. Coronary angio is almost required for all the patients, especially who are more than 50 years of age, to see the coronary. And whereas Mark Ruel has told us in Innovation, it is published in 2019 that there's no CT evaluation is required for right anterior thoracotomy aortic valve replacement. But my experience, or I will suggest you, all of you, always go for CT, plain CT at least, and forward distance from the ascending aorta to sternum should be less than 10 centimeters, and alpha angle should be or equal to 45 degrees. Because if your angle is too acute or too obtuse, it will going to give you a very, very difficult approach. It will be almost difficult to expose the right coronary cusp. If you go for a straight aorta, means alpha angle is going towards upward, means maybe 60 or 65. Or if you go to a more horizontal aorta, then again it is very, very difficult, right commissures or sometime onto the left coronary cusp upward. So these are the important things, and stuck to these parameters, you will have a very good result. See, this is a typical classification of type of aorta for right anterior thoracotomy. Type A, 1A is almost onto the right, less than 10 centimeter valve replacement, you will have no problem. Type 2B means patient aorta is towards the right side, but approximately 40% is below the sternum. In this, the technique is you need to take lot of sutures. And one more technique is that rather than clip the internal mammary artery and cut a part of the sternum in a U shape, so that if you cut a part of the sternum on the U shape, you can easily reach to the right coronary cusp. This is the technique which you can go for type 1B, but do not recommend you not to go for it. So how to do the procedure? Second or third intercostal space, after assessing through your CT scan or X-ray, where is the aortic valve lying? One more important thing. It is almost important if you're going through third intercostal space, you are sure that your aortic root is here, and you will see that your aortic root in the space. And after cutting if you're opening the third space, cut the upper one costal cartilage. If you're opening the second space, cut the lower costal cartilage. And if you're cutting the upper costal cartilage, sometimes what you feel, it is very difficult to clamp the aorta upward because the aorta accesses the aorta upward. So you will see that I can reach to the aortic root, but how to put a clamp or how to give a plegia. So for that, but it will happen rarely, maybe in 5% patients. For that, do not hesitate to disconnect one more intercostal space upward, not downward, upward. Clamp very easily. And it is important so that your ascending aorta is completely in your field. Whenever you start your right anterior thoracotomy as a first case, you will always see that how can you, I do the procedure. I can see only aorta, go on pump. When you go on pump, you will see the right atrium, you will see pulmonary vein, you will see only aorta. How can I do aortic valve replacement through this? You do a femoral cannulation, go on pump, you will see everything. Exposure, single lung anesthesia is important. Soft to retractor, I say must, or it is important at least. Multiple stage sutures, they are good. You can take multiple stage sutures from the pericardium, first these sutures and pull them through a stab incision, small stab incision through the chest wall. There is an important thing. Sometimes there's a large right atrial appendage, which is covering almost all the ascending aorta. And when you go, even if you go on pump, the right atrium is still lying onto the root. It's very difficult, and it will keep coming into suture. And take a small stab incision and pull this bursting through the chest wall. It will not come into your field, and you will have a very nice exposure of aortic root. Cannulation, I will recommend to go for a groin cannulation. Some of the cases you can see on YouTube, people have done through the central cannulation, but my recommendation is that it is good in that. It is always better to go for a femoral cannulation or groin cannulation. Venous cannula should be 2-stage. Very good venous cannulas are available now, one from Sorin, from Medtronic. And what is the trick? Always place your wire into the superior vena cava. If you are using a Medtronic cannula is inside, maybe your cannula is into the right atrium. So what is the technique is that you pull your stellate little down and push your cannula up. Otherwise, your cannula will remain in right atrium. It will not go into the SVC. Separate SVC cannula. Sometimes it is difficult to put your 2-stage cannula. It will not reach you during the operation. Do not panic. Just put a small right angle cannula into the superior vena cava. Always be ready with a Y and connect it to the pump. You will not have any problem. Superior vena cava cannulation, myocardial protection. Flexible aortic clamps are very good. They are advisable, but if you have a straight, that's why I'm saying start your cases with pure aortic stenosis, give a direct root plegia and remove this cannula. So it will not come into your field. You can reinsert it later on. And if you have a doubt about your aortic cardioplegia, then always after you have put in aortic stage, you can see your coronary, always give a coronary. There is no harm in giving some more additional cardioplegia through the coronary. Right superior pulmonary vein bursting is the similar, but what you need to have, what I do is I use a malleable retractor, a small malleable retractor, which assistant pull it superior vena cava towards him or her, then you malleable, little rigid aortic root, right superior pulmonary vein vent. One more trick. Some people want to always have a tendency to put this right superior pulmonary vein vent through the mitral valve into the LV. Now you are not sure where it's going. So don't push it hard. If it's going, it's okay. If it's not going, do not keep pushing de-airing. And whenever you have completed your procedure, always remember that you need to reinsert your aortic root cannula for proper de-airing. Very, very important to remember that you can put your pacing wires only before the aortic cross clamp is removed. I will tell you later on and how to close it. Closure can be done either by wire or by wire thing. After some time, patient will come and it usually pricks to the patient. Sutures, they do not give Vicryl or whatever if you want you take. They do not give a very stable joint, which the costal cartilage you cut. So it will keep moving. Or sometimes if your soft tissue is not properly approximated, they bulge onto the anterior chest wall. So what I experienced, it's a little expensive. Always put plate. It can cost about 12,000, 15,000 rupees more. Put plate, 2 screws, and important. If you are cutting 2 costal cartilage, then it is always important to fix patient will not complain of pain. There will not be any movement. Let's see what is the statistics said by right anterior thoracotomy. So ICU stay is definitely less. Hospital stay is definitely less. Wound infection is definitely less. But the rest of the complications are full stenotomy or mini right anterior thoracotomy AVR. There is another study which has compared the right mini thoracotomy AVR, and their findings suggested that right mini thoracotomy AVR is safe, feasible with all prostheses and sizes, but it increases the operative time. On the contrary, it reduces your cost value. In hospital, outcomes are comparable with full stenotomy. So what we are giving more and more are more of a cosmosis and more of a patient satisfaction, less of pain or blood loss. That's it. One more meta-analysis. So if you combine all the meta-analysis of mini AVR, so early mortality is similar, post-operative stroke, acute renal failure, or myocardial fibrillation, and more in conventional AVR. Cross-claim time, but probably it is because the conventional AVR, you're taking all the risk patients, high risk, low risk, intermediate risk, which it is not been removed in these meta-analysis. CPP time and cross-claim time is longer in mini AVR. ICU and hospital stay and ventilation is lower in mini AVR. Comparison of all the three, upper partial surgery, full snort AVR. So CPP time and aortic cross-claim time was lowest in mini thoracotomy, means upper partial snort. With the ST score, if you compare, if ST score we see that the best is conventional AVR. Adding to suture as well to mini aortic valve replacement have some impact. We all know that if we increase 1 minute of cross-claim time, CV morbidity, not mortality, morbidity increase by 1.4%, especially in patients who are more than 70 years of age. And so there is a propensity mass trial passed equally in patients who are more than 8 years of age, adding perceval sutureless valve, decreased operative time, lower post-operative strokes, early extubation, and shorter hospital stay. Again, another study which is using an Edward intuitive valve, reduced cross-claim time, low mean gradient, low patient perspective mismatch, and increased pacemaker implantation. So if you combine a sutureless valve through right anterior thoracotomy, what we are giving? A direct visualization, annular debridement, shorter cross-claim time, fast a limit of surgical AVR and tower. So that's why it is recommended for some of your candidates which can offer, you can offer a sutureless valve. So I conclude is standard surgical AVR is the excellent procedure and keep doing it for most of your patients. Mini AVR is safe and effective, especially for score. It's not going to increase surgical risk. Right anterior thoracotomy gives better patient satisfaction as compared to partial snort. Initially, select your patient very cautiously. Adding sutureless is effective to facilitate mini AVR in difficult situations, a small aortic group and calcified aortic group. Let me show you a small video. Important is do not dissect the femoral groin vessels. Do not put a tape and all those things. It's not required. A small incision, 5 to 6 centimeter incision. This incision in second intercostal space. This gentleman was more than 80 or very. Otherwise, you can cut it by the Caesar also. Intermammary artery have been clipped. Expose the pericardium. Standard. You can see the pericardial stay sutures. You can taking out through small steps incision through the pericardium, through the chest wall. Groin cannulation. Always check that your wire is in the superior vein cava, as I told you, as you can see. As I was telling you, sometimes the right, this RA appendage is very bulky. It is coming away. You put the suture and pull it to the chest wall. It will not retractor is shifting the SVC and you are putting a cannula into the superior pulmonary vein, cross clamp by a flexible clamp. Now you expose the aorta, put your stay suture as you used to do in conventional, or if you do not want to put, don't put it. Decalcify the valve. You need to take long seizures. It was very easy. Minimal invasive seizures were not working well. Always check that a small calcium is left. We are taking a guiding suture for the sutureless valve. 3 guiding sutures in 3 commissurer, collecting the perceval sutureless valve. Passing the perceval sutureless valve, guiding suture through the 3 knobs which are given onto the valve. Put a traction onto these and glide your valve into the aorta. You can see through my telescope now that the valve is going into the aorta. Check that the valve is fitted nicely to the aortic annulus. Now unload the valve. You can see that now knob is out and we are removing the last clip. The valve is deployed. Now inflate the balloon for 2 minutes at 4 millimeter of mercury. Put some cold water, warm water. Keep it for 30 seconds. Now check the valve. Valve is functioning well and close the aorta as usual. Reinsert the aortic root. Remove the pulmonary vein cannula and now your heart is beating well. Not much of bleeding. Aortic root vent has been removed and you can see the heart is contracting well. Small incision and a very single digit gradient. You can see how nicely aortic valve is functioning. Thank you very much. I think I finished in time or not?
Yeah, you have finished well in time, sir. Thank you so much. And I think it's really, last time I have seen without the sutureless valve, this time I have seen with the sutureless valve. So as we see a lot of operating videos from your side, we learn more and more things. So precious time from your, I know you have a very busy schedule down there. And I would like to request you to please stick to us for some more time, because there are a lot of questions will be asked to you at the end of the webinar. So I request.
Yeah, I'll repeat. I will go for one because election is going on here in Jaipur. So I'll go for a voting and I'll be back in half an hour.
Okay.
Yeah. Okay.
I'm requesting with Dr. Ajeet Bana, sir. Sir, please stop the screen sharing, sir.
Okay, I will.
Okay, let's start with our next presentation with Professor Vivek Pillai from Sree Chitra Institute of Medical Sciences, Trivandrum. So, Dr. Pillai presently is an additional professor at Sree Chitra Cardiothoracic and Vascular Surgery Department. Thank you.
Rizvi, can you hear me?
Yeah, I can hear you and see you also.
Yeah, but then my presentation, it is not, I may have to leave and come back just to get my presentation for screen sharing.
Yeah,
just
we'll be able to. Dr. Manish, you are ready with your presentation, isn't it?
Yeah.
Okay. So we'll try to wind up Dr. Vivek very fast and give some more space if possible. Yeah, Vivek, yes, you can see it.
Yeah, okay. Thank you, Rizvi, for the opportunity to do this presentation, and also the MAX team. Dr. Bana and Dr. Rajneesh about aortic valve replacement and different fancy approaches. I think I will speak about a problem that some of us may face at various times. I would like to thank my colleagues for helping me with the presentation. And a brief outline of this presentation: what is the available data on patient process mismatch, then what are the surgical techniques that we can employ for managing a small root, then what is the published data on the annular enlargement techniques. Since our video was not so good, I've taken a video from CTS-net on the next procedure, and then we'll just have a slide down our experience. Aortic root tension, and it is attached 45% to the interventricular septal muscle and 55% to the fibrous annular continuity of the mitral valve. It is related to the conduction system as well as the coronary arteries. All these, the aortic root extends from the ventricular aortic junction through the sinus valsalva to the sinotubular junction. So when you take LV outflow obstructions as a group, basically it can either be a subvalvar due to muscular hypertrophy, or valvar due to annulus in a small annulus, or a supravalvar, the area around the sinotubular junction is affected. Some important anatomy, that is the various structures that might get involved when we enlarge the root. Posteriorly, we have the mitral valve and the annulus, the fibrous trigones, then the coronary arteries also. During the opening of the aorta, you have to be careful about the right coronary generally. And then if you're attempting to do a Ross procedure, we'll have to be lies behind the posterior leaf of the pulmonary valve. Then what is a small aortic root? Cone has defined it in absolute terms as anything less than 25 millimeters. And it is important because, unless you give a very good orifice, our overall goal of aortic root replacement so as to reduce the symptoms might not be achieved. To define when we have an undersized prosthesis placed across the aortic root, so that the cross-sectional area will be less than the patient's own valve. There is increased gradients during exercise, and peak gradients might be usually more than 30 millimeters at rest. That is usually measured by echocardiography of the prosthesis using continuity equation, and it is the multiplication of the cross-sectional area into the velocity time integral across the LVOT divided by the velocity time integral across the aortic valve. And because different processes and different patients, we need to have a standardized value. So it is usually we take the indexed effective orifice area, that is indexed to the body mass, body surface area. There are certain fallacies because it's sometimes the effective orifice area calculation is operator dependent. So there can be technical difficulties with measurements and pathological healing of various types of valves. All these, might not give us an accurate value. Like an earlier presenter had said, we might be able to use a multi-gated CT, or in future that can probably define available to us. So the original paper by Rheumatic came out in 76 that showed that first defined PPM as a problem when the effective orifice area is too small in relation to the patient's body surface area, and there is a mismatch leading to a reduced cardiac output. Come up with reference values of indexed effective orifice areas of less than 0.8 centimeters square per meter square body surface area as a threshold for defining PPM, and less than 0.6 centimeters square per meter square as a severe patient prosthesis mismatch. People further went ahead, and then he had produced the worse hemodynamic function and less regression of the left ventricular hypertrophy after the valve replacement procedure, leading to more cardiac events and lower survival. He also measured the importance, that is with regard to compared them patients with moderate and severe, and found that it was significantly higher in patients with a significant patient prosthesis mismatch. This is a paper that we had come out with Chitra last year, Iqbal, and that we found that LV regression was significantly higher in patients with the indexed area more than 0.75. Studies that I could come across that they have studied AVR with the bioprocesses, then with root enlargement procedures, and even with very small 17 size valves. Most of them studied short-term and long-term outcomes. Short-term outcomes, they showed a statistically significant difference in 30-day mortality between the group. However, if you see long-term outcomes, there are no statistically significant differences in long-term mortality or overall survival, even if you have residual PPM. One of these studies, however, showed that there is a residual ventricular hypertrophy and patient prosthesis mismatch than when compared with patients with the residual hypertrophy but without PPM. All the papers have come, and the European group led by Peter Kapitein has come up with a consensus that they recommend that long-term outcomes of AVR, whenever possible, we should try to attempt procedures that reduce PPM, and they have found that there is an all-cause and cardiac-related mortality over long-term follow-up in patients with PPM. Now we will come to what are the surgical options that are generally available. There are quite a few, and graft or a Ross operation or the standard xenograft. But these are not generally available in all situations because of the lack of homograft program and surgical training for these specialized operations. We can, however, attempt a mechanical root replacement like a Bendal, but problem is all mechanical valves generally we are hoping for. The easier and the real world solution that most of us do is the annular enlargement procedures. The posterior enlargement as the anterior enlargement. Relatively simple. First, we'll just move on to the homograft subcoronary implant, most frequently used 57%. And even though it's a procedure that studies have proven that it does not increase the operative risk. But the disadvantage of homograft is the gradual structural deterioration that occurs, and studies have proven 70% reoperation at 20 years. And there are certain contraindications as well, especially in young patients less than 20 years of age. Corner operation, it's very good when you have to, there is an element of subvalvular involvement as well, like this aortoventriculoplasty. Here also, they require the pulmonary autograft and a homograph. You should have a live homograph program in your department to get this procedure going. Stainless processes as well, even though studies have proven that they increase operative times, they have yielded in better results and improved LV function even in patients with small roots and LV dysfunction. Usually annular narrowing is not an isolated problem, so we tend to have some element of subaortic narrowing as well. So myectomy is a procedure for a myectomy. I think Dr. Ravi Verma will speak more when he speaks about HOCM. He will speak about the techniques of myectomy. What we generally follow and what most people do when facing a situation, which is a rather simple solution, is either the anterior or the posterior approach. The anterior, you have the Conor-Aston operation, and the posterior is the next. Not very difficult to perform since you have a good ventricular outflow exposure. You can do the myectomy and you can sufficiently enlarge your root, and you can safely and without bleeding reconstruct without any problem to the adjacent structure, which is the next when you go through the center of the NCC and right up to the level of the annulus, or you can the Nunes procedure where we go between the non-coronary and the left coronary and stop short of the belly of the AML. And if you want to increase it further, you can go travel a little bit more of the AML. This is the general technique that most of us follow. A transverse aortotomy, and the lower end is extended into the middle of the non-coronary cusp. A patch, which can either be a native pericardium or a bovine pericardium, or otherwise what we use is the elbow graft. A piece of it is cut out, and then the lower end of the patch on either side of the aorta, and then the sutures along the native annulus is taken like we generally do, and then sutures are taken outside in from the graft. The region of the graft, and then we close the rest of the aorta. See this very clear. Menugian technique. Both the Nix and the Nunes procedures we do, we will usually do not open the lobe of the left atrium, so it can be teased off the aortic root. So nothing needs to be done there. But in Menugian, generally we open the root of the. We will require two patches, one for closing that left atrial patch, and the next for the for widening the aorta. The other operation, and if you compare the amount, the length of the annulus that we can actually enlarge the posterior, it is kind of limited 2 or 3 millimeters, maybe around 6 and 7 millimeters. So in cases we have very narrow root, or in cases when you have to attempt a DVR along with it is just a mitral valve replacement also along with kinetic valve, or in reoperations, the Conor-Aston operation is a very good choice. Here the aortotomy is made vertical, and then we go between the right coronary and the left coronary. When you cut, when you reach, you just have to be careful. Once you open, make a small aortotomy, and then look for the orifice of the RC left of that, and then proceed towards the annulus. Then you stop there, and then then we have to take a find out where the pulmonary annulus is, which is seen generally posteriorly and above, higher than the aortic annulus. Make sure you do not injure the pulmonary annulus, and make a small vertical RVOT incision along the direction of primary incision, and then you extend it right up to where it meets the annulus. Then you will see the ventricular septum joining there. Then we'll have to make a ventricular septotomy. Then that is also continued along the line of the primary incision as well, and just be lateral to the more lateral to the septum, because medially you will have the papillary muscle of the tricuspid valve, may have some conduction tissue around that, as well as septal branches of the LADs. So you don't injure all that. So just keep slightly laterally. And then when close the first, you initiate a rhomboid shaped patch. One end of the patch is sutured to the lower end of the interventricular septum, bring it up to the region of the annulus. Once you have reached the annulus, you need a second patch to close the RVOT. And this patch, the base of the patch, is generally triangular. It is base is sandwiched between your valve sutures and the initial patch. Then you take the irregular valve switches like you gently the aortotomy using the initial rhomboid patch and the RVOT with the second triangular shaped patch. The point of concern is where these three patches meet the septum and the RVOT. Take narrow bites there. Otherwise, sometimes in our initial cases we did have some problem bleeding from that area. But then with the presence of the fibrin glue, nowadays bleeding is not much of a problem. This is another technique. Theoretically, we have not performed the two-directional enlargement, where they say the aortic annulus can be enlarged up to 68%. When all else fails in patients with a diffusely thick aortic septum or a very small LV, and another option will be a Tyagi because it's a very low profile valve. It can gives generally single-digit gradient. That too is something that we can attempt in a small group. Now we move on to what are the results that are published. This is the Mayo Clinic group that are in the posterior root enlargement. Though the raw operative mortality initially should seem to be high, but on multivariate analysis found that the aortic root enlargement per se is not an independent risk factor for an operative death. This is generally more often required in higher risk patients. Similarly, this is from Tyrone David. Here, patients who are more likely to undergo are females and have had previous cardiac surgery, comorbid conditions, as well as worse NIHA class. This is the Mark Well article that showed that it is associated with reduced postoperative gradients, and but it does not improve long-term survival. And prosthesis across the valve, and then I think contextually in the study had proven that for every 1 degree increase in gradient, around 1.03% increase in heart failure is there in long term. This is another study from Manuel Antunes that showed that bioprosthesis in patients who had underwent aortic root enlargement. This is more important because valve in valve can be subsequently done later. And then another interesting part of the study was when you compared the long-term survival of patients with aortic root enlargement and an AV, it is comparable to that of aortic valve replacement. This is from Virginia Gaurav. So he had shown that because of the aortic enlargement was employed, they were able to do a larger instances of valve in valve procedures later on. Now, if we were to think that it is that this procedure might be risky, we have shown that there is no differences in operative mortality or morbidity even in patients who are octogenarians. This is another Japanese study showing similar results. This is a small video that I've taken up from the CTS net. It's almost like how we do the procedure. After the transverse aortotomy, the incision is extended. Is dissected out of the root so that no injury is made there. Then pericardial, this is a bovine pericardial pass I've taken, and that is sutured to the lower end of the incision. After that, the patch it's carried on along the sides of your aorta on either side, and then once you have traveled around 1 centimeters from your lower end, regular valve sutures can be taken. Those along the patch have to be taken from outside the patch. Unless the sutures are taken like we generally do from the LV to the aorta. The sutures are taken from outside the aorta into the close. Sutures needs to be very close. And even the transitional area, they have taken sutures from outside the aorta onto the patch. Valve is sized and seated. Aortotomy is closed. Two things to look forward in post-operative scenario that we have faced is one is the bleeding, which now usually doesn't occur because of the availability of the fibrin glue, and some patients we have had some instances of coronary artery obstruction due to a valve stent or a swing, where we had to go back and put grafts mostly to the right coronary. This, before I conclude, this is our experience. This is from, I think, 10 years data. We have had 25 cases and predominantly females. Mean age is 37, follow-up from 2 years now. We have most of the patients that live on diet, 3 of them are in functional class 1. We had posterior enlargement was done in the larger number of patients, followed by the coronary stent. And most of the patients, there's one patient with a residual gradient, but since I think he's not functionally debilitated, we have not reoperated on him. And if you see, we have been able to substantially increase the aortic root annulus in these patients. Problem and tailor-made solutions are required. Base your decisions on choosing the type of procedure and device by factoring elements like pathology of the aortic valve, the age, the PSA, patient's lifestyle. Though there are no clear objective data to suggest the exact indications and that they do not prolong an overall long-term survival, it is definitely a safe operation with providing better quality of life with lower gradients, and the benefits of the surgery outweigh the risk. Thank you.
Thank you, Dr. Vivek. I think that's a wonderful presentation, and I was really looking forward to see your experience. I think it's indeed a good number of cases that you have done in Sree Chitra. There are a few questions which at the end of the presentation. There are so many questions. I don't know. I think how can I ask so many questions to so many people at the end? But yes, we have got a lot of questions. But thank you so much. It's extremely well on time. You did in 19 minutes and few seconds.
Thank
you
you
so much. That's the best part of it.
Yeah, sure.
So with this, I would like to introduce our next speaker, Dr. Manish Agarwal. He is the key person of our TAVR program in Max Hospital, Patparganj. So Dr. Manish is an interventional cardiologist who takes interest in a lot of complex primary angioplasties and non-regular angioplasties. And he's got structural heart valve fellowship at Gottsagen Georgi Hungarian Institute of Cardiology at Budapest, which is a world-renowned center for TAVR in European and world perspective. So with this very small and formal introduction, I would like to request Dr. Manish to start his presentation. Manish is associated with us since last 1.5 years. Dr. Manish, to you, please. Thanks.
Thank you so much, Dr. Rizvi, for the introduction, for the kind introduction. And I would just like to reconfirm with you, are my slides visible? I'll try to. So first of all, my salutations to all my esteemed colleagues who are doing seminal work in the field of cardiothoracic surgery and interventional cardiology. I would also like to thank Dr. Rizvi for conceiving this platform, the Max Heart Valve. It has been an engrossing 2.5 hour session where I've been hearing to all the presentations of my previous speakers, and they were excellent presentations. And in my case, I shall be giving a very brief introduction of TAVR and its evolution. And in the later half of my presentation, evidences in favor of TAVR, especially in the intermediate and low risk group. The data or evidences for the low risk group is one of the prevailing or most discussed topic in with this brief overview. I'll start my presentation. We all know that aortic stenosis is a life-threatening condition and progresses very rapidly. And survival after onset of symptoms is intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. In fact, surgical AVR has been the gold standard for treatment of severe aortic stenosis for the last 40 years. This is just as even mild symptoms develop, the prognosis starts dropping. The prevalence of severe AS keeps increasing with age, and it keeps increasing, and in octogenarians it is of the order of 9.8, and as age increases the disease accelerates and leads to severe AS in the forthcoming future. So survival in AS is dismal with medical therapy, and as of now, so for the last 40 years, AVR has been the gold standard for treatment. Or frailty issues has had a very dismal prognostication for the patient with hardly 20% survival at 5 years. So what is the need for this new technology of TAVI has been the gold standard and has given us such excellent results over such a long period of time. The need for TAVI was felt when about 1/3 of the patients of severe aortic stenosis were deemed unsuitable for surgery and go on and die within 2 years for lack of undergoing an AVR. Acquired AS with the increasing population, with increasing elderly population, with increasing longevity, with increasing lifespan, acquired along with it, there are associated multiple comorbidities, which sometimes makes it difficult for or a high risk case, a very high risk case for AVR. Many of the patients themselves would be scared and reluctant after many would prefer a minimally invasive technique, and that gave birth to, these were the above conditions which gave birth to TAVI or TAVR as an alternative modality to the AVR, which is the gold standard of treatment. So this is just a brief options. In the coming few slides, I'll be focusing more on only two systems, the Medtronic self-expanding system and the Edwards balloon expandable system, the platform for TAVR to be introduced. These are the two valves on which all the trials have been conducted, first in the high risk and inoperable risk group, then in the intermediate risk group, and then in the low risk group. So these are the two valves for TAVR to be used as a primary modality of treatment for severe aortic stenosis now. So coming to the first system, which is the Edwards SAPIEN valve system, which is a balloon expandable system model of which was used in humans in TAVI, and it was approved in Europe in 2007 and in USA in 2011. It has a balloon expandable stainless steel. The system was usually crimped onto a balloon catheter to use it. The 23 mm valve, which was adequate for an 18 to 22 millimeter annulus, required a 22 French system and a minimum catheter system. While the 26 millimeter valve, which was adequate for a 21 to 25 millimeter aortic annulus, required a 24 French system. So with the issues with this early generation valves were that there were two. So now there has been an evolution in the Edwards SAPIEN valve. The newer generation, the next generation valve was the SAPIEN XT, which rather than having a stainless steel strength, it had a new leaflet geometry, which led to a better function, coaptation, and had a lower profile. The SAPIEN XT was available in 23, 26, and 29 millimeter, and the French, the catheter delivery system came down to a lower profile, and a 16 French sheath could be used rather than a 22 and 24 French system with the earlier generation, first generation SAPIEN valve. There's been a further evolution of the SAPIEN system, and now the present valve, which is used in Europe and America all over, is the SAPIEN 3 valve. It is a 14 French system, transcatheter system. It has this has been specially designed so as to prevent paravalvular leak, to minimize paravalvular leak, And now Sapien 3 is available in 4 sizes, the 20, 23, 26, and 29 mm to 28 mm. The second valve system is the self-expanding system. It's not a balloon expanding system. It's a self-expanding system. It is and has led the further research on this valve, and it has come out with new generation overvalving system, which I'll just explain. So the first, the core valve system is a tri-leaf mounted in a multi-level self-expanding nitinol frame. It has an upper third area which has a low radial force and sits in the ascending outer so as to orient the valve into the aortic root. The middle third or the waist lower third has a high radial strength which sits in the LVOT and has a skirt of pericardium that seals the system. Now the present valve system of the self-expanding valve of Medtronic which is used is the Evolute R, and the latest these valves, the Evolute R and Pro, are available in sizes of 23, 26, 29, and 34 millimeter, and they cover the whole range of the annulus from 18 to 30 mm. So there are certain requirements for each of these valves. What should be the adequate diameter of the sinus of Valsalva? What should be the height of the sinus of Valsalva? What should be the percentage of oversizing? These are all issues which are technical issues which will be discussed later. So the evidences and the preliminary evaluation of how to go about doing a TAVR. It is very important to note that TAVR requires a multidisciplinary heart valve team, and it's a class 1 indication. The cardiothoracic surgeons, the cardiovascular imaging specialists, the cardiac anesthetists, and the old paradigm of individually operating has long been gone and buried, where now surgeons and cardiologists are working as a team. And I am aware of many cardiologists and cardiothoracic surgeons teaming up in the country and as well as in outclips and all the other exciting transcatheter systems of which are evolving and which will soon be probably the modality of choice. There are a lot of patient selection considerations to choose whether to do a TAVI or to opt for a TAVR or a SAVR. These are the brief where the to be taken into account, like the frailty of the patient, the comorbid conditions, concomitant CAD. What is the STS predictive risk of mortality at the PROM stands for the predictive risk of mortality at 30 days, whether you can classify the patient into a low, intermediate, high, or a prohibitive risk, and of course the selection if a TAVR or a SAVR. A pre-TAVI workup would first of all require a clinical assessment, and clinical assessment would be in the form of the cardiologist and stabilizing the patient prior to doing any TAVR. Many times the patients may be decompensated and heart failure and may require CCU care, stabilization, and a bridging balloon aortic valve is considered at a later date. The coronary assessment in a pre-TAVI workup is essential. A coronary angiogram is essential, and any proximal lesions, like osteoproximal RCA, any proximal severe lesions or in the left main should be fixed up prior to doing a TAVR. And ideally, the gap between, there are a lot of operators who have now progressed to doing an angiogram on the day where to do an angiogram at least 15 to 20 days prior to the TAVR, do an angioplasty to fix up any proximal lesions, and that is how we would like to go about. The other important thing is to get a for assessment of TAVR. It is the multi-slice CT assessment of the annulus, which is going to help us in sizing of the valve. It is going to help us in valve selection. It is going to help us in assessing all the system. The CT sections would be a 0.5 millimeter slices right from the femoral artery up into the iliacs, up into the aorta, and up into the valves, and each section, and you get about the calcification and about the diameters of the vessels all along the transcatheter route, right from the femorals up into the aorta. So multi-slice CT has become the defining investigation to get a multi-slice CT. It is fed into a specific software known as the Trimensio, which helps us to analyze the CT scan further, and which is of a great advantage actually in especially the VTC, so that you don't end up with a coronary occlusion. So multi-slice CT is of paramount importance in evaluating the patient for a TAVR, suitability of TAVR. And relevant cardiac anatomies which should be considered would be to evaluate the left ventricular function, dimensions, any thrombus, the mitral valve, especially the presence of mitral regurgitation, or whether the patient is a post-MBR, associated post-MBR, the LVOT, any sigmoid septum, any small left ventricle or a hypertrophied septum. You need to assess the aortic anatomy, especially the bicuspid valve, which was initially a relative contraindication. TAVR in bicuspid aortic valves. In fact, there's a whole registry dedicated to bicuspid aortic valves called the Bahl registry.
5 minutes left.
A lot of
Dr. Manish?
There's been a lot of developments in the field of TAVR in bicuspid valves. There's been a lot of lot of registries which have elucidated very good results in contraindication to TAVR. The other relevant cardiac anatomy to be considered is the aortic size, angulation, the aortic calcification, whether there's a porcelain aorta, and about the most importantly, the coronary ostial height, which should ideally millimeter, would be susceptible to coronary obstruction, and you would need to probably go in for coronary protection measures with a catheter in the right coronary and with a stent inside the with a stent over the wire, just for a coronary protection in case you have a low coronary ostial height. Scan. Now coming to the important topic of building up the evidence for TAVR. So first and foremost was that since the aortic valve replacement, the surgical aortic valve replacement was the gold opportunity that transcatheter aortic valve system got was in surgical rejects, high risk cases or inoperable cases or surgical turn down cases. So before coming to that, Dr. Alan Cribier, he did this procedure in 2002. And I will now divide these evidences into two groups from 2002 to 2014, which I shall call it as the TAVR, I shall call it the TAVR present. So in 2002 to 2014, the balloon expandable system was the Edwards Sapiens valve. And this is the evolution of the Edwards Sapiens. You went to the Sapien XT and then you went into the Sapien 3. And this has been the evolution of Sapien 3. And Sapien 3 got approved for aortic and mitral valve procedures in 2017. Partner 3 trial, which was conducted in the low risk aortic valve cases. So as I was saying that the initial opportunity for TAVR was in high risk cases. Important, we have the partner trial, which was conducted in very high risk cases, inoperable cases of AVR, which were surgical turn downs, and the basic groups of AVR. And what we saw was that TAVR had in the partner 1 cohort B that the all cause patients without any treatment, and in the cohort A, in the partner 1 cohort A, we found that the TAVR had a similar all cause mortality with the surgical out. These cases of TAVR with the similar mortality with SAVR. While these cases in TAVR were done in very high-risk cases, inoperable cases with the STS 15. So these results were very impactful, and these created a platform for TAVR to be used in these high-risk groups. It was also found that the TAVR improved the quality to AVR in this respect in the partner 1A trial. The other system is the self-expanding system, which is the Medtronic system, and you can see here the evolution of the Medtronic system. And they initially started with the core valves, led to Evolute R, which was a fully repositionable, resheathable catheter system. And then the latest generation self-expanding valve is the Evolute Pro. And the Evolute Pro got its approval from the US FDA. It's available in 23, 26, and 29 millimeter sizes. The 34 millimeter valve is still the Evolute R valve, which had got its approval in October 2016 from the US FDA. So while partner 1 trial established the balloon or the Sapien XT valve in the high risk.
Dr. Manish, excuse me, Dr. Rizvi here.
Yeah.
Yeah. So you are only having about 1 or 2 minutes time left.
Only 1 or 2 minutes time left.
Yeah. Thank you.
Okay, so I'll quickly shift to the US pivotal risk trial, and the partner 1 trial established TAVR as a class 1A recommendation in prohibitive risk and a class 1A recommendation in high risk. A lot of lessons were learned from these initial trials. What were the peripheral system? We learned that annular measurement is not good enough through the 2D echo, and a CT assessment of the annulus was imperative for deciding the valves, as well as the height of the sinus, width of the sinus and tubular junction. We also learned that you require a continuous in-hospital rhythm monitoring for 40 to 72 hours with TPI backup, and all these led to decreasing morbidity and mortality. Now the TAVR present, there's been an evolution of the valves from the Krieger Edwards valve to the Sapien 3. This has led to a lot of reduction in the vascular complications with the evolution of the device, with the lower profile of the device, and led to a reduction in paravalvular leaks. As you can see, on the right hand side is the older generation Sapien XT, and on the left hand side is the Edwards Sapien 3 valve, the latest valve. And you can see that the 57 leak and 41.3% were with mild paravalvular leak, and only 1.3% had moderate paravalvular leak, with 0% cases of severe PVL. So what is the evidence for the intermediate risk group? Now, a group and operative risk group with the partner 1 trial and the core valve US pivotal trial. The partner 2 trial conducted by Dr. R.R. Makkar, Dr. Martin Leon, and Sushil Kodali, who are one of the pioneers in TAVR, established part equivalent to SAVR in the intermediate risk group. At 5 years, there was no significant difference in the incidence of death from any cause or disabling stroke between the TAVR and surgery group. Results were similar for the transfemoral access, and at 5 years, more patients in the repeat hospitalizations were though more frequent after TAVR rather than surgery. The concluding part of the partner 2 trial was that among patients with aortic stenosis who were at intermediate surgical risk, there was no difference in the incidence of death or disabling stroke at 5. Then the next the important trial was the Surtavi trial, which was again in the intermediate risk group. And again, the Surtavi trial concluded that it is a non-inferior alternative to surgery in patients with severe. Both these, the partner 2 trials and the Surtavi trial led to US FDA approval for the transcatheter heart valves to be used in the intermediate risk group. And this led to a revision of guidelines where with the first partner 2 trial group. However, with the Surtavi data, class 1 indication was given again in the intermediate surgical risk group. So the only at this stage, the only surgical AVR was the class 1 indication for TAVR. So what is the evidence for the low risk group? Now, these evidences for low risk group have come in the recent 1.5 years. The partner 3 trial was conducted by Dr. Mack. And again, the partner 3 led the Kaplan-Meier estimate of the rate of the primary composite endpoint at 1 year was significantly lower in the TAVR group than in the surgery group. 8.5% versus 15. This was in the low risk group. It has to be noted that this was in the low risk group, the partner 3 trial. So in conclusion, in the partner 3 trial, among patients with severe aortic stenosis at low risk, the rate of composite of death rather than with surgery. The low risk trial was the Evolute low risk trial conducted by Dr. Jeffrey Pompa, Dr. Didier Chechet, and Dr. Michael Reardon. Again, in this group, was in the surgical group, 8.6 versus 11.2, and had a larger effective orifice area of 2.3 centimeters square versus 2 centimeters square in the low risk group. So again, in patients with the low surgical risk, TAVR with respect to the composite endpoint of death or disabling stroke at 24 months. The third trial in the low surgical risk group, and which has the longest duration of follow-up, is the Notion trial. Again, the Notion trial, in any of the composite outcomes or any of its components, TAVR patients had larger prosthetic valve area with a lower trans-prosthetic gradient, which remained unchanged over time of over 5 years. These the follow of data comparing TAVR and SAVR in low-risk patients, which demonstrated no statistical difference for major clinical outcomes 5 years after TAVR with the self-expanding prosthesis compared to SAVR. So now FDA in August 2009, heart valve or TAVR systems to be conducted in low-risk patients, that is with an STS score of less than 4%. So in concluding, a heart team is concept is supreme. TAVR is now approved in the guidelines for intermediate and high-risk groups and FDA for the low-risk group. And minimalistic approach with conscious sedation is expedited recovery. Though trials are ongoing for long-term 10-year results, which will give better clarity of the durability of the valve, which is as the TAVR results in low-risk group, because low-risk group may be younger patients who require long-term data. That long-term data, 10-year data is lacking in the low-risk group. So as of now, surgical AVR still remains the gold standard also. These are the new TAVR devices. The upper left corner is the Lotus Edge. The upper middle one is the Accurate Neo. The upper right corner is the Portico of Abbott devices present. There are ongoing innovations of embolic protection devices to be used in the transcatheter aortic valve system to lessen the neurological events further, like the Edwards Emboli X filter, the Claret system. You have newer procedures for valve-in-valve TAVR cases, especially in patients having a small bioprosthetic valve with a label size of less than 21 millimeter, in order to minimize the patient prosthetic mismatch, which Dr. Vivek Pillai was just talking prior to. My patient prosthetic mismatch is usually more in valve sizes of 21 millimeter or less. So if you need to put a TAVR in a already a 21 millimeter valve or less, then you need to probably increase the space. Has been accomplished with the help of Atlas Gold non-compliant balloon. In which bench testing has been done, and it has been found that most of the valves could be fractured except for the Hancock 2 valve and the trifectas like Basilica have been evolved, which will prevent coronary obstruction in valve-in-valve TAVR, as the new TAVR valve can push the leaflets of the original bioprosthetic valve to block the coronary arteries, resulting in devastating consequences on the table. Hence, assessment of the VT or multi-slice CT and a Basilica can be done, in which an electrified guide wire is used to lacerate the leaflet, which then sprays and permits coronary flow, and you can safely go ahead and do a TAVR. To a tricuspid valve, it is called as the tricuspidization of the bicuspid valve by the electrified valve. So you cut the aortic valve and convert a bicuspid valve into a tricuspid valve so as to get suitable long-term results of TAVR and bicuspid alignment of the valve, so that future access to coronary arteries is not blocked. This assumes significant importance as US FDA approval has been given to the low-risk group patients, and TAVR will now be done in relatively younger patients who will require future access to the coronary. Continuing innovation to bring better valves for easy future access to coronaries. One example of the industry coming hand in hand with the doctors is, as Dr. Rajneesh Malhotra had showed, that the metallic bioprosthetic frame, the bioprosthetic frame is an experiment built for suitability of doing TAVR at a later stage. So these are exciting times in the field of structural heart disease, and I'm sorry for rushing through the slides, but time was of constraint. Otherwise, I could low risk group with more patients and with more detail. Thank you so much.
Thank you, Dr. Manish. That was really a good and a lot of detailed things were there. So there will be some questions at the end of this session and webinar. So quickly, I'll go through next presentation with Dr. Sanjay Theodore. And Sanjay has done his MBBS from CMC Valvotomy, MS in General Surgery from Stanley Medical College in Chennai, and MCS from Sree Chitra Children's Institute, and his fellowship at Royal Melbourne Hospital, Australia. The surgeon with 15 years experience with more than 4,000 cases to his name. I would.
And thank you, Rizvi, for having me on board. Surgical AVR in patients with severe left ventricular dysfunction. When a diagnosis of severe left ventricular function is made in a patient with aortic valve disease, this patient straightaway goes into a high risk. We need to ask ourselves some questions. Now, in this day and age of Tyagi, is there any role for surgical AVR in patients with severe LV dysfunction and aortic stenosis? Can surgical AVR be performed with acceptable mortality and good palliation? Palliation includes good functional recovery as well as prolongation of life. Should these patients be intervened at all? Is the natural history so bad that we need to intervene, or should we just leave them alone because anyway they're going to die? These are questions we need to ask ourselves before we go on and operate these patients. So the turn century Varadarajan et al. In the University of Loma Linda studied a large group of patients with stenosis. They concluded that the prognosis was grave and is worse with advanced stage LV dysfunction and renal failure. So you can see the survival rates, 18% at 10 years and 32% at 5 years. At the same time, the UK registry had a survival of if the patient had undergone aortic valve replacement. Tarantini and colleagues studied a group of patients who underwent AVR, who had severe aortic stenosis, but they also had severe LV dysfunction. And the patients who did not undergo an AVR, all of them died within 4 years. If they had an AVR, they survived up to 60 to 70% survived. The natural history is very poor in aortic stenosis with severe LV dysfunction, and all of these patients should be operated. Now, coming to aortic regurgitation, this is slightly different from aortic stenosis. From the time the aortic regurgitation is diagnosed and it becomes severe, it takes about 10 years for atrophy and dilatation of the ventricles, which balances out the wall stress, and the patient remains in a state of compensated failure for a long time. And many studies have proven that operating the asymptomatic patient during this compensated phase is not advantageous. And LV dysfunction sets in, then the downward spiral is extremely rapid. And at 3 years, all the patients are dead. So in aortic regurgitation, it becomes extremely important to time surgery. Now, we have another study by Rothenberger who compared AVR in both aortic. And you can see their 5-year survival rates are about 64 and 75%. If you think back on the Varadarajan paper, the patients with aortic stenosis, even with good LV function, had only a 30% survival. Again, Rothenberger found that the functional improvement is class 3, and after surgery, most of them went to class 2 and class 3, and even some of them went to class 1. And they also found that the left ventricular function improves in both these groups, and the improvement is about 15 to 20%. So that is a significant improvement, and this improvement in the survival of the patient. So from all these studies, I picked up a few risk factors which will influence the long-term outcome in these patients. One is advanced stage as expected, female sex emergency procedure, advanced renal, or about 25% of these patients required a coronary artery bypass surgery. And all of these patients were also included into the study group because you really can't separate coronary artery disease and aortic stenosis because both of them have similar risk factors. Now, it is in aortic stenosis, if the end systolic volumes are high, and in aortic regurgitation patients, if the preoperative contractility was poor as measured by stress echocardiography, or if the LV mass index was more than 185 grams per meter. Important to remember here that if the patient has triple vessel disease and aortic valve disease, the risk is not increased at all compared to patients who already had a myocardial infarction. The patients who had a myocardial infarctions have a poor prognosis. So, LV recovery, and they found that most of the patients with AS had maximum recovery at 2 years and AR slightly later at 4 years. Patients with aortic stenosis have less recovery if the endostolic diameter preoperatively is more than 55 millimeters, or if there's patient prosthesis mismatch, or if there's a low gradient AR. Yes, it's not optimal. In AR, if the patient was in class 4, or if the left ventricular mass index was extremely high, then the recovery was delayed. Now, as surgeons, we can do a lot to improve the results of these tough patients. So, myocardial, I think before we go into that, I think I should say that ventricular dysfunction should be operated on by experienced surgeons, because these patients do not give us a second chance. So the first time it has to be done properly and perfectly. Myocardial protection becomes extremely important. But again, this can be according to the convenience of the surgeon, but probably the ideal type where you give antegrade and retrograde. Surgical approach again should be to the convenience of the surgeon. If the surgeon is well versed in minimally invasive technique, it will be the good procedure to have these patients because there will be less surgical stress. Many of these patients will be old with multiple comorbidities, and reducing the surgical stress becomes important. Again, valve delivery, quick deployment. Only if the surgeon is comfortable using these valves should the patient be receiving these valves. Otherwise, just go ahead with your standard practice and do a good, proper job. Now, decalcification of the aorta is such a two cardioplegias to debride the annulus, but there are other surgeons who could do equally good job 5 to 10 minutes. So you need to work on that technique and come up with a good technique where you can shorten the clamp time as well as do a good job on debriding the annulus. I have used one of the things which I learned this, and in nearly all the cases, 5 to 10 minutes, the entire valve can be removed in toto, however calcified it is. Anyway, that depends on your learning curve. We need to practice on a good technique to do that properly. Now it becomes important, like the previous situation, SAVR finds itself in this high risk population. So I think it was a couple of years back, Turani et al. Presented a large group of patients who underwent SAVR and TAV. The thing was, he found no difference. So even in aortic valve disease with severe dysfunction, there was no difference in early outcomes. TAVR obviously had a shorter ICU and hospital stay. But this again is similar to both the partner 1 and 2 trials, where it was just a non-inferior patients as good as TAVR and can be performed safely. So you can see the long-term outcomes also are not very different. It is very similar. Both the curves are statistically not significant even at 4 or 5 years. And with the E of 25 also, there is a good survival of these patients to long-term. Speaking about TAVI and how the evidence is good and it's supporting the use of TAVI, we need to study this more carefully, especially the partner 3 outcomes. At 1 year, this was probably the first trial which said TAVI was superior to surgery. So they claimed that there was a big difference in the primary endpoints of death and severity here. But as you can see at 2 years, which was reported about 3 or 4 months back, you can see the curves are converging. And the interesting thing is between year 1 and year 2, there were more strokes and mortality in the TAVR group compared to the surgical group, the valve thrombosis events. Now, these thrombosis is not massive. It's not like having a stuck valve, but you have one of the leaflets which do not move. And we all know that in a tissue valve, even if one leaflet does not move properly, calcification and early structural valve degeneration. So those 2 curves, I expect them to cross another 2 or 3 years and diverge after that. Now, as a surgeon, we should have a certain limit to which we are adventurous, even in this group of patients. Porcelain aorta, absolute porcelain aorta, which could not be cut into. Many patients have patchy calcification with epicardial ultrasound as well as palpation. You can find an area which is not calcified and go ahead and do a safe operation. Thoracic irradiation, uncommon. I have not seen a case becomes a contraindication because the patient is more likely to die of hepatic and renal failure rather than cardiac failure. Life expectancy less than 1 year, especially if it's incurable cancer. Previous CABG with functioning grafts is again a relative contraindication simply because for TAVI, probably it's easier done. Frailty, as my previous speaker mentioned, it's extremely important. I have found it very good to prognosticate patients. If the patient, it's easy to do bedside, check the patient's grip. If it's a good grip in an elderly, walk 4 meters in 1.5 seconds. And if they're well balanced when walking, they do well. Previous history of MI, again, it's a relative contraindication. They do not have a complete recovery of the myocardium, and the long-term prognosis is not as good as other patients without an MI. I have done about revisitation and LV dysfunction. I did not find any difference in the hospital stay or ICU stay with requirement for ventilation. Everything was pretty much routine, except for one patient who died on the day before he went home. So in my without real problems, if they're managed well and we make sure that the surgical procedure is done properly. What is the relevance of surgical AVR in India? There are several major considerations here. And the main thing we need to remember is the age study from Bangalore, from Jayadav, where they studied about 3,000 patients. And the average age of patients with severe IS and severe AR was 46. So this is a huge difference compared to all the trials in the West, where most of the patients have been with aortic stenosis and aortic regurgitation are going to be more suitable for a mechanical valve. And 46 is pushing it for tissue valve. Now, again, if we reduce our threshold for doing tissue valves, say a good thing to go for. Suppose you do a TAVI and the second time the patient requires a surgical replacement rather than a valve in valve, the procedure becomes extremely difficult and the mortality rates and morbidity is extremely high for a surgical procedure in a TAVI patient. On the age 55, he can always go in for a TAVI at the age of 65 if required, which is much more safe for the patients. Cost-benefit ratio in India, 95% of the patients in India will not be able to afford a TAVI. Many of the TAVI complications are either lethal or they add significantly to the procedural cost. One is the TAVI and TAVI for significant parallel leak, then the significant heart blocks which are produced and requirement for dual chamber pacing. Again, it will drive up the cost of the procedures. So as of now in India, and safely in patients with severe left ventricular dysfunction, and in the foreseeable near future, I think surgery will remain the gold standard in most of the patients with aortic valve disease and severe left ventricular dysfunction in India. Thank you.
Thank you, Sanjay. That's a very nice presentation, and the closing remarks were very, very practical indeed. So I'll come back to you on that. There are a few things which I don't agree and few things which I agree. So we'll just discuss all those things and all those points. So it is my turn now to present you one slide and one presentation. So I'd like to start my presentation. So I'm Dr. Rizvi. I'm the Associate Director of Cardiac Surgery at Max Hospital, Patna, and Organizing Secretary of this particular webinar. So I'll just... So Sanjay, you can... Thanks. So Abhishek, can you see the slides?
Yes, sir, we can see it.
Okay, thank you. So let's start my topic. So biological prosthesis in young patients. To straight to the point. So there are no financial disclosures on this topic. However, About India have helped us. So valve prosthesis in young population, usually all the replacements are guideline based, as we have seen in the whole day that most of the things are all guideline based. But rule of thumbs for our valve replacement, that's mechanical valve below the age of 60 to 65 years of age, and biological valves above the age of 65 years. So that's the rule of thumb. And if it is so, why? Use of biological valves in young. So number one area that valve replacement during pregnancy, that childbearing age needs the replacement of valves with biological valves. In the childbearing age group, also the same. Patients which are not tolerant to oral anticoagulants, patients' choice is very important. Remote location, especially in our country where iron monitoring may be quite challenging. Indian patients residing in remote locations like in hilly areas and all, where iron management is extremely difficult or impossible, biological valve can be a good option. Now, in selection of prosthesis, let's go very quickly through the slide. Here, if you see that there is important aspect, the desire of the patient. If the patient desires for a particular valve, and if you find that desire is reasonable. In favor of dry prosthesis, we can go for selection of the prosthesis models based on long durability, hemodynamic performance, implantability. All these things have been discussed in details in our webinar today. Prosthesis, as I said, is less than 50 years. In bioprosthesis, is more than 70 years. Definitely in mechanical prosthesis, increasing incidence of structural deterioration of bioprosthesis, lower risk of anticoagulation complications. Not going in details about this. In a nutshell, if the patient has got more age, go for a bioprosthesis. I would like to deter to that little bit. And if you see the difference of HA and ESC difference in Europeans, they have said this between 60 to 70, you can use both this. So in both, I would probably prefer the bioprosthetic one. Or doing like a debate that I would like to put more and more biological valves in my patient rather than mechanical valve, and I'll show why. So this paper, I would take a landmark and my reference. So this is a Mount Sinai group in 2018. And it's not a small paper, 11 patients from 1997 to 2006. It's a huge number with a long-term follow-up. And they have said the bioprosthetic valves have increased from 14 to 47% of aortic valve replacements in this particular period of time. So all the parameters and all other complications, which are morbid complications, not the mortality I'm coming to, the morbid complications, all are much lower in the bioprosthetic arm than the mechanical arm. However, one point that is always there in bioprosthetic valve, reoperation rate is extremely high in the biological valves. So the next represented incompletely, this finding suggests that in adult aged 18 to 50 years, bioprosthesis is a reasonable alternative to mechanical valves for aortic valve replacement. And I will go by this. If I get a chance, I would like to put a biological valve in a young patient because the problems with mechanical prosthesis can be catastrophic in the patient. Why this young group is important? Why this? Because they are usually the ones who are unable or unwilling to comply with the oral anticoagulants after a year. Age less than 55 years is one of the most important independent predictor of non-adherence to oral anticoagulants. If you see anticoagulant tablets, they're the young ones, not the older ones. Older ones always take their pills, their packets every time in their hand. Non-adherence to oral anticoagulants in young is not likely to be because of morbid conditions. It is mostly because of socioeconomic barrier to healthcare, childbearing, and most importantly, patient preference. One in young population and long-term access to healthcare may be very challenging. So we have to go with biological valve to deter these particular complications. Management of oral anticoagulants during pregnancy is also very challenging with reported mortality up to 5%. So importance of patient preference is very important in our practice. We must respect the patient's preference and desire. If the desire is non-reasonable, he's asking something very silly, we should not speak to him. But if a young guy from a very, very high level IT group, he says that he's very, very, kind of paranoid about the stroke being happening to him, about the bleeding episode being happening to him, I should respect that. So reporting of continued perceived disability is very important. With mechanical behavior, the sounds, the quality of mechanism, he always says it's a metallic valve. Disruption of work, career, income is an important factor. In North America, with mechanical prosthesis, that's what the Mount Sinai paper says, and fear of bleeding and stroke is always there. So basically, in a nutshell, biological valves would be preferable in young age. So basically, these are a fact group: the construction, overall height, the type of the preparation of the similar valve material, age at time of implant. Again, I'm saying the biological space is more in case of young patients than in the older. Smoking, overweight, patient prosthetic mismatch, persistent left ventricular hypertrophy, all these factors to be taken into consideration. These are some of the reports of different types of valves do wonders in long terms. But again, if you see the age is going down, the performance is also down. Similarly, Hancock, again, the Tyrone Davis paper in 2010. So these are different types of papers by different investigators at different times with different prostheses, where the longest term with the perimount valve at 20 years after the implantation of this device. So basically, what it's all saying, I'm not going into details about all these valves. All the valves are made to stay for a long time. But as a lot of people say, it's a genograft, it is made from porcine or bovine tissue. You will have some reactions, you will have some characteristic changes, failure. So these are the different types of avalanche valve, which is a good valve, and with a good hemodynamic. But all these valves are always seen better at the age group which is more than 65 or 60 years of age group. In India also we have come with a new product. This is also supposed to be a good valve, and it has its initial reports with the multi-center trial, which was shared by Dr. Devi Shetty, had a good results at almost 5.5 years end. So I think it is also a promising valve to come up with. So Dr. Rajneesh has detailed discussed about Resilia valve from. So I have got one more presentation by Dr. Manoj Kumar at the end of the session with pregnancy and heart valves, where we'll discuss about biological valve choices in young. But definitely biological valves in MVR in young people is already in practice. I don't have to tell and don't have to convince people. Widely used in women in the childbearing age group, and have now been included in the ESC guidelines, can then carry negligible risks. So this is the guideline where it is conducted that a bioprosthesis should be considered in young women contemplating pregnancy. That is the 2018 ESC guidelines. This is 2A. So I think this already has come. So I don't have to say that biological valves has no place in young people's experience of our center. A single center, single session experience, total biological year from 2013 to 2019. The age range was 34 to 89 years. These are different types of bioprosthesis which were used in different age groups. So if you see the trifecta has come up with the largest number, used trifecta. It is just so many things have probably come into picture, the cost, the patient choice, and so many things. Then that's why we use this valve. And if you see our numbers, 30 to 40 years, 5 valves, and 40 to 50 years. So overall, 30 to 60 years. So it's a huge number. So this is a follow-up of 3 years now. There's no report from structural heart disease in this group at 3 years. Close follow-up with 6-monthly echo. 3 monthly we do a telephonic interview. Mean pressure gradient we have seen between 9 to 12.5 millimeter of mercury. Almost all cases are done through MICS replacement. It's a very small cohort. I really agree with that, with a small follow-up. But as the numbers are going, especially the numbers, the echoes at 3 years, I am definitely sure that they are not going to change in the next 3 years also. So, but the early results are very promising. All patients are in normal 5 milligram per day. So basically, I would like to conclude immediately that there has been a significant shift in choice of heart valve prosthesis. Biological valves have been increasingly used in our practice. Patients' choice becoming an important factor in choosing a valve prosthesis. Due to surgery, they can have become risk has become less and less. Valve and valve TAVR can change, as Dr. Sanjay has last mentioned in this concluding remark. That is better to do a biological valve at the age of 50 years rather than putting a TAVI, because if the valve fails at 70 years, we can very easily put in a TAVR into that 70 years old patient rather than going for a redo aortic valve. So biological and the guidelines is already in common practice. Thank you so much. I would like to conclude here and immediately go to the next presentation. I think the next presentation is Dr. Praveen Verma, sir.
Can you hear me? Yeah.
Yes, sir. Yes, sir. 1 second. I'll just stop sharing my slides. Thank you, sir. Thank you for joining us. Okay, slides, sir. I will just start. Yeah, I can see you now. So can you start? So I would like to welcome Professor Praveen Verma, sir, to our.
Can you stop your slides?
Yeah, I have stopped, I think.
Yeah.
Okay. Is stopped now, sir?
Yeah.
So let me introduce Praveen Verma, sir. So he's an alumni from Trivandrum, and he's done his MCS from Sree Chitra, and presently heading the Amrita Institute of Medical Sciences, the Department of Cardiothoracic training from Sree Chitra, and then he has gained advanced cardiothoracic surgical training at the Brigham and Women's Hospital and the Harvard Medical School, and where he gained experience with this topic which he's discussing about, going to discuss, that HCM, minimally access, and definitely mitral valve repairs. So he has taken keen interest in all these topics which I just mentioned, and I'm really thankful to sir that he has given time to this particular webinar. So, and I have seen this presentation before, so I would like to again ask Dr. Praveen sir that please guide us how to do this.
Ritik, thank you for that kind introduction. So, hypertrophic cardiomyopathy, it is defined as a non-dilated left ventricular hypertrophy in the absence of other, left ventricular hypertrophy occurs in aortic stenosis, systemic hypertension. You have to differentiate it from athlete's heart and various other syndromes like Pompe syndrome, Fabry syndrome, Noonan syndrome. So basically, it's an autosomal dominant genetic disorder. When you say autosomal dominant, you mean that if you have that disease, 50% of your children can, and more than 1,400 mutations have so far been identified, and it causes sarcomeric mutation and causes left ventricular hypertrophy.
Sir, your slides are not shared, I think, sir.
I did share.
Let's see, sir. Yeah, it is not coming.
Can you see that?
No, not yet.
Can you see now?
Not yet.
Okay. Can you see now?
Not yet, sir.
Okay.
Yeah,
So I'm.
now it is coming.
Can you see?
Sir, only now your name is coming. The slides have not yet come.
Okay. There's some problem.
Yeah, take your time, sir.
So I'm seeing only Dr. Manish Agarwal's screen here.
Okay. So the slides here option has come to you, sir. Okay. Abhishek.
Yes, sir.
Abhishek, sir को panelist बना है ना?
Yes, sir. Sir is panelist. That's only he can share his video.
Okay.
Sir का video भी नहीं आ रहा है, sir.
So, sir, can you start your video now? Once, can I see your video, please?
I can see only the sound here. Only the sound here.
The share screen is coming, is it?
No, yes, sir. You are visible also, sir.
Yeah, you are visible.
नीचे देखिए सर, नीचे बार में lowest बार में share screen green color का बटन नजर आ रहा है सर आपको share screen.
Can you see that the green button share screen, sir?
One second. Yeah.
On the lower part, there will be a, yeah. Now it is coming. It is now coming. Yeah. Yeah.
Now can you see?
Yeah.
Yes, sir.
So you have to go to the presentation now, sir. Yeah. Now it's coming. Yeah.
Can you see it's a full screen or?
No, not that full screen. You can do just full screen, sir.
Okay. Can you see that?
Yeah.
I'm sorry. So yeah. So there are the vast majority of them are non-obstructive. When you say non-obstructive, it means that the left ventricular outflow peak gradients are less than 30 millimeter under both basal and provocative conditions. So when you have to call it as hypertrophic obstructive cardiomyopathy, then there are two types. One is the basal obstructive. That is the commonest type of hypertrophic obstructive cardiomyopathy, when the resting gradient is more than 30 millimeters of mercury. So obstructive. So these patients, they will have asymmetric septal hypertrophy. But when you put a echo probe and look at the gradients, the resting gradients are usually less than 30, and we think that it is a non-obstructive type, and we may not do much about these patients. But it's very important that when you find an asymmetric septal hypertrophy and the resting gradient is less than 30, you need to provocate these patients. How do you provocate? In which they do amyl nitrate. Here we can actually make exercises and then measure it. And if it is more than 30 millimeter, then it becomes an obstructive type of hypertrophic cardiomyopathy. So we do cardiac MRI for all these patients. So on the left panel, you can see that the classic septum is thick and it's usually more than 2 centimeter. But it's very important that all people who start surgery, you have to note that this intraventricular septal hypertrophy starts at least 1 centimeter below the aortic valve. So there is an area between the aortic valve and the intraventricular septum, area, you will surely create a ventricular septal defect. So on the right panel, you see a non-obstructive type. That's the commonest type of non-obstructive type, where the hypertrophy occurs only in the apex. So those kind of patients, many of them can be asymptomatic, or what is the most commonest symptom is they'll have severe shortness of breath because of diastolic dysfunction, and they have this heaviness in the chest. All say that they have some kind of weight put on their chest, and the most warning sign is when they have a syncopal attack. And it is also one of the commonest cause of sudden cardiac death, especially in young athletes. Third-class athletes have died of hypertrophic obstructive cardiomyopathy. So it's as you know, it's like a dynamic obstruction. When there is a decrease in the preload, that is the fluid inside the heart, when the heart starts vigorously contracting, or when there is a decrease in afterload, like you give a nitroglycerin or a S. So in order to understand septal myomectomy, you need to understand the mechanism of left ventricular outflow tract obstruction. So when the intraventricular septum is hypertrophied, because of the turbulence, because of there's a controversy about which phenomenon is that there can be a Venturi effect or a flow drag phenomenon, which actually drags the mitral valve, especially the anterior mitral leaflet, contacts the intraventricular septum. So when it contacts the intraventricular septum, the mitral valve opens up, and you get a mitral regurgitation along the posterior leaflet. So there are two phenomena in that. One is that the anterior mitral leaflet opens and you get a mitral regurgitation. So the point of contact of anterior mitral leaflet to the septum is very, very, very important. And I will show you in the T afterwards why it is important. And when you put a color Doppler, you find two jets. On the left side is the LVOT jet. So what is marked in the red arrow, the septum, after that it becomes a dagger shape. So classical LVOT obstruction in hypertrophic obstructive cardiomyopathy is a dagger shaped jet. So in aortic stenosis, you get in HOCM, you get a dagger shape. So because of that, on the right side is a dense envelope that is caused by the mitral regurgitation. So you get two color jet mitral regurgitation. So before you start surgery, always look at the direction of the jet. In HOCM, classical HOCM, the jet will be always posterior. So when your anesthesiologist show a center, you will have to worry whether this patient has got an intrinsic mitral valve abnormality. He may have an associated mitral valve collapse. He can have a mitral stenosis. We had a patient with a mitral stenosis so if you find a jet that is not posteriorly directed, you will have to always worry whether the patient has got an intrinsic mitral valve abnormality. So algorithm of HOCM is very simple. Those patients who are asymptomatic just need to be followed up. Those patients who are mild to moderate symptoms or severe symptoms are initially put on drugs. So the calcium channel blocker, disopyramide is actually very good, but it's not available in India. So if these patients are symptom free on these drugs, they need to be followed up. But those patients who have got refractory symptoms, even on maximal drug therapy, they should be referred for a septal ablative procedure. So when you talk about septal ablative procedure, and for the last 20 years, alcohol septal ablation has come in, but alcohol septal ablation in the last 10 years has shown that they actually give inferior results because the LVOT gradients come up, and there are so many other things. So it is now not who are too sick to undergo a septal myectomy, and it's never indicated in any patient below the age of 80. So septal myectomy is the gold standard. Alcohol septal ablation is an alternative in very few select patients. So can you see the TE picture here?
Yes, sir. Yeah.
Can you? Okay. So you ask your anesthesiologist actually to freeze when the anteromitral leaflet touches the septum and mark that point. That is the distance beyond which you should do a septal myectomy. If you limit your septal myectomy, or the LVOT will not be, the LVOT gradient will not be abolished by your surgery. So that is one important point where you have to measure that at the septal contact. Ask the anesthesiologist to mark that point and measure the distance from the aortic valve, and also ask them to measure what is the maximal thickness of almost 2.5 centimeter. And your aim is to reduce the septal thickness to less than 1.5 centimeter. So how do you measure how much you have to cut? Is that you can take the knife. You typically use a 15 blade knife. Like if you have to reduce it to from 2.5 to 1.5 centimeter, 1 centimeter you tie like a thread, and so that is the depth you have to go. Beyond that, if you go, you can create a ventricular septal defect. So initially, people used to do sepno, that is not enough. We need to go to what is called as extended septal myectomy. So what do you mean by extended septal myectomy? Is that you need to cut the interventricular septum. The length is very important. That you have to go into almost the base of the papillary muscles. That is, you have to definitely go beyond the septomitral contact, but almost up to the point of papillary muscle. So this is. I will show you a surgical video. Is it okay? Can I show this video?
Yes, sir.
Ritik? Yeah. So Sanla. And your cardioplegia should be perfect, because these are all very hypertrophied ventricles. So we use delnidocardioplegia. This surgery was done by Dr. Prem Shekhar in 2018. Prem Shekhar is the chief of cardiac surgery in Brigham. He's one of the world's foremost exponent of this type of procedure. So he used blocks for exposing the septum. One is that the left-sided pericardium, you need to keep it down. You don't hitch it up. And the right-sided pericardium, can you see one pericardium hitched up to the retractor? The head of the patient up and rotate the patient to the left side. That is how you expose the interventricular septum. And this retractor is very important. This is a malleable retractor, and you put it below the aortic valve. And tell the assistant that the aortic valve is under your retractor, so don't move around. So first thing is to take that suture. Can you see that suture being taken in the interventricular septum? Yeah. So you take the suture in the interventricular septum. Where you take the suture is that that between the right coronary and there. So your marking should be below the middle of neither of right coronary cusp. Can you see the right coronary cusp and where the suture is taken? Yeah. So, and the first cut should be very deep. If you take a very shallow cut, then the subsequent cuts it's almost impossible to do. So what you do is you make a trough. So you have to make two troughs, one here and one more towards the left side between the cusp. So you pull on the sutures and then slowly go below. So this is a very small area. What you're seeing is actually the chordate to the anterior mitral leaflet. So everything should be done under vision because severe mitral regurgitation. So one thing what is very important is that the mitral valve should be preserved. If you try to exercise the mitral valve, these patients have got severe diastolic dysfunction to start with. And if you exercise the mitral valve, they will have an added systolic dysfunction, and they do it very poorly. Diameter is almost 1.2 centimeter. That is the first cut. Can you see that? Yeah. So you can see the base of the papillary muscles there. Can you see that?
Yeah.
Yeah, okay. So that is the second cut he's going to take. See that he's cutting almost 1 centimeter below the aortic valve. So if you start cutting little above, then surely you will create a VSD. We had two patients, we created the VSD. And it is not a not an easy procedure. You cannot close the VSD through the left ventricle because the muscles are all very friable. So you'll have to put a bicaval cannulation and open the RA and close a good recovery. But it's a very frightening experience. So this is the dangerous part. That is, you are going to cut the chunk of muscle with the scissors, because you can always cut one of the cornea. So see, can you see the base of the papillary muscle? Yes. Yeah. So yeah, that is the limit up to it go. So people will be wondering that it will cause areas like where you cut, the chance of permanent pacemaker implantation is very less, and then you come off bypass. This patient had a mean gradient of 9 after surgery. This was done 2 years back, and this is a 19-year-old boy. So this is the difference between septal mammectomy and extended septal mammectomy. So in septal mammectomy, you just cut only a part of the septum, while in extended septal mammectomy, you go in depth. So the depth as well as the length is important. So you try to go up to the base of the papillary muscle, as well as you try to reduce the interventricular septal thickness below. Only a small resection, the turbulence still persists in the LV outflow tract, and it will cause a recurrence of obstruction. So after this, you ask your anesthesiologist after surgery to measure that what is the interventricular septal thickness, and there should not be any turbulence across the left ventricular outflow tract. And I will tell you that even patients having severe MR just before surgery, after you finish the procedure, the MR disappears, and even that disappears. And you have to also ensure that the length is below the septomitral contact. So there are certain manuals you can do to make sure that under TE, your surgery is good. That is, one is to make an ectopic. After the ectopic, the gradient usually goes up. It's called the Braunwald phenomenon. So you can make an ectopic and see any turbulence. You can atrial pace this patient. You can pace at 120 because the tachycardia, because of the low diastolic filling, should increase the turbulence. So you start atrial pacing at 100. These manuals are okay, then this is a cure. So one more thing I want to mention is that in some of these patients who got interventricular septal thickness of less than, let us say, 22 centimeter, they can have intrinsic abnormalities of the mitral valve. One of them is that anterior mitral leaflet is long. Usually the anterior mitral leaflet length is less than 30 millimeter in most patients, but length can be more. There can be abnormal papillary muscles attached to the directly to the anterior mitral leaflet. That's called as a Cruise abnormality. You can have a strong secondary chordae attached to this AML. So all these things, all these anomalies, you have to recognize before you start the surgery. Direct insertion of anterior papillary muscles into the AML. That can be, all other things have to be identified before surgery, and cardiac MRI is very, very useful. So if these patients who have intrinsic mitral abnormality, is the anterior mitral leaflet by a horizontal plication. So this is a technique called RPR, resection, plication, and release. So we don't use continuous switches, we use horizontal switches, and we try to reduce the 33, we try to reduce it to around 2.8 or 28 mm. And this is a patient recently we operated. Can you see this echo, Rizvi? Yeah. So if you look at it, the interventricular septal thickness was around, and in this patient is that the PML is very long. The PML length was very long, and it is actually pushing the anterior mitral leaflet into crossing sand. So this PML was around 28 mm in this patient. The turbulence and LVOT gradient will still be there. So what we did was we plicated the anterior mitral, the posterior mitral leaflet. We did a septal mammectomy and plicated the posterior mitral leaflet, and you can see that there is hardly any gradient. There is a turbulent flow, and there is hardly any MR in this patient. So this also is the mechanism of LVOT has to be identified before you start doing the surgery. So this technique, actually we described this technique. We have done almost 2 patients with this. We described this technique in Asian annals. It's almost like a cure. Their survival is similar to that of normal population, and it is far better than patients who are not operated. And alcohol septal ablation. This is a picture from I taken from Nishimura. You can see that it doesn't cause that kind of it is not a what you call as a measured myectomy. It's like a bomb blast that was occurred. There was an abnormal papillary muscle that was directly attaching to the anterior mitral leaflet. So this patient will have very inferior results with alcohol septal ablation. And what is now coming up more frequently is that this patient had a scar, and it increases the scar burden, and these patients can have increased risk of ventricular tachycardia and sudden cardiac death. But in post-myectomy, there is no extra scar burden. So the surgeon who did this is, who initiated this procedure is Andrew Morrow. So most people don't know that Andrew Morrow actually suffered from hypertrophic obstructive cardiomyopathy. There was nobody, multiple strokes, atrial fibrillation, and finally died. People think that he actually committed suicide. So this is the autopsy of his heart. You can see the classical findings of hypertrophic obstructive cardiomyopathy. The interventricular septum is very thick. Rest of the LV is also thick because of the secondary obstruction. And because it's an autosomal dominant disorder, he had 3 kids. So because it's an autosomal dominant cardiomyopathy, the daughter actually underwent a heart transplantation because of that. And this is her heart. The other son had a septal myomectomy and is now cured of the disease. And recently, like 3 years back, his daughter is now having non-obstructive hypertrophic cardiomyopathy. You need to tell about this screening the family, because you can prevent a lot of sudden cardiac deaths by advising the patients that your family members need to be screened, your son needs to be screened, your daughter needs to be screened, because it's to conclude. Before you start a septal myomectomy program, you need to get a cardiac MRI in all these patients and make sure that you do an extended septal myomectomy. The depth and length are very important, and it's a surgery with a stiff learning curve. But persisting, you have to be, because in the initial period you err by undercutting, and later on, then when then I am still in that learning phase. So in the last few cases, we had this, I'll tell you the BSD, because we thought that the septal excision was not adequate. So I became more aggressive, and then ended up in ventricular septal defect in 2 patients. Now we are kind of stabilizing. So in some patients, you need to times posterior mitral leaflet. But what is more important is that MVR should be avoided unless the patient has got any intrinsic mitral valve abnormality. Otherwise, you will make the patient worse after disease. And all patients should have a risk assessment for sudden cardiac death. There are several criteria. I don't want this. If this patient has got a risk factor patient on AICD, and it's very important that you screen the family members. Thank you. So I will just say that about this lady. She's Lisa Salzberg. There's a non-profit organization in US called Hypertrophic Cardiomyopathy Association. She's actually the founder of that. She had a heart transplant. Her only wish was she wanted to see the heart, which had troubled her, in her lifetime. So in that basket is her heart, with having the hypertrophic cardiomyopathy. She's doing very well after heart transplantation. Thank you.
Thank you, sir. Thank you. That's a very lively and very, very pragmatic and informative discussion.
Thank you,
Dr. Praveen. Sir, and really we have enlightened the evening by seeing more daughters and daughters and sons. So it's very exciting. Thank you so much.
Yeah,
be
sure.
with us. We'll have a lot of questions for you. So I'll open Professor Santanu Pandey from HGPJ Lucknow. Dr. Pandey, sir, you are here.
Yeah, sure. Good evening.
Good evening, sir. Good evening. So let's just introduce shortly. Everybody knows Professor Pandey. Just for the people who might not know him, he's a professor in the Department of Cardiothoracic and Vascular Surgery at HGPJ Lucknow. So area of interest is mainly minimally invasive coronary artery bypass surgery, who he does really, really well. I have liked to do that, but it's very difficult. His research is on development of a tissue valve and right ventricular function, and he has done a fellowship. So he's a fellow of ICTS CSI Royal College of Surgeons, England. So he will speak to us on a very interesting topic, which I am really interested in. That is tricuspid valve repair.
Thank you.
Over
so I share my
Pandey,
screen
please.
now.
It's coming, sir.
Hello. Okay, you can now hear me. So I start now. My topic is tricuspid valve repair, the best practices. So tricuspid valve is very easily forgotten valve for surgeons, and that is what slide haven't come. Okay. So why is that? It's showing that I'm sharing my screen.
You are sharing your screen. Screen has come.
Okay.
And you're using a MacBook. And yeah, please. Slide has not started again.
I haven't started yet. Okay, I'll put it.
Yeah, you're clicking here.
Yeah, you see the slides now?
Not yet.
Mm-hmm. So what do we? Did you see the slide now? Do you see it? No?
No, sir.
So I'll stop share and then I'll share again. Maybe.
Yeah, please, no problem.
Yeah. Now you see that?
Yeah.
Now you see the slide? Yeah. So I'll be talking on tricuspid valve repair, the best practices. So tricuspid valve is a very easily forgettable valve.
Once they are making your life easier, it is your job.
So
I think Sanjay, you have to mute yourself. Sanjay.
Muted, sir. Muted.
Yeah, thank you. So and it's very common. It's one of the most common valvular heart disease because it's present in almost 80% of individuals in some form. So the reason it has not caught the imagination of, because it's in the low pressure chamber, and the right ventricle is extremely compliant, and the compliance of pulmonary circuit is quite huge. And for this reason, it is tolerated by heart and by with very vague symptoms. And once the presentation is florid, usually the right ventricular dysfunction has set in, and it's difficult to repair it then. And the original idea is, which was created, was that if you address the left-sided heart valve, this secondary TR will disappear. Came with about 5,000 patients, which showed that moderate and severe and moderate TR causes reduced survival at long term. And this was independent of right ventricular systolic pressure. Then there is a very recent paper analysis of STS data of 20,000 in excess of 20,000 patients, which have shown there was a very statistical significant difference between absence of tricuspid regurgitation and presence of severe or even moderate tricuspid regurgitation. So the important thing is, which may differ from our patients, is the age of patients. The age of patient in these series is in these patients, the tricuspid surgery was done or not done. That gave a lot of the statistically significant difference was there in survival too. So this made a case for tricuspid valve surgery in cases of severe tricuspid regurgitation by this paper. Now, there is atrial fibrillation also increases the chance of having tricuspid regurgitation. And there was a propensity score match study of a large number of patients. If the patient remained in sinus rhythm, there was a difference in the survival of these patients over long term. And there was difference when they were propensity score matched also. So it makes a very strong case for addressing atrial fibrillation when we are going for valve surgery, and we are going to also has shown a trend towards leaning towards doing a ablation for atrial fibrillation in cases where severe TR needs to be addressed. Now, not only severe TR, even moderate TR has been shown to be associated with long-term drop in long-term survival, with long-term survival reaching about 87.5%. And this is again, the regurgitation was isolated. So the effect of tricuspid regurgitation on actual survival, which was 87% at 10 years. And rehospitalization was around 96, failure was in 96% of patients. And if we address it with some form of valve regurgitation was nicely demonstrated, at least in midterm, and still it was better at long term. So what are the risk factors which can cause progression of tricuspid regurgitation? It is very important to understand that the age of the patient. So if the age is more, if the patient is in atrial fibrillation, and if the tricuspid annular diameter millimeter per meter square, these patients are going to have increasing tricuspid regurgitation as the time passes, and they will have problem with survival. They will have bad survivals. So these patients, in these patients, tricuspid regurgitation should definitely be addressed. So phase. So how do we define tricuspid regurgitation? It is very important. There are so many factors. I would suggest that we each unit sits with their cardiologist, and one of the criteria should be in reporting tricuspid regurgitation in that unit, and so that surgeon knows exactly which patient is severe, has a severe tricuspid regurgitation and a moderate tricuspid regurgitation. The other important thing is the presence of dilation of the inferior vena cava. If it is more than 21 millimeter, we should see if the hepatic artery veins are dilated. That shows that even if for some reason the TR may not have been picked to be severe TR, there is right-sided process which is going on. And so the right ventricular dysfunction should be categorized at the time when tricuspid regurgitation is being labeled. So these two things are very important, and they should be standardized. So tricuspid regurgitation can be primary because of the primary pathology of the valve by itself, or maybe secondary rhythm problems, or because of left-sided valve problems. So when we address tricuspid regurgitation, it is very important to see if they are asymptomatic or symptomatic. Asymptomatic patients usually are treated with diuretic therapy until and unless they become symptomatic, or they start showing the right ventricular dysfunction. When they are symptomatic, it should be identified what kind of pathology is there. Primary pathology most of the time requires some sort of surgery, and it may be a tricuspid valve replacement in the rhythm, that is ablation and atrial fibrillation, or repair, which is to be directed if the right ventricular dysfunction is not severe. If right ventricular dysfunction is severe, then the ball has passed the post. So if we see the secondary TR is, we should see whether it is symptomatic or asymptomatic. And I would say we should see three things. One is symptom, the other is right ventricular functions, and the grade of tricuspid regurgitation. So if tricuspid regurgitation is severe, right ventricular dysfunction is just that is normal right ventricular function. If the patient is symptomatic, he should go for a tricuspid valve repair. If the patient is asymptomatic, then you have to follow this patient up very keenly every 6 or maybe 12 months. As soon as right ventricular function starts going down from 45%, you should offer them surgery even if there are no symptoms. And if there are symptoms and right ventricular function has gone down below 30%, then these patients should be managed medically. So there are a few very familiar technique of managing tricuspid valve repair. That is Devagourous technique, which is very common and has been shown to fail in most of it. That is on the right side of the panel, and that is you place plagets with each suture. What we do in our unit is we take a pericardium felt, which is measured over a tricuspid valve ring sizer, so that we can have a felt of that size. So using a Teflon, we used to take a strip of Teflon marked over the tricuspid ring sizer. But in one of our patients, we had bad experience of appearance of tricuspid stenosis. So we have shifted now largely to to the pericardium. That's from almost all the good companies. And this is easily done on beating heart. As you take sutures for interrupted sutures for doing a Devagourous and annuloplasty, it would be similar sutures for placing the ring. Now there is one very recent paper which has used this pericardium as a ring for annuloplasty of tricuspid valve. This patient is almost matching our patient which we operate, and they show that Devagourous is as expected, usually fails with time, while pericardium, use of pericardium or ring gives almost similar result in at least in at 3 years or 2.5 years. However, there was no difference in survival, and we can expect that because this is only a study which covers 2 years. There is another big study which is did propensity score matching, also published in 2019, and they show that if you do a band repair, the kind of repair which is rings, band repair show early failure, but then band repair shows a gradual failure over time, and the ring repair is better than the band repair except for early failure when a ring repair shows slightly inferior result. However, if you have to replace the tricuspid valve, it's not a very bad idea because this is a quite fairly long follow-up. Replacement instead of repair shows similar survival. So if you have to replace the tricuspid valve, that is not a very bad idea in these patients. And with valve and valve therapy becoming more aggressive, at this point of time, we can place a tissue valve even, and we can sail through 10 years and followed by a valve and valve in future. So what are the contemporary trends in paper comes from United States? We have to make our own registry and see what we are doing in India. There has been consistent and persistent rise in tricuspid valve procedures. And when we compare it with infective endocarditis procedures and congenital heart surgery, tricuspid valve procedures are steadily rising. So what are the indication? Any severe regurgitation when we are going to address the left-sided heart valves should be repaired. And any primary regurgitation at the same time should be repaired. Now, the original idea of addressing the left-sided heart valve would improve the regurgitation and tricuspid valve is no longer tenable at this because these guidelines come from Europe and Western world, where the average age of patient is 65 years. And when we compare it with our patient, where the average age is around 29 or 30, at least in the geography where we operate. Class 2 indication is if there is a moderate TR which is present when you are doing the left-sided heart surgery and there is dilation of tricuspid diameter annulus more than 21 millimeter per meter square, or if there has been evidence of failure sometimes during the course of disease, these patients should be considered even in mildly or asymptomatic patients with moderate regurgitation at the time of left-sided valve surgeries. He should go and repair this valve. That is 2A indication. And 2B indication is like if there is asymptomatic patient from tricuspid valve point of view, but they are having some sort of RV dysfunction, that should be addressed when the left side is addressed. So in our experience, I'll just show you these some slides here, and this is very early. We have been working on this project, and we are trying to collect the data. The initial data is now available with us, but we are trying to increase its duration. So what we were doing is when we, this is like tricuspid valve when we are doing left-sided heart valve surgery. So what we decided in our unit that we will do severe TR if the right ventricular systolic pressure is less than 60, tricuspid annular diameter is more than 21 millimeter per meter square, or if there is a primary disease of tricuspid valve. And techniques which we used are these three, which I have already discussed. 15 to December 2017, there are 787 patients with about good 70% of patients presenting with mild or no TR. Now that is something very big for us because 70% of patients do not present with TR. Now we should consider this with the age of patients which are greater than 30 years. So the moderate TR was present in 16% and severe TR was present in 12%. So we divided them into less than 60 and more than 60 groups. And this is the kind of intervention. We did intervention in about 68 patients. So this is what has happened over 2 years. We are trying to increase. Unfortunately, this year has gone as null. It's very difficult to follow patients during corona pandemic. So if it's interesting to notice that no TR and in severe TR, they have almost behaved like similar. And we have not addressed severe TR if there was severe PH unless and until the tricuspid annulus was dilated. So this in very early phase, it's very early, 2 years, there's nothing for end that the original idea of not touching the tricuspid valve, if the regurgitation is present with severe PH, may be true for our cohort. It's a very early indication for that. The other interesting thing is mild to moderate TR patients are showing statistically significant even in 2 years of follow-up. That is what I was stressing in initial part of my presentation, that we have to be very cautious in addressing a valve regurgitation as moderate or mild, because this is the part of regurgitation where the right ventricular dysfunction, there is moderate regurgitation, mitral regurgitation, and there is starting of right ventricular dysfunction. This is what is going to happen in follow-up. Severe TR, the occurrence of severe TR would be much higher. So this is on group, if we divide it into right ventricular systolic pressure and more than and less than 60, almost similar throughout in appearance of severe TR during follow-up of 2 years. Then 68 patients where we repair tricuspid valve, this is the kind of result which we have seen over 5 years. So there has been a steep drop and there has been constantly increasing severe tricuspid regurgitation as we move to 5 years of follow-up. And the severe TR has been present in about, freedom from severe TR is about in 78% of patients. And if we see, we did tricuspid valve in these 5 years, but there was a steep drop in annuloplasty, ring annuloplasty group. Ring annuloplasty is basically the bland, either of Teflon or of pericardium. So there was initially a steep drop and then it has remained static. So the band failed in initial part of after the surgery in the very first month, in the very first follow-up. If we compare it with Devagourou shows consistent drop over a period of 5 years. And this could be attributed, this sudden drop where the band failed could be attributed where it is suggested, or it is, the tricuspid valve is not a unidimensional or a single dimensional valve. It has got 3 dimensions. There is a portion towards right ventricle, which is the lowest. And if possibly the ring would have been used in these patients, they would not have developed early failure, which they developed with the band. So the take-home message now is out and addressed during the left heart valve surgery. So if you are getting a patient with severe TR and severe PH and the annulus is dilated, you are going to definitely address that. If you are going to, if you are seeing a patient where the annulus is not dilated, the right ventricular function is fine, you can, this is open to discussion time and believe on the original hypothesis. But if the right ventricular dysfunction is settling in, the right ventricular ejection fraction is reducing, then it should be repaired even at this point of time. I would suggest that if the tricuspid valve is not dilated, it is better. Moderate TR needs to be very carefully assessed. If it is more that if the tricuspid valve is dilated, it must be addressed. If the right ventricular dysfunction is settling in, must be addressed. So the most important information is preoperative assessment. So preoperatively, the right tricuspid valve should be assessed with one strategy, show the surgeon and cardiologist, and he should be marked as used in postoperative follow-up also. And right ventricular dysfunction is a must. Indian perspective, I would like to say at this point of time, we need to do a big study or maybe multi-institutional study, because our patient heart disease, and we are taking guidelines for repairing tricuspid valve from the Western population, which is where the average age is 65 years. So that is a point to ponder and think. Thank you very much.
Thank you, Professor Pandey, for your candid presentation. There will be a lot of, already I have got a few queries from different angles, so we'll discuss those in our, after the completion of all this.
Yeah, I always create controversies.
Yeah, so yeah, so that is totally in you know, totally opposite to what you have said about 2 days back. There's a different webinar,
yeah,
but the data was totally different. Let us discuss this after the end of the session. Yeah. So thank you, sir, for coming back in. So next we have got Dr. Manoj Kumar, who will be talking on pregnancy and valvular heart disease. Without this topic, we cannot, you know, complete a valve symposium. So Dr. Manoj Kumar is currently the Senior Director of Cardiology at Max Hospital, Patparganj. He is a DM cardiologist from GV Pant Hospital, Delhi, and has got almost more than 20 years of experience in interventional cardiology and different complex. Dr. Manoj Kumar, sir, to start his presentation. Sir, please be on time. Thank you.
Thank you, Dr. Rizvi, for your kind words. So I'm supposed to speak on pregnancy and valvular heart disease. So we are up to 4% of pregnancy, but the incidence is increasing due to the improved prognosis of rheumatic heart disease and congenital heart disease. females. So we will restrict our discussion on these 3 points. Is pregnancy safe in the patient's disease? Management of prosthetic valve during pregnancy. So before going exactly on the topics, I will just see there is increased blood volume, there is increased cardiac output. So increased blood volume, the increase in maternal blood volume begins as early as the
full screen, please.
Hello? Okay, just wait.
Thank you. Thank you. Thank you, sir.
It's okay? Okay, so pregnancy, there is increased blood volume, and the increase in the maternal blood volume begins as early as the 6th week of second week of gestation, and it stays at that level, that is 50% higher than the pre-gestational blood volume. So we know that there is an increase in the plasma volume initially, and it is faster than the RBC increase. So that leads to the physiological anemia. Hematocrit value can even decrease up to 33%. There is always increased cardiac output during pregnancy. And pregnancy is the increase in the cardiac output, which begins to rise during the first trimester and peaks around 25th week in the pre-gestational value of cardiac output. The reason for the increased cardiac output is increase in the intrinsic myocardial activity. Central circulation is of low resistance, and pregnancy also causes systemic vascular drop in the output. There is decreased pulmonary vascular resistance, pressure changes during labor, fluid shifts after pregnancy, and increased physiological changes which we encounter during pregnancy. So summarizing in this table, you can see there is average increase output in first trimester and almost 50% during labor. Heart rate also, baseline heart rate increases during 15 to 20% of the basal heart rate. Blood pressure usually in the first trimester and second trimester decreases, but in the plasma volume, blood volume by 50% and cardiac output by 50%. What effects on coagulation cascade during pregnancy? There is decrease in the fibrinolytic, increase in the fibrinogen level, factors 7, 8, 10, and von Willebrand factor. So blood becomes thick or more. So what problem we face during pregnancy in patients with prosthetic valve? Maternal hazards and valve thrombosis, maternal death with advancing gestational age. So finally, fetal, maternal and fetal outcome in 30%, retroperitoneal, retroplacental bleeding leading to premature birth, fetal death, and embryopathy may be due to the vitamin K antagonist used for the prosthetic valve. It's increased chances of embryopathy. Fetal intracranial bleed during vaginal delivery, especially when you use forceps delivery in second stage of labor. During pregnancy, there is an increased risk of valve thrombosis that ranges from 3.9% to 33%. Like ball and cage valves have the higher thrombotic rate. Increased risk of thromboembolism, patients with atrial fibrillation, stroke, increased risk of hemorrhagic complication, increased risk of heart failure, and increased risk of maternal death, that maternal mortality increases by 2 to 15%. So prosthetic heart valve replacement is highly risky for both mother and fetus. So it is dangerous for both mother and fetus. European Society Cardiology guidelines that it is recommended to perform risk assessment in all women with cardiac disease. Of the WHO classification of calculation of maternal risk. I will just highlight what is the WHO classification for estimation of maternal risk. It is recommended a multidisciplinary pregnancy heart team. So this is a new concept of heart team with the involvement of gynecologist and obstetrician. Vascular risk. Class 1 patients, no detectable increased risk of maternal mortality and also mention the patients who are coming in the class 1. Class 2 is the small increased risk. Class 3 is the significantly increased risk of maternal mortality. And class 4 is extremely high risk of maternal mortality. So class 3 and 4 have higher maternal mortality rate. So class 1 patients includes patient symptoms, normal sinus rhythm, no cardiomegaly, no residual valve lesions, normal ventricular function, and no pulmonary artery. And setting these classes are based on the pulmonary artery pressure. Class 2 patients include tissue valve factor, patients with atrial fibrillation, NYHA class 2, mild obstructive lesion, and mild LV dysfunctions. These are the class 2 patients. It includes tissue valve with risk factors, mechanical valve, NYHA class 2-3, moderate obstructive, still no pulmonary artery pressure. So what happens in the class 4? The patients in heart failure, NOHA class 3-4, severe obstructive valve lesions are included. Function important criteria. And if the mean pulmonary artery pressure more than 50 millimeter of mercury, that comes into the class 4, that increases mortality significantly. Different valvular lesion, mitral stenosis, which is very common, and it is one of the commonest valve involved terms, or pulmonary hypertension. Patients with have a high PA pressure. Restricted activity, then beta-1 selective blockers are recommended. This is the recommendation from ESC 2018. Diuretics are recommended when congestive symptoms persist, beta blockers to decrease the heart rate and to increase the length of diastole. But even patients have congestion, then diuretics. Intervention is recommended before pregnancy 1 square centimeter. Therapeutic anticoagulation using heparin or vitamin K antagonist is recommended in case of atrial fibrillation, left atrial thrombosis, or prostatectomy should be considered in pregnant patients with severe symptoms or systolic pulmonary artery pressure more than 50 mmHg despite medical therapy. So our last possibility is BMB, balloon mitral. Summarizing that the stenotic lesions are dangerous in the pregnancy, in the situation of pregnancy, and regurgitant lesions are better tolerated in pregnancy. So in patients with intervention is recommended before pregnancy in patients with severe aortic stenosis if they are symptomatic, or if they develop LV dysfunction, or when they develop symptoms to be considered before pregnancy, even in asymptomatic patients. Even in asymptomatic patient with severe AS, when a fall in blood, so any hypotension developed during a stress test is an indication for the patients of severe AS for the valve replacement. Can be done even during pregnancy in patients with severe aortic stenosis and severe symptoms. So coronary artery bypass surgery or valvular surgery may be considered during. Recommended that the valve prosthesis for women contemplating pregnancy is chosen in consultation with pregnancy heart team. So as Dr. Rizvi was enforcing that patient choice and discussion with a valid discussions with the patient should be involved in decision of the which valve should be used for the valve replacement as in pregnancy. So whatever evidence till date is available, pregnancy doesn't progress or does not increase the deterioration of tissue in the young patients. So, and it is possible that if bioprosthesis has been implanted in the first operation, then the, even surgical replacement of the valve or in the aortic position tower is possible as a choice for young patients also. So prosthetic valve requires anticoagulation. We know that all metallic valves requires anticoagulation. So bioprosthetic. So what is the chance of getting embryopathy when you use vitamin K antagonist during 6 to 12 weeks of gestation? That is the peak susceptibility for teratogenicity. And during second and third trimester of pregnancy, it is relatively anticoagulants. And you should also know this fact that this teratogenicity or embryopathy that warfarin or acetylene induced, this is dose-dependent phenomena. If a patient requires less than 5 milligram to maintain INR, the teratogenicity at more than 5 milligram per day, it is teratogenicity rate is around 8%. So it is a dose-dependent phenomenon. So what are the choice prosthetic valve during pregnancy? There is one possibility that you continue for the vitamin K antagonist throughout the pregnancy. Embryopathy, spontaneous aversion, all these three groups, whether you continue vitamin K antagonist or you adjust heparin in the first trimester, then you go for delivery, or during third stage of labor, you switch to the again on the heparin, this anticoagulation in prosthetic valve. So a spontaneous abortion rate is similar in all these three. And if you see this continue heparin, because heparin doesn't cross the placenta. But if you are using the mixed approach, heparin during first apathy is 3.4%. If you see the maternal death rate, it is 1.8% in vitamin K antagonist, 2% in the mixed heparin plus oral anticoagulants. What is my take? Can see there is increase in the blood volume, there is plasma volume is increased. So use dose of heparin or low molecular, the larger dose is required, and proper monitoring of anti-10A activity is required when you use low molecular. Lines of European Society of Cardiology, the patients when conceived, pregnant, the class 2A recommendation in hospital, you have to see PTT of 2 times of the control. And in hospital, change from low molecular weight heparin to vitamin K antagonist 2 weekly. Every fortnightly, you have to monitor the INR. In second and third trimester, you can carry monitoring of INR is required. Then during delivery or in the third stage or third trimester after 36 weeks, you have it and stop 4 to 6 hours before delivery and starts 4 to 6 hours after delivery if there is no chance of bleeding or gynecology. The second class is women who are requiring low dose of vitamin K antagonist. They can continue vitamin. Switch over to the low molecular heparin is a class 2B indication according to the ESC guidelines. And same thing, you have to stop this heparin infusion, unfractionated heparin infusion, chance of bleeding after 4 to 6 hours. So in pregnant women on vitamin K antagonist, it is recommended to perform INR. Women on low molecular heparin, on unfractionated heparin, it is recommended to perform weekly anti-10A level monitoring or PTT monitoring with dose adjustment within 36 hours. Low molecular heparin is not recommended when weekly anti-10A level monitoring and dose adjustment is not available. So it is a very important test if you have the facilities of anti-10A molecular weight heparin in place of unfractionated heparin. In pregnant women with low molecular heparin, it is recommended to target anti-10A liter for aortic valve prosthesis and slightly higher in the mitral and right-sided valve prosthesis. So this is a very important parameter to be monitored. Recommended to discontinue vitamin K antagonist and start adjusted dose intravenous unfractionated heparin or adjusted dose low molecular weight heparin at the 36th week of gestation. It is an effective peripartum anticoagulation. Unfractionated heparin should be continued until 4 to 6 hours before planned delivery and restarted as early as possible 4 to 6 hours after delivery. And for all this, maternal delivery is considered as the first choice for the most patients, barring some exception, that is maternal related. So if delivery starts, means you have an urgent indication for the delivery or to take out the baby, cesarean section is recommended. That is the maternal indication. So cesarean delivery with dilatation of ascending aorta, if the dilated ascending aorta more than 45 millimeter, severe aortic stenosis, or if the PA pressure is very high in a situation of Eisenmenger syndrome. So induction of labor should be, so we should not go beyond, or you should not allow pregnancy to go beyond 40 weeks of gestation period. Delivery before necessary surgery should be considered when gestational age is more than 26 weeks. So if you are planning some surgery after 26 weeks, delivery should be done before you are planning for any surgical recorrection of the valve. If cardiac surgery is to be performed after 24 weeks and before 37 weeks, the used or recommended for the mother for the surfactant formation on the fetal lungs, prophylactic antibiotic therapy by the European Society of Cardiology. Second important thing for these patients, handling these patients of performed choices are paramount. So counseling prior to surgery, discussion on available options and what is your choice. So involvement of patients is very important. Advice for contraception is also needed because they should be encouraged for the small family norm. Explanation of pregnancy predisposes for the extra risk. So small family norm should be encouraged. And if there is a very high maternal, we should avoid pregnancy. Explanation of risk associated with various strategy, active involvement in decision making, explanation of follow-up, and hospitalization if switch over is planned. So whenever you switch over from vitamin K antagonist to unfractionation is better during this switch over period, because you all know this fact that the warfarin is much more tension of valvular thrombosis. So even after delivery, you have to counsel them for the contraception, vasectomy, and tuberoseptic pill should be avoided because it has own drawbacks, or it also causes venous thrombosis. And lot of, in short, the management of prosthetic valve and valvular heart disease in pregnancy. Thank you so much for your kind attention.
Thank you, Dr. Manoj Kumar sir, for your candid and very wrapped up presentation in a short duration of time. We'll have some questions at the end. Please be with us till the end, sir. Thank you. So with this, I would like to welcome Dr. Ajeet Surgery at BLK Super Specialty Hospital and Director of Heart Failure and Transplant Program. So everybody knows Dr. Kaul for his contribution to cardiac surgery, adult cardiac and pediatric cardiac surgery both. He has accomplished almost about nearly 20,000 cardiac surgeries to his credit, and has been very successfully running our BLK's pediatric cardiac surgery program. Over to Dr. Kaul, please, for his very unique presentation on a cardiac surgical approach for all different types of percutaneous interventions. Over to Dr. Kaul, please.
Can you hear me? I'm sharing my screen.
So, yeah. So, Dr. Manoj Kumar sir, can you stop sharing your slides? Yeah, thank you. Yeah, Dr. Kaul, please start sharing the slides.
Yeah. Just a second.
Yeah, no problem, sir.
Yeah, just a second. Can you see my screen now?
Not yet. It will come, sir. Just...
Now is it better? It says my internet is a little unstable. Just a second. Is it all right now?
No, sir. Not yet.
Not yet. Just a minute. Let me see what is the problem.
You can stop sharing and reshare, sir.
Okay. Is it okay now? Can you hear? Not yet.
Not yet, sir.
Is it now?
So I think your internet connection is a bit weak on there because you have kind of become free on your where it's coming as like your network bandwidth is very low here also.
Now is it okay now?
No, sir. There's a message coming on the screen that your network bandwidth is low here also, in our side also.
Okay, so what do I do?
Sir, we can swap the presentation with Dr. Kaul so that we can just we can put in the next one.
I think that
yeah. So I will start with if Doctor, and then you can start with a better connection. Sir. Dr. Mishra sir is here already.
Yeah, can you hear me?
Yes, sir. Yes, sir. I can hear you, sir. Yes, I can hear you, sir.
Rizvi?
I can hear you, sir.
Yeah, sure.
So, good evening.
Sure.
So,
Good evening.
let me introduce, We don't have to introduce Dr. Yugal Mishra, sir, to the cardiac surgery fraternity. He was past president of the ICTS and presently the chairman of cardiac sciences, medical director for the anti-medical specialist in the Manipal group of hospitals in Dwarka. And also he's the chief of cardiac sciences. And he does all types of surgery, whatever written in the textbook. So with this, I would like to welcome Dr. Yugal Mishra of heart valve surgeries. Over to Dr. Mishra, please.
Thank you. So, can Ajay call and share that videos? So, I don't see that. Just a minute. Let me go. Yeah. Okay. I'm fine. I'm fine. So I am
it's coming.
My presentation.
It's coming. Yes. It's coming. Yeah.
No. Now.
One more go. I think so it will come.
So good evening, friends. With Vivek, Dr. Manoj, Adil, and Vikas are laid down a fantastic symposium. I have given me a task which has happened today, and I'm thankful that my all discussed and then get some conclusion what is going to happen in the future in the area of heart valve surgery. What I'm going to talk about, I may touch upon few things, but the presentation or whatever tips which I'm going to bring out is going to share, and the one which you have already presented in this whole day today. Now, if we see this, but the things now there is a query, there is a question mark now whether the surgery is a gold standard treatment. And in 2011, STS came out. The database showed that 8,000 patients who underwent mitral or aortic valve replacement. But another issue which is there is in there is a 0.4%. And if we do the mortality is somewhere in the range of 6. And if we do double valve, again the mortality is very high. In spite of so much experience in the field, we still have going to now. I have already mentioned here that in the era of TAVR, we are discussing the mortality in the range of isolated aorta and of course combined CABG and valve very high. If you see on the right side that I have, these are most of the cardiac surgeons still split the sternum to do the valve replacement. You still use same swing. And in a country like ours, we still use maybe around 80% in the age group of 60-65. Dr. Rizvi has very nice, elegantly put the perspective for India, where preference is for the tissue valve, but we are not reached a future for heart valve surgery. There are the two things which are important. Is the disease is going to decrease? The answer is no. There are going to be more and more patients who are, of course, not a rheumatic, which is going to decrease maybe in another 10 to 20 years time, but the degenerative lesion is going to go. And this here, I'm at the, and somewhere at the 2030, there will be going to be 70 million people who are going to be more than 65 year age, and around 10 million people who are going to be more than 85. Now going to go, there is going to be an incidence of aortic valve disease. There is going to be the incidence of course, mitral valve disease much more than, so somewhere at the age of 75 years, around 12% of the population are going to have a double valve involvement. Total 8 to 9% are going to have mitral valve, and somewhere around 3 to 4% are going to have a aortic valve, which is going to be huge. So there are going to be substrate, but surgery like that, I think no, because now there are competition, not a competition. There is another technology which is going to give a better out elegantly than opening up the sternum and doing the surgery. Now here I have shown now the factors associated with the increased risk of surgery in aortic valve: female gender, renal dysfunction, diabetes, moderate to severe COPD, low EF, NYHA class 4, cerebral vascular disease, immunosuppression. Now these are the aortic valve disease a high risk, and anatomically, if there is a porcelain aorta, prior radiation, bypass graft, which I done earlier, and which now non-traditional, we already discussed frailty, high operative risk in cirrhosis and pulmonary hypertension. Now these are the next 10 years or 20 years, we are going to do the same cardiac surgery, are not going to modify. And I think before me, the other importance of catheter-based technology, I would have also shown that even the surgeons can venture out to the catheter-based intervention in aortic and mitral valve. I can see that how the catheter-based technology is reeling and coming back would have been doing the surgery. Now, if even the low risk category where the STS score is the FDA has recommended, which you can see in these two publications, and Manish has elegantly narrated that in a low risk and also self-expanding valve both showed the benefit, whether we tubular vision, but the fact of the matter is that this is a science, and this is a publication, this is a data which shows that definitely outcome so far the death, stroke, and rehospitalization as compared to the surgical arms. And this is from self-expanding facts that there is a technology which is showing superior results. Patients' acceptance is more, and of course, the country like ours, where we were talking about because affordability is increasing, the cost of the technology is decreasing. So one has to grab this technology now. Then thinking of that, not going to go away or 5 years, 6 years. There is some in a low risk cases tower. Now he also touched upon little bit that in a surgical valve replacement of the aorta. Now this is a fact that if the valvular, and if it is moderate, the mortality is high, definitely shown in this graph. Bother about now that there are technology which Mani said, and I have also put a few technology here which are making the procedure safe, making which we are going to get eventually tissue, as we got. He said you're going to also touch upon the Regelia tissue and need not to load during the procedure and directly implant. So the tissue is going to be, and this is going to come maybe a year or 2 years time. Valve aortic regurgitation, now there is technology. JNA valve is now meant for, and there is work going on, and eventually the FDA the mitral valve area. Now the technology is little cumbersome at this stage, particularly but it will remain for a long time, and we are going to operate maybe another 10 years, 20 years till the rheumatic process. And for functional, there is the technology available. We have mitral clip for degenerate. what is being seen, that we all in the aortic. So still we have a safe area operating till the going to the operating risk for mitral valve double area. Patient with MR have moves, making them higher risk. The function MR don't get empty, except that when Dr. Alferi has started being copied for the catheter-based technology, which is a mitral clip, that
Sir, we have lost your presentation somewhere. Vivek sir.
So many.
So your internet is quite, I think, weak.
And
sir, आपका internet बहुत hello.
So what I.
Yeah.
Yes,
yes.
So
the slides have
your
not,
audio will
slides are
become
not
better.
coming.
You switch off your video and the audio will become better. It will consume less bandwidth.
But the issue slides.
Slide share you can do. Your video is consuming a lot of bandwidth. So you switch off your face video, yeah, and then speak, then it may be better.
That's a good point, sir.
Now, better, yes.
Your voice is coming.
Besides the catheter-based technology, now there are, we as a surgeon still help our cardiologist and give a transcatheter route to deploy these valve in native mitral valve. Now, the technical anticoagulation. Now,
slides are not coming.
Can you see that?
No, slides are not coming.
Slides are not coming.
Slides are not coming?
Yeah.
You're not able to see the slides?
No, sir.
Repeat?
No, sir. It was coming nicely.
You have to stop share and share again, sir.
Yeah.
Now,
stop share and share again.
Not yet.
About that. Yeah, I know. Ritvik?
Yes, Anil, it's not coming.
Put your cursor to the down.
No, just
share screen will come. Stop that. Reintroduce. Switch off your video and then go to audio. Then
no. So I leave the meeting?
No, don't leave the meeting, sir. You can stop sharing.
Stop share screen. Then
share. Yeah. So stop the sharing.
Just bring your cursor down the full screen. The pop-ups will come up. Mute video, start video, share.
I have to go to full screen now. Yes.
Now your pop-ups will
yes.
come.
Sorry. Yeah, I got that.
Over this. Yeah. Now go to start scarce.
It is coming now, sir, again.
Yeah. Yeah.
No problem, sir. It's fine.
Yeah.
Go back. I'm leaving the meeting and come back. Just.
I think Doctor, give an option to Dr. Call if you can.
Is it? I don't know whether it is.
Sir, are you fixed now, Dr. Call?
Yeah, I think so. I have changed the internet connection. Let me see whether it works. Can I?
Yeah.
In that case, can I start sharing?
You can try.
I think so. I think let's not.
Can I try? Okay,
yeah, I think you can try because then you can again have Dr.
If you switch your video off, then the audio becomes good because if the bandwidth is
now,
low,
I think Dr. Call is changing internet connection. Is okay. Can you start sharing your slides, sir, Dr. Call?
Okay, let me start sharing my screen, and then this. And this is the presentation.
No, we can't see.
Is it okay now?
No, not yet, sir.
Now, Dr. Yugal Mishra's screen has come.
Sorry. So, can you see now?
Not yet, sir.
Then let Yugal start his presentation.
Yeah, something is. Yeah, it has come, sir. Yeah. No, slides are not yet come, but your screen has come, sir. No, sir.
My screen has come.
Click in the PowerPoint.
Let Ajay then go ahead with it.
Hey, Yugal, I am trying, but I am.
Click on the PowerPoint. Dr. Yugal, you are in the screen. There is a visible PowerPoint. Click on that. Yeah, click on this.
Clicking there. So, are you able to see anything?
Yeah, it has come now. Yeah,
it's come now.
Yeah.
So now go to full screen. There is an icon. This icon. Go to the right corner.
Yeah, I'm just
go
going.
To full screen.
I'm going to. Let me go to. Yeah, let me go to that. Yeah. Okay. I'm sorry.
This you go to this icon. Yeah. Even these slides you can present.
You can see now. Yes.
We can see your slides in a smaller mode. So
Move on.
you can present on this.
Yeah.
Yeah. No. Go on again.
You have disappeared again, sir.
I think now Dr. Call can try again.
Yeah, let me see if I can.
But your slides are coming, sir.
I think anything?
Yeah, it is coming as it is saying that you have started just sharing your screen.
Very slow internet.
Yeah.
Very poor. So I think I'm sorry, Rizvi.
Okay.
I will be participating.
Rizvi, tell me one thing.
No, sir. Dr. Mishra's screen has come already. There is come as mechanical heart valves, past, present, and future.
Okay.
That slide we are here.
Fine.
Okay, so let me move out, right?
Yeah, you're okay, sir. It's on the Inspiris Regalia valve slide.
Yeah, okay. So technology now, what we are seeing actually, if we see the 60 years from our, the mechanical valve, and it took 60 years to come out with a Bahl, and now, the Onyx where we can give a. Now, this is a technology which is really helping. And now, hopefully, this technology is going to come into the other valves, which is.
No, we can't
have this technology.
Switch off your video.
Then scenario, if we can get that, definitely we are.
No, we can't hear anything.
Yes.
Okay, I think ask him to stop the presentation, and Dr. Call should be given a chance completely if he can.
Yeah.
Okay.
Yes, sir.
Rizvi, then you have to allow me to share my screen.
Yeah, please. You are allowed, sir, already.
Okay. Then let me. Now, can you? Can you see it now? No.
Yeah, I am going to, unshare this one.
Dr. Yuval, you need to stop it. Then only Dr. Calls will come.
Is it okay now?
No,
sir.
Nothing.
I'm really surprised. What is the problem? Why should this happen? Maybe that the internet is not good.
Can you see the share screen icon on the bottom of your slide, sir? On the screen?
Green color.
Yeah, I know. See, I am sharing the screen.
Yeah.
This is share screen. I have pressed the share screen.
No.
And then go to the presentation. I open my presentation on full this thing. Now is it visible?
No, sir.
I think I call it a day because I don't think I...
You try pressing Alt and S button, sir, once.
Press what?
Alt and S button. There's a Alt key next to your space bar.
Alt and S.
Alt and S together.
Alt and S together. Okay, I've done that.
Still not coming, sir.
So what do we do? I think forget about
You can take questions now. It's
Slides,
35.
you can speak some.
Yeah. Anyway,
No, sir.
let's start another session.
No, this, I think there is some technical fault in your internet connection because in the beginning of the session you have shown everything.
Yeah, that's what I'm wondering. Why is it not coming now?
Just a minute, sir.
My slides.
Just a minute, sir. Abhishek, please make call sir as host. Then he'll be able to share easily, I think. You can do from your end. Abhishek?
Yes, sir.
You make Ajay call sir as host. Then he'll be able to share. From your end, you can go on to the participants, click on sir's name and...
but sir, only one host is only at the one time.
You go there in the participants, choose sir's name, right click and choose make host. Then sir will become host and he'll be able to share.
Yeah, sir, I will try, sir.
Okay, let me try. Now I have opened it and this is full screen. Visible?
No.
Now you try that Alt and S button, sir.
Alt and S, okay. Alt and S simultaneously.
It must be giving you some notification because some sound is coming from your computer, sir.
Yeah. I don't know. I'm again sharing the screen and yeah,
I
there
think
is
there is
something wrong
definitely
because
internet problem.
when we started, I shared everything and it was going on smooth. So I think there is some problem somewhere. I've even stopped my video so that your share screen is okay.
Yeah, it is coming.
It's coming now.
हाँ, तो
It's coming now.
हाँ,
Okay. Now you can see.
Yeah, you can see.
हाँ,
Yeah, it has come, sir. Yeah.
Okay.
Oh, thank God, sir. Something has come.
So,
Okay. So you have to be very quick,
okay
sir.
now?
Yeah.
Okay.
Yeah,
Okay. So now this is a slightly different topic: percutaneous cardiac interventions, surgeon's perspective. Well, I have changed my slide because Dr. Manoj repetition. Now, cardiac surgeons should learn bias. Yeah, Dr. Manish. Yeah. So it is 90s. Cardiologists were diagnosing the cases and surgeons were operating, including when I just joined CTVS, they were doing pacemakers in Bombay, of course. Vascular angiographies. I've seen Patwardhan doing good vascular angiographies. Then came PTCA, BMB, and the whole thing changed. And surgeons gave up pacemakers, BMBs, and vascular interventions, which they were doing. And then after 2000 was the total disruption. Endovascular came. And it is important to understand that TAVR is going to change everything. Like PCI changed the way we manage coronary artery disease, TAVR is going to change the way we manage valvular advances in the last decade. And surgeons may not like it, but this is the market share of TAVR. And this is what is going to happen. So you can't avoid. And with these trials coming up, partner 3 and evolute low risk, more and more percutaneous valve will be implanted. Now, we should not be like an ostrich, think that MICS is not the answer for interventional surgery. Now, what is important is heart team. And it is very, very important to have a decent heart team. See, I've worked in many hospitals where heart team did not mean anything. It is very critical cornerstone for establishing a transfer effort. I'm very lucky we have a wonderful team of cardiologists, and this is our team. And we have Dr. Chandra and Dr. Bhalla who come and rescue us from time to time. But I'm really lucky to be a hybrid transcatheter cardiac therapy program in structural heart failure, coronaries. I'll go through that. I'll skip through most of the slides. I'll come to, see, it is very important that whenever a patient comes to us for intervention, the last 50 years, we had problems. We had very funny valves, but over a period of time, things have improved. Cardiology, unfortunately, these interventional procedures, especially structural heart, telling our patients what is best for them. And you have to understand there are lots of patients for TAVR who come with concomitant mitral valve problems or coronary artery disease. And you have to be very, very careful because recently we operated a patient. I did a MICS aortic valve replacement. He was advised that we realized that he also had mitral valve problem and the regurgitation was severe and we had to replace both. So unfortunately, the role of cardiac surgeons at the moment is mainly to manage complications, provide access, not even called for closures. So surgeons need to wake up. Let me tell you, they are best suited to do non-coronary intervention. Intervention should be divided into two parts, coronary and non-coronary. And surgeons are best suited for that. We have been managing structural heart disease for the last 5 decades. Nobody understands tissue valve better than good peripheral cannulations with 20-22 size. Why can't we do interventions? Cardiologists are the gatekeepers for ischemic heart disease and surgeons are for structural heart disease. Try and understand that. So now what does the American market here? It's not board certified, it is board eligible. Cardiac surgeon can become a primary TAVR operator. You have to do 100 SAVRs in your lifetime, which almost all of us have done. And for 50 AVRs in a year, 20 TAVRs, 2 physicians, which are cardiac surgeons, and 1 physician, which is an intervention cardiologist with an experience of 300 PCIs annually. So these are the guidelines. So why are we shying away? Unfortunately, there is no training program for cardiac surgeons. I find it very stupid to row like a bunch of monkeys and telling one day we have done cardiac catheterization training and we are now trained. That is stupid. Cardiologists spend their lifetime. You give a cardiologist a catheter and a device, he can do wonders. I've seen them doing basilica procedures. I mean, they are really skilled a lot. And we got to learn from program, which I find most of the surgeons doing. It is stupid. Next, this is our experience. We have done all these procedures. TAVRs around 26, TIVAs, AAA, ASD, cooptation, PDA. How we establish, these are various normal machines which are available in the OR. And this is the most important thing. This is Zeem image intensifier, which can be used, replay facilities available and very good imaging, but it doesn't work unless you have a CAT table. This is in our OR, we can have this. And this is the whole setup. You can do a lot of procedures with these things. You need not have a hybrid OR for all that. MICS, I consider only as a non-midline. That is, if you have ventilator, if you have a cross clamp, it's not an MICS. It's not a minimally invasive surgery. It is a non-midline cardiac surgery. Now, we have changed our procedures. We don't do blind punctures. We have modified this. We do it under echo guidance. Now, I'll just show you this video. You will understand this is how you can see this. This is another one where you can see that we are puncturing the artery under ultrasound guidance. All our cath procedures. Now, this is where things have changed. You know, normally in India, we don't get patients with these problems. Now, we had a patient who's this thing, and he was turned down by one of the MICS centers in Delhi, where they said that cannula was not going. This is, we do all under fluoroscopy guidance, our cannulations. And believe me, this went very well. Now you can see this going ahead, and just see this very carefully. And this is, the cannula is going up. You can see that. And we crossed the aortic obstruction very fast. I'm sorry, because there's no time. Now we do a lot of heart failure procedures, including the first one I'll show you. This is CRTD placement. You can see this going on. I'll just cut short this video, and I'll come to the next this thing, and that is this being in place. Let's see who's this. Was the CRTD, nothing, no big deal. Now this is a very interesting. We had an LVAD patient where we had to explant. Now this was all planned by us, because we had to sort of block LVAD. And this is, I took ADO to this closure device. See, we were going to the inlet of this, and we blocked both the orifices. And later on, this is a final. This is first ADO device which was here. This patient is doing absolutely fine. We didn't do surgery. We decommissioned this interventionally, all done by the heart team. I am really lucky to have wonderful. Now this is one of the cases where occlusion was there, and you can see this procedure going on. I'll just quickly in this. This is supera stent, because it was bad, so we had to put a supera stent. This is the reconstruction. One by cardiac surgeon, one by the vascular team. Again, coming multiple times by ischemic leg. Now it is this I could not do in our routine theater, so we had to shift to our we use it as a hybrid OR. So you can see this. You know what is interesting in this picture is, now this will be the interesting part of it. What we realized that I did an aortogram. And when I did an aortogram, I realized it's very interesting. On the, just follow the screen very carefully. Just see this, and you will realize. See, this balloon is coming down, but it is getting. See, there was an obstruction at that place, and what we did was we put a covered stent inside and did embolectomy on both sides. This patient is doing very, very well. This is another case. See, well, this was a ruptured aneurysm, came in the middle of the night, and we did a stenting for this, and patient is absent, which I can say in the interest of, this was a patient who had come with, a bad dissecting aneurysm, and he was fixed. The patient had come totally paraplegic with both cold clammy extremities. But I want to close my presentation because as such we are very late. So Rizvi, in a nutshell, surgeons should change. That is my message, and start doing other procedures. Hello.
Yeah, thank you, sir.
Okay, I stopped
got a little bit delay because of the technical.
Yeah, that's why I thought there's no point in going into details of this. But then this is what I want to do in procedures.
Yeah.
Sir, I'm requesting to Dr. Kaul, sir. Sir, please make me again the host.
Okay, how do I do that?
Yeah, that's.
Sir, you can see in the list of panelists. Next,
Abhishek, you can go and claim back host. You can become yourself, sir. It does not have to do anything. You go there and you just try claim re-host status.
1 minute, sir.
Okay, while we do all these technical things, so there's a question to first of all the panelists are, I think, should be now on the everybody there. Yeah. So first of all, a question to Dr. Bana, sir.
Yeah, I'm here.
Dr. Bana is there. Yeah. Sir, yeah. For a right thoracotomy AVR, because if once you kill it, you can go on bypass and then deflate the lung.
Yeah, it is. You can do that way, but to start with, it is always better to go for a single lung. It is comfortable. It is very comfortable to your lung is deflated. It is very comfortable. You can take it personally. But you do two, three procedures, and if you see on X-ray that lung is not hyperinflated, don't go for a double lung, single lung.
Second question to you, sir. So what type of plates you mentioned that you use for?
These are dynamic plates available by orthopedic colleagues. These are you can see about 3 centimeters in size. And I don't remember the name of the plate exactly, but we are orthopedic.
Okay. So I'll take it from Saurabh later.
Yeah, Saurabh.
Okay. And you said the
approximately, including screws.
Okay.
I just want to add one more point regarding. You wanted to ask something to me or any other thing?
No, sir. Yeah. So, and in your practice, when you do right, Mark Ruel has categorically said that no CT scan is required. But you emphasize on the point that be safe, get a CT scan done. So, I think practically speaking, we should always have a CT scan before putting a right.
Absolutely right. Absolutely right. Mark Ruel maybe has done lot many procedures, but if you see experience across the globe, people want that you need to have a CT scan and always follow that CT scan. Don't do that, otherwise you'll stuck. Because it's very, very difficult to see, right? If you remember, if there was a case going on in Mumbai, live case by Vivek and not assessed properly, the aorta was almost central, and he could not assess the right coronary cuts. He could not take his sutures at the right coronary cuts. He need to convert it.
I saw that, sir. Live video. Yeah. Okay, thank you, sir.
I just want to add few comments to Dr. Kaul and Dr. Yugal Mishra about the TAVI and about transcatheter procedures. So surgeons should not be very scared. I was attending a aortic forum from Germany, and Germany is a leader in transcatheter therapies, especially in TAVIs. And that talk was given by a cardiologist. It is on website. Who has done 3,000 hours? Who has done 3,000 hours? He was commenting, and he shows us the slides that after 5 years, what we are seeing is there's a diversion. Surgical AVR is going up and tower is going down in the performance. So he said that probably low risk trial, they need to be reassessed. He was very, very categorical. They need to be reassessed because this procedure probably is not for low risk, and that to be not for low risk, low age. Means 65-year-old man with a low risk should not go for towers. That was a presentation by a cardiologist who has done 3,000 procedures. So 5 years, that there's a remarkable difference in the long-term outcome if you compare to Tower and Tower in the graphs for diversifying in the performance of valve, in reappearance of aortic regurgitation, in sudden death, and so many things. I will tell you, very important. Surgeons should be very, very good for, but listen to it, that there is a trial which is going on. First implant of aortic valve was done on 19th of September 2019 at Chicago. This valve is known as a trio valve. This valve is a polymer valve. They have selected us at India as a center through Mount Sinai, probably in March 2021. That valve is one valve, all life, done. No anticoagulation is required, only anticoagulation for 3 months. That's it. That's the polymer valve, name is trio valve. First implant 19th September 2019. And after that, there are 57 implants have been done. In India, company want to come to India. They have tied up through other centers in India. We'll partner to it. And if we do that, then at the age of 35, you put trio valve. Your job is done.
Ajeet,
you decalcify the valve, put it properly.
Ajeet,
and the third thing,
Ajeet, third
thing. I just want to tell one more. I just want to tell you the transcatheter double valve replacement of Asia in native valve, not in valve, in native valve in lockdown about 1.5 months back. We do not want to publish it. We do not want to disclose it because we are following the patient. That was patient of a Hodgkin's lymphoma. That patient aortic annulus was very difficult to do. Surgery was impossible. So what we planned is we made a hybrid theater in the operation in the cath lab, and I discussed with Vinay Bapar if something goes wrong, what we need to do. So he guided me that we need to put a felt, open the chest, and take 3 sutures. And believe me, Doctor, one cardiologist from US was throughout on the line with us, guiding us how to do this procedure, and we did it remarkably well. Did self-exposition. So surgeon, first of all, should need not to be scared. We are still in the game, number 1. Number 2, what Dr. Kaul said, definitely do it. Go to cath lab, learn. Start doing angiogram yourself. Number 3, start treating chest pain. Most important. Why not patient aaj janega?
Okay, sir. Thank you. We will leave it on that.
I'm happy Ajeet is excited.
Okay. I think we have a lot of panelists on the forum. They may be very, very happy with this.
Ajeet, these forums,
I'm telling the facts.
Yeah.
What TAVI facts? I am telling you the TAVI facts. It is available on website, sir. TAVI facts. It is available on website.
Treating your, the chest pain.
Okay.
Please do your job.
No, do everything. Do everything.
Confidence.
Yeah. So thank you, sir. Thank you, Dr. Bana.
Respectable. So let them treat, the chest pain. You do your job. I enjoy surgery, though I do catheter-based technology. I have started, but I still enjoy class 40 years. I'm doing the same. I am go on doing that. Though additionally we have to use whatever.
I was joking, but chest pain, don't take it away.
So okay, thank you. So there's a question to Professor Bahl, sir. So as you said on your presentation about balloon mitral valvotomy, it seems that all the cases of mitral stenosis, severe mitral stenosis, can be taken picture not having severe MR. What is the other indication where you will refer the case for a surgical mitral valve replacement on severe MS? You don't consider that patient for BMV because your slides showed that practically all valves can be, they can be subjected to mitral valvotomy.
Yeah, good question. The results won't be the same. As I told you, there are classical indications. Suppose there is a large LA clot, not in the appendage, but in the body. That will be a contraindications. Suppose there is a echo, don't look at the Wilkinson score. Look at the valves, look at the commissures, because whatever is the whatever has to give way by the balloon, that will give way. So if you find spotty calcification in the leaflets, you'll bound to produce more MR. Is young, she is a female, she to undergo pregnancy. It is good to have a BMV and accept that 1.4 post BMV area is acceptable. She completes the pregnancy, then goes to the surgeon. Cardiology for many years. So there are indications when after post CMV I have done BMV. There are times when I have produced complication and people have saved me. So this is a team approach. So all the valves can be taken up. Are you going to?
Yeah. So the next question is to Professor Devagourou sir. Have you started mitral valve repair in the rheumatics since how many years? And what is the longest term follow-up from All Institute of Medical Sciences? What is the recurrence rate of severe MS, which calcification in rheumatic mitral
I
repair?
put 3 articles, 3 of them published mostly by Dr. Sampath sir. And the actual survival is coming to 85% at the end of 15 years. So if you are done open mitral commissurotomy, the long-term results are good. Only in mixed lesions we have a problem. In mixed lesions or in MR, most often when the recurrence is there, we have a stenotic valve. If you do MR, most often we get a stenotic valve with mixed lesions, not with severe MR. And those annuloplasty. So hopefully the results will be longer now. And we don't accept more than mild MR. So we usually go back, fix it or replace it. So unless the patient is a young lady where we accept some unsatisfactory results.
Yeah. So, Professor Devagourou, do you have any experience with repairing both the aortic as well as the mitral valve child, where the aortic valve is a little bit thick, booming, and
mostly usually aortic valve repair and mitral repair I attempt in non-rheumatic patients. Rheumatic patients I have not attempted. Dr. Sampath has done double valve repair, and some of them come back early because initially they look all right in the aortic valve, and then initially they look all right, but they come back with a regurgitation lesion. Rheumatic valve to repair is not easy. Either you have to do the free leaflet advancement. We have a strip of pericardium and the free edge of all the 3 leaflets. Even if one leaflet is sagging, usually I think it is better to put a Ozaki type repair than repair the aortic valve in a rheumatic population.
Thank you. So there's another question to Dr. Samir Kubba. Dr. Kubba is here, or you left? He's left probably. Dr. Kubba is left. Okay, no problem. So Dr. Sanjay Theodore is here. Dr. Sanjay Theodore?
No, he's there.
I think he's driving. Yeah, but he's there.
Tell me.
Yeah, Dr. Sanjay. Yeah.
Yeah. Tell me.
So there is a question to you. If severe aortic stenosis with mean gradient of about 25 millimeter of mercury across the aortic valve, and the valve area is 0.9, and with ejection fraction of 10 to 12%. So is there any severely rheumatic valve? Do you want to subject this patient to any test before subjecting only severe AS, no aortic rigors?
So there's simply just one thing to take into consideration. Either way, 30-year-old, we are going to operate. But the thing is, prognostication can be done with strength contractility. Contractility can be calculated. They've got some formulas to predict the contractility after surgery. So if the contractility is going to be good prognosis, other action, you should give it a try because many of them do improve. There will be a certain portion which will not improve, but that comes into consideration only when the patient is 70 years old. 30 years old, I think you should.
The other question regarding this is for our 2 senior cardiologists, Dr. Manoj Kumar sir and Professor Bahl, that if after doing a aortic valve replacement in a patient with 10 to 15% ejection fraction, is there any need of a machine?
Yes.
This is not to Sanjay, this is to a cardiologist.
Yeah. Okay.
Dr. Manoj Kumar sir or Dr. Bahl respond.
The question of primary ICD even in patients with DCM is questionable. Yes, theoretically you should give because any patient who have a low ejection fraction can have a primary VT which can be saved. But whether to give in all patients who have a low ejection fraction even is debatable even in patient with dilated cardiomyopathy. So usually we do not follow that unless patient has ischemic cardiomyopathy with ejection fraction of less than 30. posterior with the low ejection fraction as a primary to all.
Okay, thank you. So there is one question which is very pertinent to Professor
You
Santanu
have to
Pandey.
put your on unmute. You are muted. That's why the sound is not coming.
So okay, we'll come back to Dr.
I agree with Dr. Professor Bahl that the role of AICD in non-ischemic cardiomyopathy is questionable, and probably that is with dilated cardiomyopathy of non-ischemic origin, LV dysfunction. It doesn't help too much. And in this patient, in severe heart failure, less than 20% ejection fraction, AICD can prevent the
Thank you, sir.
cardiac death.
We'll come back to you again. To Professor Santanu Pandey, sir, and Dr. Yugal Mishra, sir, together. Because I have just attended a webinar with Professor Dr. Bhagwan Karela and Dr. Mishra about 2 or 3 days back on tricuspid valve repair, which is totally in contrast to what you have just spoken, specifically that if the tricuspid valve annulus is normal, if the severe tricuspid rigors and right ventricular systolic pressure is more than 60 millimeter mercury, you would rather leave that valve alone. Is that right?
We will leave that valve alone, and reason for that is the data which is coming to us through STS database. The average age in Western world where tricuspid valve repair is done is 65 years. While we in our cohort, we have seen that our average age is around 29 years. So possibly this PAH, which the person has developed, is for not more than 5 or maybe 6 years, because he would have developed gradually this PAH time. We should see other parameters of right ventricular dysfunction. So if right ventricular dysfunction has already set in, then the game changes. You have to address the tricuspid regurgitation. The other way of seeing it as right ventricular remodeling happening is seeing the right ventricular eccentricity index. Yes, that the right ventricular remodeling is in advanced stage. And such patients with severe PH, even with a normal tricuspid annulus, should get tricuspid valve repair. But if these things are absent, like RV pressure, RV function is normal, right ventricular eccentricity index is less, they may benefit with the original idea. Original idea was you fix the left-sided valve, the right-side valve will become okay. So that needs to be, I'm not saying that it is, it needs to be done always, but what I'm scared of is we have seen the annulus is very normal. At that point of time, trying to repair with, not with a ring, may actually reduce the size and create a tricuspid stenosis. And that would be much more harmful to the patient. So if valve where the tricuspid annulus is not dilated, I would be much more comfortable using a ring rather than a band or indigenous way of repairing the valve.
So Santanu, I do agree partially with you, but I do disagree. Now, there are two things. Now, if you are getting a patient who has got a normal annular size and has got a severe tricuspid regurgitation, it might be, if it's a combined left-sided and right-sided valve, maybe in rheumatic, there might be some commissural fusion, which leads session where I have done commissurotomies to the tricuspid valve, put in a ring, and remodel the annulus, and I got very good results. So the number one, that there is some organic element which we are with normal annular dimension, and number two is high PA pressure, maybe because of left-sided valve, which is corrected, and that might be leading to, and which is transient one. But the second thing is that one must try to get that is there any organic element in this particular valve when we are dealing with our patient situation, which is in India, which are thanks.
Very true, sir.
And another thing is that which another thing which I think should also impress upon, even if the patient who has got dilated annulus, the potential candidate who subsequently may develop TR, so it's better to fix that.
It must be done. It must be done if tricuspid annulus is dilated for sure. I would say if tricuspid annulus is dilated and eccentricity index is more than 2, we should use a ring rather than bands or modified Devagourou stenosis. Yes, we also had those things, sir. And but that changes the classification of involvement of primary of tricuspid valve as primary, and primary tricuspid regurgitation needs to be addressed whatever the size is. And I would absolutely agree if the size is normal and you have to put the machine out, fix it with the ring.
So there's another question.
So, Santanu and Devagourou, I would like to
yes, sir.
Just I want to ask both Dr. Devagourou and Dr. Santanu Pandey, who are already being operated and the mitral valve was done, they are on the follow-up. Are you getting patients with liver failure who have not been fixed with a tricuspid regurgitation, severe failure, edema? Are you getting a lot of patients now?
Not exactly, sir, but sometimes we do get.
Devagourou,
sir, most often we address the tricuspid valve. If there is annular dilatation, 100% we'll do. If the pH is high, and as you said, if the TR is eccentric, or if there is a gradient across the valve, or the valve is thick, we'll definitely look at it.
if there is an eccentric TR, that gives some suspicion that there is a commissural fusion on either the anteroseptal or a posteroseptal region. Some commissural fusion is there. That is one. And we also, for some time, as such, for tricuspid alone, we have not gone back and repaired in a redo situation.
Dr. Yugal, there are a group of patients who undergo PTMC or balloon mitral valvotomy. At that time, many of these patients have a severe TR, and which is thought to be due to pH, as was being discussed. Many of these patients also have an organic element, and these are the patients who like tricuspid percutaneous balloon valvotomy also. It is contraindicated in presence of severe TR, but we have seen that TS can coexist with severe TR, and opening the valve itself gives some relief. So there are a group of people to treat patients.
Very true.
I agree, sir. I have done maybe around 20 cases where I did a commissurotomy. They had a severe regurgitation and had a very good result. Sometimes we do even a Devega in tricuspid situation. Not a Devega, sorry, Alferi even in
I would like to also reiterate at this point, as Deva has said, we are also not seeing many of such patients, but off and on they come and get admitted with cardiology. What I would like to put a point at this juncture is 3-4 patients to show these symptoms. When usually these symptoms come, the right ventricular dysfunction has set in so much that it becomes a contraindication for actually doing a tricuspid surgery. So the whole idea of doing a tricuspid is that stage. And I would again say that if the right ventricle, right atrial volume is high, if the IVC is dilated, if the hepatic vein is appearing dilated, possibly even if this patient is controlled on medication at this point, possibly he will have a bad outcome in future. So when we are assessing TR, it is in a low pressure area. So right ventricular dysfunction needs to be seen, remodeling needs to be taken care of, and the secondary effects, those will start showing reversal if you do a very good diuretic therapy care of when we are assessing tricuspid valve. So it should be seen more seriously at the point before you take the patient for operation. Whenever this TR is more than mild, I would say, because most of the time moderate TR, which is assessed preoperatively, actually turns out to be a severe TR data till now. We have only collated 2 years of follow-up.
Thank you.
But
thank you so much. So there is a question to Professor Praveen Verma, sir. So there is a specific variant of left ventricular LVOT obstruction. To the mid cavity, there is a big gradient. With what is your approach for the mid cavity with a huge bulging of the septum on the mid cavity? It's not on the LVOT, there is a great gradient on the mid cavity.
So mid cavity obstruction.
Sorry. Second question also. How do you manage the ventricular septal defect? And I think we have a HOC, and I think it's very dangerous.
Yeah. So first of all, is a mid-ventricular obstruction. It can either coexist with the classical hypertrophic obstructive cardiomyopathy. One of those surgical procedures where it is very difficult to access through aortic valve. So we have so far not ventured into doing it. We have, I think, we have a follow-up of more than 1,000 hypertrophic cardiomyopathy patients in our center, not obstructive, but overall non-obstructive. And we have 4 or 5 patients with purely mid-ventricular obstruction in doing that. Arthur Schaff is one of those guys, and only those people, they do it. So they actually use a trans-aortic approach and then go trans-apically. So it's a combined approach. And few surgeons have tried to do it through the level because our program is still very young.
Yeah.
And
so there is one question to you, that there is a question from one surgeon who asks that, have you ever detached the mitral valve anterior mitral leaflet from its attachment to go to the septum?
No. So this is an approach described. I think this was recently published in 2019 Annals of Thoracic Surgery, where they use purely a left atrial approach. They open the left atrium, anterior mitral leaflet, and do a septal mimectomy. I have actually written a comment about that in Annals, which is published. It gives a good exposure, but the main problem is that once you touch the left atrium, in these patients post-operatively, you know that the patients with the diastolic dysfunction, if they go into atrial fibrillation, it can be a little dangerous. So it is not a very standard approach, but there is an article in Annals of Thoracic. Standard approach is still transaortic septal mimectomy.
Thank you. So there's a huge number of cases, 1,000 cases of
HCM.
hypertrophic obstruction.
Not obstructive.
Yeah. So HCM is also a huge number of cases, sir. So now coming
VSD?
last question to you, sir.
No, you wanted to comment me on about the VSD? Yeah. So when you have a VSD, how do you diagnose the VSD on table? Is that you allow the heart to fill. Once you do the septal mimectomy, you ask your perfusionists to clamp the left ventricle. Then there is a chance that you have created a VSD. Did you understand that? And of course, it is picked up by transesophageal echo. So in the transesophageal echo, once you see it, you will find that after only a LVOT. So you need to wait till that time. So if you see that, don't try to repair this valve through the aorta. you go on bicaval cannulation and open the right atrium, and then identification is a problem. So what we use is that we inject this fluorescent dye into the left ventricle and see where it is staining, and then put a big patch and use pericardium. We don't use autologous pericardium, non-tanned autologous pericardium, and use continuous sutures, and then anchor it in multiple places with the blood jet. So put a large autologous pericardium. So we actually called our pediatric.
You said that which is the site of VSD occurring, which is just below the weakest.
No. You don't cut just below the aortic valve, because you have to cut 1 centimeter below the aortic valve. If you cut just below the aortic valve, it will fall down and you can have severe AR. So the area where you usually get the VSD is mid-ventricular septum. That is the area where it is not very visible. So if your knife goes in, it will just, and another danger is to take out the muscle bits. So if you pull too much, you can avulse it. So we had 2 cases. So
in adult subaortic region, just below that. So how you can, in that situation, how you do that?
Subaortic ring is like a congenital abnormality. So in that, I don't think, because it's a very thick fibrous tissue, you can excise it and it will not cause problem. But this will cause problem if you are too aggressive.
Okay, thank you, sir. Thank you for your inputs. And my next question, there is a question to Dr. Amaresh Rao on the Sree Chitra heart valve. So what was the last modification that the Chitra heart valve has been done? So it is called as MRI specific question to you, Dr. Amaresh. Be very fast on the answer. Amaresh, you're there? I think Amaresh has gone to sleep. Amaresh, you're there?
Can I answer that question, Ritik?
Yeah.
So Chitra valve was always MRI compatible. So the latest this is that they are going to I think they have installed a diamond coating or that disc. So it is supposed to reduce the.
Okay. So Amaresh, the question was to you, Dr. Praveen sir already answered. The last thing to you is that have we started using Chitra valve in other countries?
Yeah, definitely. It's in use in a few developing countries: South Africa, Kenya, Malaysia, Bangladesh. It's been used in quite a few countries, but I don't think it finds its way in European countries or US. I guess
Eastern Europe, it's being widely used.
Yeah. So the next question is to Dr. Adil Sadiq, not Adil Rizvi. Adil, you are still there?
Absolutely, Rizvi, I'm here.
Yeah. So first of all, number one question to you: what is the highest number of pathology of mitral valve repair that has been done through MIC?
It's degenerative, as said out there by Dr. Devagourou and other people as well. I try to shy away from rheumatic pathology for mitral valve repairs. So most of them are the degenerative kinds.
And you always go through the third space, or you sometimes also go
sometimes
down
I go down to the fourth space as well. And one of the deciding factors for that was the preoperative X-ray, which I demonstrated in the presentation, and that's which way to go.
There's an important question about pain management. There's a literature suggests that sometimes the pain in the thoracotomy on the right side can be more than the sternotomy approach. So what is your take on that? What special precautions?
I think it starts up with the way, initially when I started doing this, I used a rib retractor for many years and a rib spreader to actually gain access. So it was direct vision associated factor for the ribs. I just use a soft tissue spreader. And I think that is the one thing that has decreased the post-operative pain by almost 80%. I also give an intercostal block.
Have you said that you don't use retractor anymore?
Most of the time just use a soft tissue retractor. And I think nowadays we've got a lot of good indigenous soft tissue retractors as well. We don't have to pay $25,000 for the imported ones, and you can do the entire thing through that. And of course, actor, you need to use the endoscope for the guidance. Yes.
Do you always use a video light camera?
I just want to add to Adil's remark. What we have done a study, have divided 50-50 patients into the two groups. Eventually, we found that initial 2 weeks, the pain from thoracotomy is much more. But after 2 weeks, this pain appears and the pain from the sternotomy also. And there is a pain, but as Adil said, if you don't retract, one thing, and second thing, use some kind of, nerve block, that can help. But initially 2 weeks were tied up after.
Okay. Thank you, sir. Thanks for this. Coming back to Adil again, the last question to you. So, do you think any difference in post-operative number of days in the hospital when you use this MICS approach with mitral repair?
I think that is the biggest advantage I feel is the post-operative recovery. Patients are usually off the ventilator the same evening, walking the second day, out of hospital by the third day, sometimes fourth post-operative day, vis-a-vis if I would suppose 6th post-operative day for a sternotomy. So there is a big difference, absolutely. I think amongst all the advantages, the one that I really go on for is the faster recovery, and the length of stay in the hospital is much shorter.
To that, there's a very important question now. That now robotic surgery has come up with a very big thing in our country. Dr. Mishra is here, and your city also have started doing it. So my question to you is that, is there any specific advantage? The length of the incision remains, I think, almost same. So it's a question to both you and Dr. Mishra. Thank you.
So first thing, I just start up. I started doing robotic mitral valves as early as 2009 in Emory, and I think there is a definite advantage with the talk about pain, post-operative recovery time. I think it's shorter with the robot. There is no doubt about it. But the robot does have a learning curve. It does have a cost factor to it. If you stand off between a sternotomy mitral versus a minimal access mitral endoscopic, the price difference, we've been able to bring it down to, like, say, 30,000 or 40,000 rupees. But unfortunately, I could not say that if I were to use a robot, because as of now, the current systems that are there, and I'm sure Dr. Yugal Mishra will also add on to that, the consumables do add on to a significant cost.
So, Adil, I do agree, but the robotic technology, the biggest advantage, if you leave cost behind, when you go with the 2D vision and with your long instrument, your maneuverability is not as good as with the robotic instruments. You 360, you can move around, go all the way to cell. So this is a study which is being done actually when we started in 2002 in this country, that they have the robot where we have a fourth arm which has got retractors, we have got a sleek instrument. Most important thing is to tackle to the subvalvular apparatus, going all the way to putting the artificial card in, taking care of, if you want to do a cardinal transfer, do whatever you want. Safety instrument. I don't know about the 3D vision. I don't know whether Adil is using 3D vision, which maybe inspires, I don't know how it is that, but so tired. When you are using a two-dimensional vision, and if your operating time is prolonged, you may get tired. You're all the time you're looking toward the monitor, and Adil can tired. You are very intuitive, and three-dimensional depth perception. Those things are, except that you don't have a tactile feedback, which you have with the 2D.
Definitely come and see Dr. Yugal relaxing in robot with mitral surgeries very soon. So now next question to Dr. Adil Rizvi, just a quick response from your side. So you said that Onyx valve we can safely use, suppose normal ventricular function, size, aortic valve stenosis, no other risk factors, no other previous history of thromboembolism. So can we put a Onyx valve and leave him with just INR of 1.5 to 2?
Yes, I want to add this, that
if it is so, because then in that case we don't have to discuss about all this.
This is true. There are three things. Those are the caveats. Number one, yes, of course, there is only a single randomized controlled trial on which the recommendation is 2B. All right, so it may be done. Number one, after 3 months of standard anticoagulation. The second point is, whenever we are talking of 1 point in addition to aspirin, so we are giving one antiplatelet plus anticoagulation. Third point, to replicate that study, all the participants in those studies had this home monitoring INR machine. So if we are trying to maintain 1.5 to 2 INR on to ecosprin, so these are the factors which will limit this exploration of this particular study onto our patient group.
Okay, so you want to say that we can use it, but with all the precautions in place and extreme monitoring, if possible, let's not put a Onyx valve in a very remote village of Muzaffarnagar and leave him behind.
No, then normal anticoagulation level could be used a little higher.
Yeah. Okay. Thank you, Adil, for this. Next question is to Dr. Manoj Kumar sir.
Sir, you are muted.
Rizvi, you are mute.
Sorry.
Rizvi, you are mute, please.
Sorry, sir.
Unmute your.
Sir, दो वैसे बैठे हुए सर, थोड़ा सा little bit jittery now. So there's a question to which is very practical, I think. So there's a young lady, 34, first trimester pregnancy. So would you always ask her to go for a cesarean section and put her on collection for the first 3 months?
I shown in the slides that cesarean section is just on the some indication delivery.
Because why I'm saying this, sir, because our gynecologists always say that हम लोग कभी इनको normal delivery कर नहीं सकते.
There is some problem in their thinking, because you know that second stage of labor can be cut shortened by the use of labor, can damage the fetus. So I think that whatever guidelines says that the vaginal delivery is, there are some certain indications. As I told you that if aortic stenosis, there is dilated aorta and it is more than 5, then cesarean sections can be preferred. Second important thing, what was the second part of your question? whether they should be indicated in the first trimester, but the proper monitoring is required. PTT level should be more than 2 times of the control, and there should be a 10A activity level should be monitored in case of low molecular weight heparin, and it should be done at least indications, whatever guidelines suggest that if you are using low molecular weight heparin in the first trimester, you should have a follow-up with that. In our country, it is available in Delhi, and 10A activity can be assessed.
So there is a question to all the panelists. In your lifetime career of cardiac surgery or cardiology, have you ever seen a lady who died or whose fetus has died because of this? Is to everyone.
No, Dr. Rizvi, whatever we are following here, most of the K-injected heparin or low molecular weight heparin, nobody is continuing. Definitely embryopathy with this vitamin K antagonist and all other manifestations like cleft palate is very common with this warfarin, and especially in the weeks period, nobody used vitamin K antagonist. Most of us switch over to the heparin or low molecular weight.
So there is a question to Dr. Ajay Kaul sir. This is from few of the young cardiac surgeon training. Dr. Ajay Kaul sir. Dr. Ajay Kaul. Yeah. So this is a question to you from few young trainees. They say that as a cardiac surgeon, you said that you that MIC is only non-sternotomy approach. And their question to you, shall we not start learning this technique, or what is your take on this? So,
see, I'm not against MICS. What my problem is, don't think that you can ultimately all valves will be percutaneous one day. Valve is coming or some silicone valve is coming. Even that will be percutaneous. So let's understand one thing. You have to change. You have to understand and get into the cath lab. That is the future. So don't think that you're going to escape that. Because Ajeet just now said about this.
Second thing what they are doing is that company is coming up with a TAVI valve, polymer TAVI valve.
Yeah. There you are. There you are.
So
you know, somebody in one of these meetings was very happy with tendine valve. They thought it was surgeons coming into picture, and gradually they are gone. So you got to learn percutaneous techniques. It's very, very important.
Talking, just to drop a point, we were talking about science behind what Dr. Bana said. There is a wonderful article from Ajeet Yoganathan, and it's a review article. If I would recommend that all of you should read that. And if you read that, you will never allow a TAVI to be done to your patient. I'm very sure. He has given 101 ways why this valve is going to fail. And that is what exactly Dr. Bana, physiologist in Germany, and it is echoing in my head still. That article is still echoing in my head why this valve will fail. And it's a wonderful article. I have that article.
Shantanu, you have to understand one thing. Our surgery has evolved over last 50 years. Give cardiologists some time.
Remember one thing. Remember one thing. Where is the money? The science will go the way where the money. And money is in transcatheter procedure, not in cutting the chest.
There too, Ajeet, Bana and myself.
Okay.
Absolutely. Industry is for percutaneous procedures. See, when we were students, it was bileaf.
What I mentioned we are doing in cardiac. We are not doing it. And they are doing so
rapid
many.
deployment valve have a better future than
We'll
leave it to that.
Our time will go. We will sail through. We'll be older.
So,
the younger surgeons, it will be.
So
which Dr. Kaul is saying for the younger people who are in their 30 or 35.
There is no problem. We still are busy with our surgical practice, and there are plenty of cases. But gradually things are
a question to Dr. Manish Agarwal. What is the longest term follow-up for a TAVR valve? Suppose if I want to put a valve in valve at the age of 55 or 60 years, what is the longest life I can expect from a TAVR valve? Dr. Manish to respond.
He is not. I can give you the answer if he's there. Manish is there.
Yeah, the longest data in the low risk trial is of 5 years. In the low risk group is of the Notion trial for 5 years, while in the intermediate risk group we have 5 years data published in 2017. So they have a 7 or 8 years follow-up. So the longest follow-up of the valves is of 8 years.
Dr. Rizvi, you will be doing a disservice if you put a TAVI in a 50 years old person. You must remember the age of all these trials.
I'm just coming to that, sir. So my next question to Dr. Bana. So what is the youngest patient that, because your center is the #1 center in TAVR in the country, what is the youngest patient that you
28.
Dr. Bana? So now
but the reason is very solid.
You can do whatever you want to do.
Let me tell you.
There must be some indications.
Listen to scenario. Please listen to me. The female with the 3 abortions, with tight aortic stenosis in 3rd trimester, they are on table, and she started decompensating. We had to put a valve.
So the answer is not that is a routine.
It is written in literature.
That's an exceptional patient. You have to do whatever you have to do, but that won't say qualify that
No,
you won't recommend a tower.
The youngest patient you have put in the tower valve.
But you have to look at the spirit of the question.
Okay. Thank you. That's a
I think we must realize we are discussing so much about TAVIs. In our country, the valve patients, they are not for transcutaneous therapies. So your lifetime, you will have enough. Like at AIMS, the waiting list for the valve surgery is 220 since I left. Every month it increases except for COVID. So there are enough patients of rheumatic heart disease who require valve surgery. I'll request Dr. Ajay Kaul and you, please keep on the leadership to whom the younger people look for. Already we are finding the CTVS seats are going vacant. If you start telling this, then I think the younger people will be very discontinuous. I think you have done an excellent job, and there will be enough work.
Yes,
I think in India.
Yes, sir, you are mistaken. Dr. Kaul has never said that CTVS is not good. He said the surgeon need to change the mindset that they need to understand surgery, they need to understand knife. It means that surgeon need to have.
I won't go into discussion.
By which he can go to
a lot of discussion at 10 o'clock. I don't think I'll go with the discussion. I will agree. Whatever.
No, sir, we are here, and I will say, I will just request Dr. Bana that they are going for the hybrid of cardiologist and cardiothoracic surgery. There is no need of any competition.
Absolutely right.
It is a complement.
Dr.
Association.
I have a question for you.
Required.
We had some bad experience with the epic valve. That was the first question. Second question is for Dr. Praveen. Any experience of the Chitra valve in the pulmonary position? Two questions. One for you, one for Dr.
First of all, I would like to say, sir, we have an extremely bad experience with epic valve as well.
Yes.
So I have placed the epic valve from 2013 till about mid of 2015, and since that I have not put a single epic valve in aortic position at least. For mitral position, it's a very good valve. I think for mitral we don't have any problem, but for aortic valve we have got a lot of not put any epic valve since the mid of 2015.
Okay.
Yeah, Dr. Praveen to answer.
We don't use Chitra valve in pulmonary position. So far we have not used. We use only tissue valves.
And can I add one thing? I have used Chitra valve in pulmonary position, and I love this valve. It works wonders. I don't know. I'm a great fan. If I have to put a valve in for tetralogy redo, adult tetralogy redo, Chitra valve, and I like it.
People advocate tilting this in the pulmonary position. That's why I asked. If you're choosing a mechanical valve, people advise tilting this.
It's a good valve.
That's why I asked.
Thank you. I would prefer Chitra valve over all other valves. It's a fantastic valve. I don't know why we stopped using it.
Time all for the day. We are really thannkful to all the panelists about India Limited, and so I would like to ask both Dr. Mishra sir and Professor Bina Bahl sir to have the concluding remark.
I think we must thank you for arranging this excellent program. It was a 4-5 hours.
Suspected COVID ward hai. मैं अभी पता करता हूँ.
और lastly, Mr. Sir, to lastly.
Actually, Max Healthcare, thanks Rizvi, Dr. Bahl, everybody, Adil. I think this kind of programs, I think this was really, we have learned a lot from each other, and there is, and I do agree with Ajay Kaul's remark, and what I want to say, skill. Wire skill, that's mandatory, and this is now, and particularly the people who have access. I had a department where I also heading the cardiologist, and in a day, Dr. Bahl, we did a 2 hours. One, I was the first primary operator, and second, the cardiologist was the primary operator. So those kind of situation has a fantastic team. Ajeet has a fantastic team. I do take help of his cardiologist who comes and guide us. Now, issue is that here, nothing like a cardiac surgeon and cardiologist, vascular expert, and the patient is a primary things. Now, the benefit has to go to patients, whether that is through the cardiologist, complement each other. And Dr. Bahl knows, nobody knows better than him, that he was in a center, he was heading a department, and then the cardiologists and cardiac surgeons, they were going hand in hand, and we are in a stage where instead of going, I remember, Rizvi, 20 years back, and Dr. Bahl can remember, there used to be cat fight, between the surgeries, best, and there is saying no angioplasty. Those days has gone. Now we also see that in a circumflex artery, whether blood. So now this is basically primarily the disease which is responsible for early restenosis or blockage. Technology is moving. We are there to are hosting this fantastic meeting. Thanks to all the speakers. And I think, Rizvi, you have got a leadership quality. You must move on, and you must go to the AICTS there. You have to.
I don't want that, but it is not for that. But
right.
Definitely.
I think Dr. Yugal, we can add Rizvi to MICS or SMICTS.
No, he is course. Absolutely. Done. The next meeting and Rizvi.
Thank you, sir. Thank you. Okay, thank you very much, everyone. Have a great night.
Thank you.
Good night. So much.
Good night. Thank you.
Thank you, Ritik. We had a great time. Thank you very much.
Thank you, Ritik.
Right.